In the last few decades, there have been major advances in the understanding of the causes and development of spondyloarthropathies. A key element of this has been the recognition that enthesitis may be considered the primary pathological process underlying SPA-associated skeletal inflammation. Previous studies in PSA patients have identified risk factors for developing enthesitis to be high body mass, more active joint disease, and young age. This association between young age and enthesitis observed in PSA patients may be due to mechanical load being a trigger for enthesial inflammation, as physical activity is usually higher in younger individuals. It is likely that the overall burden of enthesitis may be higher than clinically estimated, primarily due to there being more enthesial sites than those assessed in standard clinical examinations. We also know that the application of imaging techniques yields a substantially higher prevalence of enthesitis than palpation. Enthesial pain can be disabling, and the management of enthesitis is still seen as a challenge for rheumatologists. The HEAL trial was the first randomized, placebo-controlled, multi-center study of an anti-TNF agent for the treatment of patients with SPA with refractory HEAL enthesitis to show significant clinical benefits. In this trial, patients receiving Enbrel had significantly greater improvement in the PGA of HEAL enthesopathy activity versus placebo, with a significant change from baseline beginning at week 8. Patients also experienced an improvement in heel pain and lower limb function. These results suggest that Enbrel could be of significant benefit to patients with SPA suffering with heel enthesitis.
Dear colleagues, Assalamu alaikum. It gives me a great pleasure to welcome all of you to the second GCC Rheumatology Conference that is hosted here in Muscat, Oman. However, it saddens me that we had to change the platform of the conference from face-to-face to a virtual one, and I'm not able to greet you in person. But the decision stemmed from the National Supreme Court recommendations, as well as the organizing committee having your safety as a priority. The aim of this conference is to advance scientific research in the field of rheumatology, both regionally within the GCC countries as well as internationally. Therefore, by creating a platform such as this conference, it will enable us to share and discuss our research in the field. It would also advance research through enhancing professional network and therefore collaboration on future multi-centered and multinational research projects. The ultimate gain in mind is to form an alliance whereby together we can set the GCC in the global map of research. Although Oman is hosting the conference, however, the success of the GCC conference is completely dependent on joint efforts. By the contributions from our pediatric rheumatology colleagues across the GCC countries, we were able to establish a solid scientific content of the pediatric program, which I promise you will be very rich in content. The first day of the conference will be loaded with interesting workshops on how to create a registry, how to conduct a clinical audit in relevance to our practice, how to develop an approach to immunological investigation, in addition to many workshops related to academia. The second day of the conference will be a day full of pediatric rheumatology sessions. The pediatric rheumatology program will contain 7 topic reviews, 10 research abstracts, 5 challenging cases, as well as a workshop and autoinflammatory disorders. In addition, there will be many topics of interest that will be running simultaneously in parallel in the adult program. Finally, the last day of the conference will contain topics that will be of interest to both pediatric and adult rheumatologists, including sessions on systemic lupus erythematosus, antiphospholipid syndrome, vasculitis, connective tissue diseases, as well as the effect of COVID on patients with rheumatic diseases. So you can see the program is really rich and packed with the most up-to-date scientific content, and we're all very excited to start the conference together. Once again, I would like to thank you for your participation in the conference and hope that we enjoy the next few fruitful days together. And most importantly, hopefully that we'll be able to meet each other very soon, inshallah. Take care. Assalamu alaikum, everybody. I hope you're doing well. It gives me a great honor and a pleasure to be introducing a great colleague of mine, Prof. Sulaiman Al-Mayouf. Prof. Sulaiman is affiliated to both Al-Faisal University as well as King Faisal Research Center. Prof. Sulaiman is an eminent figure in the field of pediatric rheumatology, not only in the GCC, but also in the Arab world and internationally. He is also the national coordinator for PRINTO, as well as the national coordinator for Autoinflammatory Disease Alliance Network. Really, the Arab world truly owes Prof. Sulaiman, great contribution for his contributions and leadership in initiating collaborative research projects within the Arab world and truly setting the GCC and the Arab world within the global map of research. So I would like now to introduce Prof. Sulaiman Al-Mayouf, and he'll be talking to us about monogenic lupus. Prof. Sulaiman.
Assalamu alaikum wa rahmatullah. Good morning, everyone. I'm very pleased to participate in the second GCC Rheumatology Conference. I would like to thank Dr. Reem Abdwani for her kind invitation. So in the coming 20 minutes, I will highlight some aspects of monogenic lupus. Here is my disclosure, and these are the headlines of my talk. There is a common saying, lupus is a disease of 1,000 faces. I think it's appropriate also to remember lupus is a cluster rather than a disease, single disease. We have systemic lupus erythematosus, we have cutaneous lupus with different subtypes, we have neonatal lupus, we have drug-induced lupus. I would propose that monogenic lupus is one of that cluster, so I will add it here, and we will see how it goes during the presentation. As you know, lupus is a heterogeneous disease and with the heterogeneous clinical and laboratory manifestation. And we know that childhood lupus is different from adult onset lupus in terms of severity of symptoms, major organ involvement, and the need for more treatment, namely corticosteroid. Saying that, we are sharing the same classification criteria with adult rheumatologists in stratifying patients with the SLE patients. Like other multifactorial autoimmune disease, the etiology and pathogenesis are not well defined. However, We know that from a lot of evidence that there are main player in pathogenesis of lupus. Among these players are self-double-strand DNA and interferon signature. This figure just to show us part of the pathogenesis of lupus. We know that there is a clearance defect in apoptosis and neutrophil extracellular traps. These are the major source of self-double-strand DNA. In the light of loss of tolerance, there are anti-double-strand DNA produced by autoreactive B cell with help of autoreactive T cell against self-double-strand DNA. So this immune complex trigger the production of type 1 interferon through intracellular sensor of phagocytes and dendritic cells. So the tumor type 1 interferon has positive feedback on dendritic cells and autoreactive T and B cells. There is a conviction that interferon type 1 is the driving force in lupus pathogenesis by participating in inflammatory reaction, dendritic cell maturation, and activation of autoreactive T and B cells, as you saw in the previous figure. We know that lupus patients have different manifestation, and also the severity of the disease and the age of presentation are different among ethnic groups. The question, what is the reason for the clinical heterogeneity? There is no clear answer. However, the basis of the heterogeneity related to genetic and epigenetic, in addition to various pathogenic mechanisms. Now, we have few questions. We need to raise it and hopefully we can answer it. What is the relationship between monogenic lupus and SLE? Is monogenic lupus a subset of SLE? From the previous slide, I can tell, yes, it is subset of lupus, but not subset of systemic lupus erythematosus, because we agreed systemic lupus erythematosus is one of the cluster of lupus. So monogenic lupus and systemic erythematosus are part of this cluster. Is it a different entity? Monogenic lupus is different from systemic lupus? Most likely, yes. And we have probably some evidence we can discuss it. The interferon type 1 considered as the primary or maybe essential pathogenic factor in lupus, and it is implicated in lupus pathogenesis by multiple lines of evidence, including genetic variant. And there are growing number of genetic variants predisposing to lupus manifestation. If we talk about interferon type 1 in pathogenesis of monogenic lupus, we know that the overproduction can lead to severe lupus and vasculitis changes. And again, there is a conviction that apart from complement deficiency, majority of the single gene defects that lead to monogenic lupus are categorized under the umbrella of interferonopathies. And we can see some cases and share it together. However, there are reports have linked the pathogenesis in C1q deficiency lupus and rare systemic autoinflammatory disease to dysregulation of interferon type 1. dysregulation, as you can see in these references. And probably it is overlap with it rather than have the same pathogenesis in terms of the clinical manifestation and the disease course. We know that lupus manifestation might be the initial presentation of inborn error of immunity or primary immune deficiency. There are certain disorders constantly associated with lupus manifestation, like C1q deficiency and C2, C4. However, others may be associated with lupus like common variable disease, while others like Ibex, Oman syndrome, very rare or unusual to manifest with the lupus features. Now, what is monogenic lupus? Is it a disease, syndrome, or construct? Just let me remind you about these three entities. Disease is one clinical phenotype and one pathogenic mechanism. Syndrome, one clinical phenotype and multiple pathogenic mechanism, while construct is multiple clinical phenotype and probably multiple pathogenic mechanism. So monogenic lupus perhaps fit more in construct than a disease or syndrome. And this construct has a strong and weak elements. The strong elements, the early onset of disease, the positive family history, and of course, if there is consanguinity, it will make it probably stronger. And for sure, if there is genetic variant. How is monogenic lupus defined, or what's the definition of monogenic lupus? This definition is my own definition. You can take it or leave it, but this is best after reviewing the topic several times and based on our limited experience. So I believe monogenic lupus can be defined as an umbrella for a heterogeneous group of single gene disorder characterized by integrating the paradoxical combination of autoimmunity and immune deficiency. And all this due to several separate pathogenic mechanisms. We know that monogenic lupus patients have a wide spectrum of clinical manifestation, ranging from mild to severe presentation. And even some patients, we know them, they have positive or genetic variant, but they are asymptomatic. From literature reports show more than 30 genes predisposing to monogenic lupus. And usually those patients severe and present with atypical manifestation, and most of the time they have consanguinity element in their history. I prefer and I like to categorize monogenic lupus in three subtypes. I will call them classic lupus, lupus plus, and lupus mimics. And what's the difference between these three? Probably we need to do further evaluation and discussion to come up with more consensus about these subtypes. But at least the lupus mimics, those who have the underlying disease is more showed more prominent features, and the lupus manifestation came after or due to the underlying defects. While lupus plus means they have prominent clinical manifestation in addition to lupus, and the classic lupus, basically they have the usual lupus manifestation in addition to the genetic defect. So let me give you an example for each subtypes, and we'll see how to do. The monogenic lupus mimics, this is a child, an 8-year-old girl presented with history of recurrent infection. She had a serious infection, required ICU admission. She had viral and fungal infection. Interestingly, she was fully vaccinated, no family history of autoimmune or immune deficiency in the family. However, during her disease course, she developed ataxic gait and facial palsy. And you can see her labs showed strong ANA positive and strong double-strand DNA with low complement and proteinuria. And the lupus nephritis showed she had lupus nephritis proved by biopsy. And I'm sorry for that slide, it's not clear or overlapped, but the MRI showed the infarction and irregularity of intracranial arteries, in addition to lung involvement with chronic changes. Now, any doubt about lupus diagnosis in this patient? Probably everyone will agree this is a lupus. And she met all classification criteria you need. However, because of the recurrent infection and the unusual CNS manifestation, we thought we need to do more investigation, especially for immune deficiency, and it showed significant defect in her immune system. And this led us to do genetic testing, which showed genetic purine nucleoside phosphorylase deficiency, which is very rare type of severe combined immune deficiency. And PNP deficiency result in metabolic disorder characterized by defective T-cell immunity and high serum type 1 interferon pathway activation. The second patient, a 6-month-old girl, still we are under the lupus mimics. 6-month-old girl diagnosed as a severe combined immune deficiency due to homozygous SARS-70 variant. She underwent stem cell transplant complicated by graft versus host disease. She presented with rash and acute kidney injury, and she developed MAS with hyperferritinemia. And the lab showed strong serology in terms of ANA double strand and low complement. And again, could this be lupus? Would you take this positive serology into consideration? I will leave it for you to think about. The second type, monogenic lupus plus, I get this from literature, and I know my colleague, Dr. Abdurrahman Asiri, he has one patient similar to this. 2-year-old girl presented with fever and respiratory distress, rash, and polyarthritis. She developed pancytopenia, hyperferritinemia, and bone marrow showed hemophagocytosis. And you can see from the photo, she had short stature and bone dysplasia. At age of 3.5 years, presented with fever, walking disability, and symmetric polyarthralgia, oral ulcer, and malar rash. And she showed again high ANA double-strand DNA with low complement. Interestingly, her brother presented at age of 19 years with oral ulcers and other manifestation consistent with lupus, with a positive serology, and in his case, he had intracranial calcification. The treating team decided to do genetic specific gene test for ACP5, and it was homozygous variant. And this is consistent, compatible with spondylochondrodysplasia with spasticity, cerebral calcification, and immune dysregulation. And this gene playing a role in stimulation and regulation of the type 1 interferon pathway. So again, all these cases have something to do with interferon pathway activation. The second or the third type is classic monogenic lupus, and we are proud to be the first group to publish this type of patient. That work was in collaboration with Dr. Reem, Abdwani, and other colleagues. We have a good cohort patient with loss of function variant in DNase IL-3. And the findings confirm the critical role of impaired clearance of degraded DNA in lupus pathogenesis. And you can see the strong family history with autosomal recessive pattern. And everyone is familiar with the C1q deficiency, and this is, I can say, a classic case with started at age of 2 years with facial rash and severe oral ulcers and digital vasculitis. She had nephritis class 3. I'm sorry for the slide, it's disturbed. And she developed CNS manifestation in terms of paraplegia and spasticity. And interestingly, she developed unusual manifestation in terms of pancreatic pseudocyst. At that time, we didn't have the facility to do genetic test, but she had undetected C1q level, which is consistent with the clinical manifestation. So what did we learn from these cases? I think monogenic lupus represent a distinctive entity and might differ from sporadic childhood SLE. It is a highly complex disease with marked heterogeneity between patients, and that due to different etiology and pathogenesis causing anything from mild to life-threatening disease. It might overlap with other monogenic interferonopathies, as I showed you in previous slides. And this necessitates us to consider early onset disease, family history of lupus, or recurrent infection should raise the suspicion of monogenic lupus. And also we have to keep or to consider a need to define a method for classifying these cases. And I think the next speaker, Dr. Lujayn Akbar, will tell us more about this point. Such patients should undergo molecular genetic testing if they have early onset and family history and recurrent infection. They are candidate to do molecular genetic testing. And the last thing, I think there is a bad need for considering the new therapeutic approach with the new medication available these days. So in summary, a variety of monogenic causes of lupus have been identified, which have eliminated the complexity of lupus. Monogenic lupus is a heterogeneous group of single gene disorder integrated the paradoxical combination of autoimmunity and immune deficiency. Refined understanding of these diseases pathways should drive better diagnostic tests and segregation of patients in subgroups for treatment and prognosis. I'd like to thank you for listening, and we'll be happy to take questions at the end of the session. Thank you.
Thank you, Prof. Sulaiman, for an excellent talk. Now, I'd like to present our next speaker, Dr. Lujayn Al-Khubr. She's a pediatric rheumatologist working in Fahad Hospital at University of Khubr. And Dr. Lujayn will be talking to us about the performance of the classification criteria, the EULAR 2019, in patients with monogenic lupus. Dr. Lujayn.
Assalamu alaikum and good morning. It's my pleasure to be presenting in the GCC Rheumatology Congress. On behalf of the primary investigator and the co-authors, I'll be presenting our work, the performance of EULAR ACR 2019 classification criteria of SLE in patients with monogenic lupus. So Bismillah, I have nothing to disclose. Now, a little bit of background. Monogenic lupus is a distinctive entity that might differ from patients with sporadic lupus or childhood lupus. It is a rare entity, however, it is now being more commonly recognized nowadays with the genetic testing. Typically, it is characterized by an early onset severe disease, usually in the mucocutaneous manifestations, and a strong family history of lupus. A wide variety of manifestations and overlap with other disorders exist, including patients with monogenic interferonopathies, for example. Up till now, there have been no validated classification criteria or diagnostic criteria to diagnose these patients. So the diagnosis is based on the physician's opinion or the expert's opinion. Recently, the EULAR ACR 2019 criteria was tested and evaluated in pediatric patients with sporadic lupus, and the results were variable. However, for most, it showed better performance in terms of sensitivity and specificity compared to the previous criteria. So our objective in this work is to evaluate the application of the EULAR ACR 2019 to monogenic lupus patients and to compare its performance against the SLIC 2012 criteria. Moving on to patients and methods, this is a multi-center, multinational retrospective cohort study, included 3 countries, Saudi Arabia, Oman, and Italy. The study group consisted of patients with monogenic lupus based on genetic testing, and the diagnosis was based on the expert physician opinion or fulfilling the SLIC 2012 criteria. The control group consisted of sporadic lupus, classified by the SLIC 2012 as well, and non-lupus patients, systemic GIA by the EULAR, and the JDM by Buthaina and Peter. The selection of these patients, JDM and systemic GIA, was based on the phenotypic similarities with lupus. So the inclusion criteria consisted of monogenic patients proven by genetic testing and or providing that there is a genetic mutation, and an age of onset less than 14 years at the time of initial presentation. Also an available ANA result, whether it's positive or negative. Exclusion criteria consisted of familial lupus without proven genetic testing and insufficient data. So the classification criteria was applied to the study and control groups at the time of initial diagnosis. Both the domains and the scores were evaluated as per the classification, criteria for each criteria. So ethical considerations: the Ethics Committee of Research Affairs Council at King Faisal Specialist Hospital and Research Center approved the study protocol. As well, the ethical approval was obtained from other centers. Now moving on to results. The sample size was initially 158 patients. However, one patient from monogenic lupus group was excluded due to insufficient data, as well as 4 from the control group. So we ended up with 135 patients, including 100 females. The study group consisted of patients with monogenic lupus, 49 patients, which represents 32% of the study. And the control group was childhood SLE, 36%, and non-lupus patients, systemic GIA, 20%, and JDM, 11%, respectively. So this pie chart represents the spectrum of patients with monogenic lupus. As you can see, the majority of patients had DNase deficiency, mostly due to DNase 1L3 deficiency and DNase 2 deficiency. And this was followed by complement deficiencies, primarily due to C1q deficiency. Other entities included primary immune deficiencies and interferonopathies. So this table compares the demographics of the study and the control group, monogenic and the control group. As you can see, all the groups had female predominance, but the highest male to female ratio was among patients with monogenic lupus. Monogenic lupus patients also had an earlier age of at diagnosis compared to sporadic lupus, but it was comparable to non-lupus patients, which was 5 years. Now, the most important part of this slide or the table is the fulfillment of the EULAR ACR 2012 criteria. So patients with monogenic lupus, around 90% of them, they fulfilled the criteria versus 98% of sporadic lupus and 12% of non-lupus patients, which was statistically significant. The p-value was also significant in the mean score. So you can see that monogenic lupus, the mean score was 22.3 versus 22.5 in sporadic lupus and 8.5 in non-lupus patients. Here we will compare between the both criteria, so between SLIC and the EULAR ACR criteria among patients with monogenic lupus, the study group. So as expected, the constitutional manifestations are counted in the EULAR ACR 2019, but not in the SLIC. Other domains, as you can see, are somewhat similar, but the neuropsychiatric manifestations were doubled in by the SLIC. It was more frequent, and this is due to the expanded manifestations of the neuropsychiatric manifestations in SLIC as compared to the EULAR ACR 2019. Now, the EULAR ACR 2019 domains across all the study groups, the study and the control group. As you can see in the table, monogenic lupus patients scored the highest in renal manifestations and mucocutaneous manifestations. Both frequencies of immunologic and hematological manifestations were more in patients with sporadic or monogenic lupus, so lupus in general, compared to patients with non-lupus. Now we reach to the summary or the most important slide of the paper. So the comparison of the performance between the SLIC 2012 and the EULAR ACR 2019. In the table, you can see that monogenic lupus patients scored or fulfilled the criteria in about 90% almost in EULAR ACR 2019, in comparison to 39.9% in SLIC 2012. Also, patients with childhood lupus, it was 98% and 90% respectively in EULAR and SLIC. Non-lupus patients scored 12 and 6%. So the sensitivity of EULAR ACR 2019 criteria in patients with monogenic lupus was 95%, which was higher than the specificity, which was 75%. Every study has its own limitations, of course, and the limitations of our study was that the study is a retrospective cohort, and none of the previously known criteria were evaluated in patients with monogenic lupus. So there is no true gold standard to classify or diagnose these patients. A more inclusive approach must be required to investigate patients with underlying, for example, monogenic interferonopathies or immunodeficiencies. Racial influences has not been explored, as the majority of our population was from Arabs. No genetic testing was carried for control childhood lupus patients. Not all immunological variables were obtained from non-lupus patients at the time of initial diagnosis, as it was not indicated. And as I mentioned, it was a retrospective cohort. So in conclusion, this is the first and largest study to evaluate the performance of the EULAR ACR classification criteria among patients with monogenic lupus. It demonstrated that this criteria is efficient in patients with monogenic lupus. However, further studies are needed to incorporate more patients with a wide diversity and genetic variants. And at the end, I would like to thank you for listening, and I would like to thank my mentor, Professor Al-Mayouf, for giving me the chance to be part of this work. Thank you very much.
Good morning, everyone. Our third speaker, Dr. Shahad Al-Ansari. She is a Chief Fellow in her second year fellowship program in King Faisal Specialist Hospital and Research Center in Riyadh. She graduated from Al-Qura University, everyone, and spent her residency in King Fahd Armed Forces Hospital in Jeddah. She has a special interest in the immune dysregulation and monogenic rheumatological disease. Welcome, Dr. Shahad. She graduated from Al-Qura University, everyone, and spent her residency in King Fahd Armed.
Assalamu alaikum. Good morning, everyone. Thank you for your kind introduction, and thank you for the organizing committee. It's my pleasure to be with you today. So without any further delay, this is my title for our paper, Genetic Variant and Phenotypic Features of Childhood Large Vessel Vasculitis and Vasculitis-like. I have no conflict to disclose. As you know, large vessel vasculitis is rarely affect children. Still, the exact etiology remains completely undefined, and like other autoimmune diseases, the etiology is thought to be multifactorial, involving interaction between different factors. Recently, genetic variants start to gain more attention and highlighting the possible underlying pathomechanisms involved systemic vasculitis. The chiasoarthritis is most common childhood large vessel vasculitis. It affects mainly the aorta and its major branches. More and more genetic variant susceptibility for TKISO have been reported. And interestingly, the identification of single gene defect have contributed better understanding of clinical variability and recognition of very rare variant of systemic vasculitis, including large vessel vasculitis. So our objectives, first is to report the characteristic of children with aortitis, large vessel vasculitis, and large vessel vasculitis-like, including phenotypic features, laboratory, molecular genetic findings, and outcome, and to review the published cases of genetic variants associated large vessel vasculitis. So it's a cross-sectional retrospective cohort study from single tertiary medical center and systemic review of childhood large vessel vasculitis associated with genetic variant. The study population was recruited from database at King Faisal Specialist Hospital and Research Center in Riyadh from January 2000 till June 2021. The search of the database using the following terms related to the large vessel vasculitis, as well as terms related to inborn error of immunity. The English language was imposed to be the language of publication, and these search involved all age groups. So our inclusion criteria, all patients with aortitis and its branches confirmed by imaging study. All patients should have positive genetic variants with childhood age less than 16 years presentation of the primary disease and elevated inflammatory markers. And we use EULAR brain to breast for Takayasu as the classification criteria. For the exclusion criteria, we exclude all patients with sporadic cases without proven genetic testing, any patient with vasculitis associated with other autoimmune disease or infection, and all patients with insufficient medical data or without regular follow-up visits. So the result first of our cohort study, we started with 89 patients who have large size vessel involvement. After removing of the duplication, 43 patients remained. Further exclusion, the adult onset vasculitis, only 30 patients younger than 16 years remained. So we ended with total of 7 patients who had large size vessel vasculitis involvement, age less than 16 years, and positive genetic variant. As you can see here, we had 2 unrelated patients with hyper IgE syndrome, 1 patient with IBIC syndrome, 1 patient with novel mutation that thought to be pathogenic with dysmorphic feature, early onset inflammatory bone disease, and large vessel vasculitis, 1 patient with DITRA syndrome, and 2 unrelated patients with familial hypercholesterolemia. As you can see, there is a male to female ratio is 1.3 to 1 with male predominant. Almost all patients presented with their primary disease at the first 2 years of life. The age of aortitis onset was as early as 7 years and as late as 17 years with mean of 10 years. And the time interval between the primary disease onset and the aortitis onset was ranging between 4 to 16 years with mean of 8.8 years. All patients had positive first or second cousin degree consanguinity. And here are our molecular genetic for our patients. So for the imaging study, all of our patients had evidence of extensive aneurysmal or dilatation of the aorta and its branches. 5 out of the 7 patients had MRI or CT, and 3 out of these 5 had histopathological evaluation suggestive of inflammatory process. And the 2 patients with familial hypercholesterolemia, only echo was done for them, and the changes thought to be related to the underlying disease, so no further investigation or imaging was done. Although we think that it could be an inflammatory vasculitis based on the presence of high inflammatory marker, but because of the leaking of imaging, we exclude them from our analysis. So this is the imaging just to give you a hint how extensive and bad the vasculitis was among our patients. So for the clinical manifestation, all of our patients had cardiovascular in form of palpitation, chest pain, and claudication and bruit. Majority had constitutional symptoms. 2 of the patients had hypertension, and 2 with CNS complication like seizure and mononeuritis multiplex. All patients had high ESR and CRP and elevated liver function tests, and all had CBC abnormalities. So all patients had a leukocytosis and anemia. 3 had thrombocytopenia, and the rest, 2 patients had thrombocytosis. 2 out of the 5 patients had a positive ANA, and none of the patients had a positive ANCA. For the management, all patients received steroid. 4 patients received DMARD, either conventional, biologic, or combined. 4 out of our 5 patients required surgical intervention, and 1 of the patients achieved remission after bone marrow transplantation. For the outcome, as you can appreciate here, that the majority of patients had the highest damage index, and almost all patients had a valvular disease. Other organ damage are cardiomyopathy and the breast function. We had a patient with peripheral neuropathy and CVA, end-stage renal disease, osteoporosis, and vertebral compression, and unfortunately, we lost 1 of our patients. So moving to the result of systemic review, we started with the 70 articles as it demonstrated here. The abstract of these articles were reviewed and 24 excluded for variant reason. Full text of the remaining 46 articles were reviewed and 31 were excluded. And we ended with 15 eligible articles, total of 17 patients of aortitis who had childhood confirmed genetic disease. So these patients are listed here, and this is the gender distribution with male to female ratio 1.1 to 1 with male predominant. The age of primary disease onset ranged between 1 month and 15 years. And the age of aortitis onset had a wider range from 14 months and 22 years. And the interval between the onset of primary disease and aortitis ranged from 1 year and 17 years. All patients had confirmed angiographic abnormalities, aneurysmal or dilatation of aorta and its branches. 11 out of the 17 had biopsy evaluation suggestive of inflammatory process. The inflammatory marker, ESR and CRP, was done only for 4 patients out of the 17, and all had high result. Autoantibodies ANA and ANCA were sent only for 3 patients out of the 17, but came negative. The majority of patients received steroid. 6 patients received conventional DMARD, and 2 patients received biological DMARD. 1 of the patients ended by BMT, and 3rd patient required surgical intervention. For the outcome, majority of the patients achieved clinical remission. 2 patients ended with CNS complication, and unfortunately, we had 4 deaths. We have some limitations that we noticed during our analysis, like some of the complications may relate to the underlying disease rather than the vasculopathy itself. Lab abnormalities were difficult to be interpreted in context of underlying immune dysregulation, like immune deficiency. And like most of the retrospective cohort study, we have some missing data, and some of the available data were maybe of poor quality. So we concluded that this is a study that's showing wide spectrum of underlying inherited disorder with genetic variant associated with early onset large vessel vasculitis, which may allow to propose the monogenic large vessel vasculitis as a distinct entity. These findings would increase the awareness of the association between large vessel vasculitis with genetic variant, and early recognition can lead to better understanding of the disease pathophysiology and earlier effective intervention in order to improve the outcome. And we are planning to review the sporadic cases of large vessel vasculitis and compare them to the monogenic cases, and then with the reviewed published cases in the literature in near future, inshallah.
Thank you, Dr. Shahad, for your lovely presentation. Our next speaker will be Dr. Buthaina Al-Adba. Dr. Buthaina, she's a pediatric rheumatologist from Sidra Hospital in Qatar. She's a member in the ACR and also a member in Pediatric Rheumatology Arab Group and Qatari Physician Association. She's a member at the High Cost Committee in Sidra Hospital. She's a member of Quality Committee in Sidra Medicine. And also she's a member in SOBI Advisory Board. And also she's a member of a Fragile Bone project in Sidra Medicine. Welcome, Dr. Buthaina.
Assalamu alaikum wa rahmatullahi wa barakatuh, and hello everyone. I'm Buthaina Al-Adba. I'm one of pediatric rheumatologists at Sidra Medicine in Doha, Qatar. First of all, I would like to thank the organizing committee for inviting me in this great conference. Although it's virtual now, but hopefully we will able to meet each other in upcoming meeting in a person. My talk today is about an interesting topic to all pediatric rheumatologists, and it's about immune dysregulation and autoinflammatory/autoimmune presentation on these kids. And I would like to share with you our experience, a single center experience, and how we actually having these challenging in seeing these patients and treating them. So I hope you will enjoy it. Hopefully in the upcoming 20 minutes, I'll be able to discuss immune dysregulation in children, describe some of the genetic causes for the immune dysregulation in kids, and recognize immunodeficiency kids who presented with autoimmunity and autoinflammatory. And at the end, sharing with you challenging cases that we face in our practice. So immunodysregulation is a group of disorders that can trigger defective or uncontrolled immune response. And it basically could present with autoimmunity, autoinflammation, or dysregulation of lymphocyte homeostasis or hypersensitivity reactions. These disorders can be caused by distinct genetic defect, and some which also can present with immunodeficiency. The rise in the prevalence of these disorders and the discovery of a new genetic causes underline the need of precise genetic evaluation. Now, having accurate diagnosis will followed by specific treatment, which can improve patient outcome and give the patients a good management. So let me start with a real case that I saw in my practice, a 12-year-old boy who presented with a 5 years history of recurrent attacks of what looks like urticarial rash that sometimes was cold induced. The attack will last up to 7 to 10 days, non-itchy, and mom complained of arthralgia as well. Mom wasn't sure about fever, but she gave a history of what she called subjective fever. And she mentioned a recurrent upper respiratory tract infection that more than his siblings. So based on that, he was referred initially to the immunology team who diagnosed him with urticaria, started him on antihistamine, but there was no good response, and therefore he was referred to us with the possibility of other autoinflammatory condition. So this is a photos of his rash, and someone can argue it's classic urticarial rash. However, we don't see this kind of urticarial rash happening in the palms, but in the face and in the legs, they looked urticarial, and as I mentioned, they were non-itchy. He had normal blood, mild inflammatory markers in between attacks, but nothing striking. And he had negative ANA, ANCA, and normal immunoglobulins with normal other immunological workup. So we discussed with the parents the biopsy, but they were reluctant, and as the rashes comes and goes, and they wanted to wait a bit. And because the question for us an autoinflammatory presentation and the rash is not classic for urticaria, we decided to send genetic testing. And interestingly, it showed a heterozygous mutation in the PLCG2, which is the phospholipase gamma-2 of a variant of unknown significance. So PLCG2 is a gene located in 16 chromosome that encodes the phospholipase gamma-2, a transmembrane signaling enzyme that catalyzes the production of second messenger molecule utilizing calcium and propagate downstream signal in several hematopoietic cells, which is very critical and important in the regulation of the various immune and inflammatory pathways. It has been reported that the heterozygous mutation at the PLCG2 can have a spectrum of clinical phenotypes. One of them, called the PLCG2-associated antibody deficiency and immune dysregulation syndrome, the PLAID. The other one is autoinflammation antibody deficiency and immune dysregulation syndrome, the APLAID. And the last one, the familial called autoinflammatory syndrome, the FCAS3 or FAX3, which all are autosomal dominant. Now, the PLCG gamma autoantibody or autoinflammatory immune deficiency syndrome, characterized by recurrent blistering skin lesion with a dense inflammatory infiltrate to a variable organ, could be joint, eye, or GI tract. These patients may have also mild humoral immune deficiency associated with recurrent sinopulmonary infection, but very interestingly, there were no evidence of circulating antibodies. The FCAS3 associated with cutaneous urticaria, erythema, and response to happens response to exposure to cold, with fever and inflammation again in different organs, including skin, joint, CNS, and GI tract. They also may have additional immunological defect, including antibody deficiency, decrease in the number and function of B cells, and increase the susceptibility to infection, and also the risk of autoimmune disorders. So this is one of the recent paper published describing 5 kids with the PLCG2 mutation that published just recently last March. And if you can see, the majority of these patients, they will present with recurrent respiratory tract infection, one of them with maculopapular rash. And when they looked at them immunologically, 3 out of 5 have the hypogammaglobulinemia. However, one of them had normal immunoglobulins, and one of them have the specific antibody deficiencies. When they looked at the genetic testing, interestingly, that either the father or the mother will have the mutation, and pretty much similar to our patient, the majority of them were VUS, or variant of insignificancy, and they were present mainly with common variable immune deficiency, and one patient, similar to our patient, present with the urticaria kind of rash that was cold induced. Now, back to that case. So what we did, we start to look if any of the parents will have the mutation. And interestingly, the father was having the same heterozygous mutation, the PLCG2 gene. And when we were asking him, he mentioned that he had some rashes when he was kids. But because it's a VUS, and we have decided to look further and do further functional study, basically the calcium influx assays, which related to the PLCG2. First of all, we looked at our patient mutation, and this is a figure that from a recent published paper in 2020, where they reported a patient with PLCG mutation gain of function who presented with autoinflammatory symptoms, and their patient had the mutation in the C2 domain, which involved in calcium binding and membrane anchoronic of PLCG2, and this is the patient that they published affected in this amino acid, and this is our patient. And if you can see, our patient is right next away to the reported patient, and just 10 amino acids away. And we decided to do more functional study, the calcium stimulating pathway. So basically what we are doing, we are trying to stimulate the PLCG2 gene by different pathways. The direct way is by stimulating by the B cells receptors, but we've decided to do the indirect way by using 2 different drugs. The first drug is the pepsigargan drug that will bind the SERCA channel. The SERCA channel are the channel which causing the calcium flux inside the endocytoplasmic reticulum. So when you block this channel, there will be decrease in the calcium in the endocytoplasmic reticulum, the ER, which will stimulate 2 different channels, STIM1 and ORI1. This will lead to more calcium influx in the cytoplasm. The calcium influx into cytoplasm will stimulate the PLCG gene, which will lead which will stimulate one of the lipids called PIP2, break it down to different kind of lipids, stimulate again the channel, and then more calcium coming to the cytoplasm. So when you have a mutation in the PLCG2, this pathway will be affected, and there will be decrease in the decrease in the calcium moving to the cytoplasm. The other way is by the carbachol drug, which is the same pathway but a different receptor. At the end, there will be calcium flux in the cytoplasm. But when you have a mutation, the calcium flux will be less. So when we try to apply this to our patient, and very interestingly, regarding the first drug, the pepsigargan, first we incubated both patient and the dad affected, along with the mom, and healthy control and 0 calcium. And when we use the drugs, there will be flux of the calcium inside, and you can see it's significantly the same. All the same. There is no significant statistical change. However, when you use the other drugs, they will be different. The father and the boy, they have a bit low calcium flux, which can prove the theory they may have a real mutation, that PLCG2. However, as I mentioned, these were an indirect way of stimulation the gene, and our next step will do the activation of the PLCG2 with the B cells receptor stimulation. So we've decided to do more functional study, and we were discussing about possible using a canakinumab for his rash. However, because of the financial issues, we held that until we complete all the functional workup. Now, moving to the second case, she's a 10 years old girl with a history of fever for 3 weeks duration. When we took more history, actually, mom mentioned that this girl used to have a lot of fever when she was young, with tonsillitis and otitis media since the age of 3 years, recurrent scalp and vaginal fungal infection. Parents were consanguineous, and she developed the weird oral and nasal ulcers, as well as a rash over her palms, as you can see in the photo. She had no cytopenia, maybe mild anemia, DIT positive, high inflammatory markers, normal immunoglobulin. She had positive ANA, double-strand DNA, and negative ENA with normal complements. So the question for us is, could this be SLE? We couldn't find a lot of criteria, but because we ruled out all other possibility infectious causes in addition to malignancy, we've decided to treat her like Lupus-like and give her steroid with a second line agent, which we use mecofenil until we do further workup. And we thought to send for her genetic testing because she wasn't typical, especially with this recurrent infection. And she found to have heterozygous mutation in RELA haploinsufficiency, again, a FUS variant. And when we look at the RELA haploinsufficiency, it's basically an impairment in the stromal and epithelial cells that lead to impairment in the recovery following a mucosal injury. And they've been saying that the systemic symptom that they have due to the direct microbiome effect to these ulcerated or affected area, which will lead to further stimulation of the TNF release. So it's a monogenic disorder that phenotypically resembles to haploinsufficiency at 20, but with a different underlying pathway abnormality in NF-kappa B pathway. And the, as you may know, NF-kappa B pathway has a role in the TNF signaling and apoptosis with the cell survival. And very interestingly, when they test the fibroblast of those patients, they found increased apoptosis and impaired of NF-kappa B activation in response to TNF. So when we looked at the literature, it's been described by a few papers, one of them Badran et al. In 2017, where they describe a single family where the index of 3 years old kids with a recurrent mouth ulcer, fever, vomiting, and acute colitis. Genetic testing revealed the heterozygous RELA mutation, and both mother and the sibling having the same mutation, and they treated very well with infliximab. The other paper was publishing for a 5 years old boy who misdiagnosed with autoinflammatory lymphoproliferative syndrome, who presented with splenomegaly, ITP-like picture, headache, CNS meningitis, and again, the genetic testing showed de novo heterozygous mutation of RELA. Therefore, we decided to look more about this mutation in our patients. And this is where we looked at the different domain proteins that in RELA mutation. And one of the important domain is the REL homology domain. And our patient is actually having the mutation inside that domain. And when we did overexpression study to that mutation, this is our patient, comparing to the control and the wild type, we found that the mutated RELA have less expression compared to the wild type, and that's why it's a polymorphic kind of mutation. And the other way is that we looked at the TNF stimulation with this mutation, and usually they have, the wild type will have very high response to TNF stimulation, but when you compare it to the mutated patient, they will have higher compared to control, but less, and that's why it's polymorph kind of mutation. So we've decided to do further study looking more at that gene. But to update you about this patient, she responded very well to steroid, currently off treatment, still getting the ulceration, but better than before. And we would like to consider the anti-TNF after completing her functional studies. The third case, we have a 5-year-old girl who presented with recurrent skin rash. It's mainly lesions, not rash, over the neck and face for the last 5 months. Mom also gave a history of intermittent fever, antibiotic with less improvement, but there was no much other symptoms, past medical unremarkable, and again, parents were consanguineous. And as you can see, this is the lesion that the physician was worried about, and they said it's not typical infection, she's not responding, though there is a lot of crust here, and someone can argue that could be infected, as well as a lesion in the cheeks. Interestingly, she had normal inflammatory marker, negative antibodies. At the end, we've decided to do a biopsy, which showed mixed acute and chronic inflammation with monogranuloma. But very interestingly, there was rare plasma cell, which is not typical with any inflammation. So we did immunoglobulin, and she had a relatively low IgA, but nothing. And the question for us is this sarcoidosis or granulomatous vasculitis. So because of that history of paucity of plasma cell, granuloma, some low immunoglobulin, we decided to send genetic testing, and she turned to have the homozygous mutation in RAG2 pathogenic variant, which, as you may know, is affecting the recombination activation RAG1 and 2, which associated with a variable a variable phenotype from classic SCID OMM to very simple common variable immunodeficiency and recurrent granulomas. They used to have dysregulation like autoimmune cytopenia, enteropathy, sometimes CRMO, as well as vasculitis has been reported like HSP and polyarthritis nodosa. So our patient was diagnosed with RAG2 deficiency, treated with IVIG, IV antibiotic, and did very well. And the last case I have, a 5-year-old boy with recurrent fever, abdominal pain, severe colitis, vomiting for 2 years duration. These attacks always triggered by upper respiratory tract infection, sometimes eye discharge, and would last up to 10 days. Blood work showed leukocytes during the inflammatory episodes, but in between he's fine. And the question for us was, is this FMF? Because of the recurrent upper respiratory tract infection, the eye discharge, the longer duration, we involved immunology, who sent for him lymphocyte subset, which showed low B cells and natural killer cells, but high CD8 cells, and immunoglobulin were relatively high, not low. But again, we thought to send the genetic testing, and he turned to have a heterozygous mutation in NFAT5 gene. NFAT5 gene is the nuclear factor activated T cells, a transcription factor regulating immune cells function and cellular adaptation to hyperosmotic stress. It has been reported in 2015 where Boland and his colleague reported a patient with NFAT5 mutation with autoimmune enteropathy who presented with autoimmunity and colitis, and they found him having a reduced NFAT activity, which affects his hypoosmolar condition. And analysis of colonic tissue and other conditions like IBD showed decrease in expression of NFAT5, and therefore we conclude that NFAT5 may play a role in the inflammation and the immunity in this colonic area. So we tested both parents, and father had the same mutation. And interestingly, he used to have recurrent infection, colitis-like picture when he was young, and therefore the patient was referred to the immunology for further workup and treatment. So in summary, autoimmunity and autoinflammatory are relatively frequent presentation in patients with immune deficiencies due to the dysregulation of the immune system, which can be challenging for the rheumatologist. And the complexity of the symptom and the overlap makes the genetic testing essential for understanding this disease to diagnose them and to treat them. Early presentation, consanguinity, similar history in the family, and recurrent infection, even if mild, should actually raise the possibility of genetic testing need. And with this era of genomic precision medicine, the approach and the treating patients are much better than before. And it's always challenging to treat those patients, as we have the background of immunodeficiency, challenging with the immune dysregulation, and weighing the risk and benefit of using the immunosuppressant treatment or follow the patient more closely. With this, I would like to end my presentation to thank all the team, my team and the research team who did a great job and contribute in our patient care. Thank you, and happy to answer any question when it's the time for the question panel. Thank you.
Thank you, Dr. Buthaina, for your nice presentation. Our next speaker will be Dr. Jude Masoud. Dr. Jude, she graduated from King Saud University in 2014. She went on to pursue her interest in pediatric, followed by pediatric rheumatology at King Abdullah Specialist Children's Hospital in Riyadh. Welcome, Dr. Jude.
Assalamu alaikum. Today I'm going to be speaking about the scope of management of Saudi patients with interleukin-36 receptor antagonist deficiency, case series, and review of literature. So deficiency in interleukin-36 receptor antagonists, a monogenic form of generalized pustular psoriasis, presents with recurrent episodes of fever, generalized erythematous skin rash, sterile pustular eruptions, neutrophilia, and elevated inflammatory markers, differing from generalized pustular psoriasis in its early age at onset and the wide spectrum of disease severity. It was first identified to be pathogenic and mapped by Marakshi et al. In a group of patients in North Africa. It's a retrospective chart review of a single tertiary care hospital in Riyadh, Saudi Arabia. Whole exome sequencing data of patients positive for interleukin-36 receptor antagonists were collected. 4 patients were found to be positive. They had a wide range of disease severity. However, their consistent symptom was fever and vesicular skin eruptions. Our first patient is a male. He's born in 1990 and diagnosed at the age of 11 years. He required hospitalization one time, and it was to the ICU. His other disease flares were managed in outpatient setting, and this is his homozygous interleukin-36 gene positive diagnosis. He failed interleukin 12-23 and calcineurin inhibitor, and his best response was in anti-tumor necrosis factor alpha, adalimumab every 2 weeks. He would not develop any disease flares if he was consistent on his medication. And their second patient is a female. She's born in 1961, diagnosed at the age of 40 years of age. Her whole exome sequence was done at that age. Previously, she was just diagnosed as generalized pustular psoriasis. She was never hospitalized due to her skin eruptions or fever. She had other comorbidities, and those were the reasons for her admission. Her previous medications that did not control the disease fully were anti-interleukin 17 and methotrexate, and her best response was on anti-tumor necrosis factor alpha adalimumab, again every 2 weeks. Our third patient is a female born in 1988 and was diagnosed at the age of 5 years. She did require hospitalizations with short durations of admission, but never ICU admissions due to her skin eruptions and fever and others. She failed methotrexate and acitretin, and her best response were on anti-tumor necrosis factor alpha adalimumab, again every 2 weeks, without hospitalizations after starting it. Our final patient, and she's on the far side of the spectrum of the disease. She had quite a severe disease, was the earliest presentation of all of them. She's a female born in 2011 and was diagnosed at the age of 1 year. She required frequent hospitalizations around every 2 to 3 months, and some of them were prolonged for 2 to 3 weeks. And also multiple ICU admissions requiring inotropic support. Her previously medication that were used and did not show great improvement were anti-TNF etanercept, calcineurin inhibitor, methotrexate, anti-interleukin-1, anti-interleukin 12-23, and her best response was on anti-tumor necrosis factor alpha every 2 weeks. She started to have only disease flares every 6 months to a year, but they were still quite severe when she got a flare, and one of them was requiring inotropes in ICU. So she was shifted to every week, and since then she's been doing very well, over a year. This is patient number 4, our youngest patient. This is one of her disease episodes when she was younger. Our first picture on the right hand is of her vesicular eruptions with starting of sloughing, and she looks quite miserable and ill. And the second picture is at the erythrodermal stage when there was already the skin sloughed. And again, the third picture is a continuation of the same scenario of the second one. So our experience supports that of Abdwani et al., where they performed a scoping review of pediatric DITRA patients managed with biological medication. It included 13 patients with a combined disease flare of 28 disease flares. They were treated with the following biological medication. Anti-tumor necrosis factor alpha etanercept, adalimumab, and infliximab were used in 12 flares, reaching remission in 8. It was either partial or complete remission in these 8 patients. And then the use of anti-interleukin 17, anti-interleukin 12-23 in 16 flares, leading to complete remission in 8 patients, or 8 disease flares. Promising results on the horizon. A pilot study conducted on palmoplantar pustulosis form of psoriasis using anti-interleukin 36 receptor antibody, spesolimab. It was conducted over a 16-week period on 3 groups. The first 2 groups were using the anti-interleukin 36 receptor antibody at different doses, and the final group, the placebo. Both the treatment arms showed superior results to the placebo in regards to decline in disease severity. DITRA continues to be a challenging disease to manage. Anti-tumor necrosis factor alpha is showing promising results that possibly would improve the quality of life and decrease the burden of the disease. Thank you very much.
So I'd like to express my sincere gratitude to all the speakers, really top-notch presentations and excellent research projects. So thank you all very much. A couple of questions from the audience. Question to Prof. Sulaiman. Any experience treating patients, monogenic patients with JAK inhibitors?
السلام عليكم ورحمة الله وبركاته. شكرا للجميع على great talks. Honestly, when we start to see these cases, the treatment was limited in terms of steroid and DMARDs. Then we initiate or introduce belimumab, and we get some good promising result. Just to answer Dr. Buthaina, so far we have 2 patients on JAK inhibitors after maybe I can say lack of efficacy of belimumab. And so far they are holding, and we hope they get better. Now we have to keep the expectation from these cases. We don't expect to cure or to control every single organ involvement. But so far the result is promising with JAK inhibitor, and probably we need to think about it as maybe before considering belimumab in certain cases.
What were the indications for starting belimumab in your cohort of monogenic lupus?
We consider it actually as first biologic DMARDs. And as you know, Doctora, from these cases, they have a refractory course. They don't respond to other DMARDs, conventional DMARDs. We know as we keep them on high dose of steroid, they are doing fairly well. But we don't like to keep them on high dose of steroid. They cannot tolerate lower dose. They cannot respond well to conventional DMARDs. Then we decide to go for belimumab. Of course, those patients have major organ.
Sorry, my question was what organ involvement those particular patients had for the belimumab?
Most of them, they have bad cutaneous manifestations. Some of them, they have arthritis. So they are variant. As you heard from the talk, they are not one group. So for instance, one patient, he had arthritis, and he did very well on belimumab from that perspective.
Thank you, Prof. Sulaiman. Another question to Dr. Lujayn, great work. Did you try to look into interferon signature level in these patients and compare them with your control group?
Okay, assalamu alaikum. Thank you, Dr. Reem, and thank you for this question. I know interferon is part of the pathogenesis in monogenic lupus or lupus itself, especially in monogenic lupus. But the purpose for the study was to evaluate the classification criteria, mainly EULAR ACR 2019, and not the pathogenesis underlying the monogenic lupus group that we have. So we have 2 reasons why we not evaluate interferon signature. Number one, it is retrospective cohort study, so it's difficult to assess these interferon signature because it's not available everywhere. And we took the available features, whether it's laboratory or the clinical manifestations. Number 2 is, as I mentioned, the purpose of the study. It's to evaluate the criteria, not the underlying pathogenesis. It would be great, yes, but this is not the purpose of the study.
I'm sure Dr. Buthaina wouldn't mind extending her help if she has interferon signature in her hospital. I'm not sure if she's extending her collaboration with you with that question.
Yeah, inshallah, we hope so.
Okay, thank you so much, everyone, for your great talk, really. We have one question for Dr. Buthaina, Dr. Shahad, and also for Dr. Jude. The question is, when we will suspect genetic defect, if there is no effective treatment with biologic, then we will think for a genetic defect at that time?
Assalamu alaikum. So allow me to answer your question. So first, I think there is several factors to consider genetics in these patients. First, I think the early onset of disease, atypical presentation, refractory to usual treatment, and strong family history. I think these factors should be present to consider genetics in these patients.
Okay. Dr. Buthaina, you have any comment on this question?
So I totally agree with Shahad. These are the main points that we have to consider when we try to think if that could be genetic. The other reason I would say, when you have patients is not like really responding very well to your treatment, or start to have a new manifestation that not typical to your diagnosis, then I think genetic testing also can help as well. You also have to win the risk and the benefit you get from genetic testing, especially it's not available everywhere and it may cost a lot to the patients. But I would say the points that Shahad mentioned, in addition to failure to respond to treatment, should trigger you to think about, should we send the genetic testing? And it could be sometimes easy to send the panel rather than send the whole exome sequencing, because I think every center will have their own panel of primary immunodeficiency, autoinflammatory, like containing at least 360 or even more genetic mutation for certain mimicking of autoinflammatory or autoinflammation / immunodeficiencies. That could be easier and you get the result earlier. But some patients that we had to push for whole exome sequencing because they were not typical to any, and we don't want to miss anything else. But I would say yes, these are the main points that we have to consider or push us to think of genetic testing.
In addition, the genetic testing will take time. You will not get the result very quickly, so that you can diagnose your patient and also start the appropriate treatment.
True.
Yeah. Okay. From my side, I have no more question for my speakers.
So I have a question to Dr. Jude. What is your experience of using anti-IL-1 in the treatment of DITRA? We know that IL-1 pathway is the main pathway in CAPS and many other autoinflammatory. So what is your experience with IL-1 rather than anti-TNF in the treatment?
Okay, so that's true. The pathway is through the IL-1 pathway family, and we used it on our last patient, the hardest one to manage, the youngest. And sadly, it did not control her disease as best as the anti-TNF. So her flares were continuing to be every 6 months. She would require really long hospitalizations from 2 weeks to 4 weeks. But at that time, she never required ICU admission. It did control her pustulosis. However, the fever was not.
Okay. There's a question from Prof. Sulaiman.
It's not a question, just if you allow me to add one comment about the first question regarding when would you consider genetic testing. All what my colleagues said is appropriate, but sometimes you need to do it also for counseling purposes, especially if there is more than one affected members. And this habit is known among our colleagues from medical genetics. Usually they will do it part of the counseling to get proper counseling conclusion.
I have a question for Dr. Al-Mayouf. Doctor, did you notice that the monogenic lupus, they have delayed puberty compared to the SLE, the classic pattern or the classic presentation?
Well, Doctor, sorry, we didn't look in that. As you know, our patient, we transfer them at least in our practice before 14 years of age. And we know the disease itself, the steroid and the chronic inflammatory process definitely affect the especially in girls. So we don't look in that specific and compare. But from the childhood lupus, we know that. We did the outcome assessment for our childhood lupus, those even in adulthood. We followed them till in adulthood period, and we found really they have delayed puberty. But we don't compare the monogenic versus sporadic cases.
I have another question for Dr. Shahad. Very interesting cohort indeed. It's very difficult to pick up Takayasu's arthritis, especially in children. It's very difficult for them to verbalize the clinical symptoms of claudication, bruit, hypertension may not be picked up. So in your cohort of patients, how did you pick them up? What was really the, if you're going to give a learning pearl, an advice and tip to the audience, what would that be? Especially the infant ones, very difficult. How did you do that?
So the early presentation of aortitis, we prefer to use the term aortitis, large vessel vasculitis and vasculitis-like, rather than using Takayasu. But in these patients, the onset of aortitis range between 4 years and 7 years and 17 years. The majority of patients presented with chest pain, palpitation, and more than claudication. Maybe one patient of our patient at age of 17, he started to have claudication. And but the majority presented with heart rate, increased heart rate, palpitation, and chest pain. So that was the major and the main presentation for their symptoms of large vessel vasculitis.
Prof. Sulaiman?
If you allow me, Dr. Shahad, and maybe Dr. Mona, remember the first case we published. Honestly, 2 of those patients discovered incidentally because they did chest X-ray and they found they have wide mediastinum. So we learn from these cases. Maybe certain syndrome you need to screen them for these cases. But I agree, Dr. Reem, it's very difficult, depends on the clinical sense or assessment, because most of the patients, they will not tell you because of maybe they don't have hypertension or they don't have enough symptoms to declare themselves.
Yeah, really, I have a comment. Just really, it is difficult to. I have a comment. Yeah, really difficult to diagnose Takayasu. I have one patient, 2 years. She presented with high inflammatory marker without any symptom, without any signs, except mild lower back pain. And after 2 years, she developed the symptom. And the main symptom she developed, it was hypertension. She was at that time 10 years old age.
Yeah, that is scary, right?
Yeah, because we looked for why she has persistent high inflammatory marker without any symptoms. We exclude everything, and it was weird.
Yes, absolutely. A question to Dr. Lujayn. So out of the 3 classification criteria, SLIC, ACR, which one would you recommend for patients with monogenic lupus?
Well, we did not evaluate the ACR, the 1997, so I cannot really comment on ACR, but I think no one is using it nowadays. So it's not the patients with lupus or monogenic lupus were not evaluated based on the ACR 1997. But the comparison is between the SLIC and the ACR EULAR 2019. So which one I would recommend? We compared both, but SLIC was the gold standard for us, plus the physician's opinion. So we cannot really compare both sensitivities or specificities. That's why I cannot compare one against another. But as you saw maybe in the criteria, the neuropsychiatric were picked up more by SLIC criteria. Immunological also were picked up more by the SLIC criteria. So in terms of sensitivity, as maybe you saw the result, the EULAR ACR had high sensitivity, which is usually used on clinical basis. But the specificity is higher usually with the classification criteria. So it depends if you want to classify or want to diagnose. If you want to diagnose, pick the highest sensitivity. If you want to classify, pick the highest specificity. So that's my answer. Still, we don't have comparison in wide spectrum. It's only like 49 patients. So we have other genetic variants that would not evaluate. So I think it should be on a larger scale before I can comment on that.
Thank you very much. Yes. And the last question to Dr. Jude, بالنسبة للDITRA patients. It's quite surprised that your patient's not responding to IL-1 because that is really the pathophysiology is with relevance to IL-1 pathway. I have to say I've been lucky with my patient, very good response with IL-1, but I'm just not able to wean it down, not able. A lot of flares, right? So what about you? Were you able to wean down the biologics at all, or with your anti-TNFs? Were you able to space them, or, they're asking how, is it going to be lifelong? And if we're just going to need to space it a little bit, I just found a lot of difficulty with the IL-1, just trying to even space it to alternate days, really needing daily treatment. I don't know
yes.
about your...
Sorry. In regards to the IL-1 and the other biological, because we used also for her IL-12, 23, which showed response in other patients, but not most of her responses were either poor response or she developed an allergic reaction that was proven by biopsy to biologicals. And if I'm not mistaken, some patients of DITRA do develop like disease flares with using IL-12, 23 and IL-1. Regards to weaning off her biological medications, we are still having problems with it. Actually, she just received her a vaccine, and she developed a mild flare while she was on anti-TNF. Thankfully, she didn't require any ICU admission, but we just admitted her because of her previous bad flares due to for observation, and she only required steroids. Later on, we might use IL-17 for her to try to wean it, but however, the adalimumab, we would never been able to wean it, or actually to space it. We've spaced it once, and she had one of her ICU flares that required inotropes.
Very quick question to Dr. Buthaina. We're running out of time. A question from the audience with regards to haplotype insufficiency is very much similar to Behçet's. Give us some clinical pearls on how to differentiate those two clinically.
Yes, so true, they are pretty much similar to each other. And I think if we want a solid differentiate, then we need to do genetic testing. However, I would say the Behçet, usually they may have more, as they reported, more vasculitic kind of presentations or recurrent genital more than not only oral, but genetic ulcers. They usually have high inflammatory markers, rashes, uveitis, for example, and haplo-20 insufficiency compared to the Behçet. They both have the uveitis, definitely, and these two are really more similar than the Rayla syndrome. But the Rayla, for example, never reported to have uveitis. But I would say, for a really definitive, it's challenging to differentiate between both the Behçet and haplo-20 insufficiency, and I think genetic testing is the solid kind of approach to differentiate between both of them. But they could be pretty much similar together at time presentation, especially if they present initially with the oral ulcer and uveitis.
Perfect. So I think we're running out of time. I really thank you enough. Excellent talks, very high standard. Thank you. We've all learned a lot from your presentations, and we look forward to meeting you very soon, inshallah. Dr. Mona, did you have any final words?
Thank you so much. Really, it was a great talk from everyone. Really, I enjoy really. And nice to meet all of you. And thank you, Dr. Reem, also for your time.
Thank you all very much. See you soon, inshallah.
Thank you.
Yeah, man.
السلام عليكم ورحمة الله وبركاته. صباح الخير للجميع. Welcome back to the second session of this great second GCC Rheumatology Conference Pediatric program. It gives me a great pleasure to co-chair this session with my colleague Safia Al-Abrawi from Oman. The title of this session is Transition and Juvenile Idiopathic Arthritis. I'm very pleased to introduce my colleague, Dr. Reem Abdwani. She is well known. She doesn't need further introduction. She is Associate Professor and Senior Consultant Pediatric Rheumatology. She graduated from Sultan Qaboos University, and then she completed her pediatric residency and pediatric rheumatology fellowship at Miguel and I think Vancouver University for her pediatric rheumatology. Dr. Reem is well known at the level of the regional as clinical excellent, outstanding clinical researcher. She published a lot of papers regarding from pediatric rheumatology, and she had extensive clinical experience in pediatric rheumatology. Dr. Reem will tell us more about transition of care in pediatric rheumatology. Dr. Reem.
Assalamu alaikum. I hope everybody's doing well. And today I'll be talking about transitional healthcare in patients with rheumatic diseases. I have no disclosures. So over the past decades, there has been significant improvement in the outcome of children with rheumatic diseases for many reasons. Firstly, there has been expansion in the number of pediatric rheumatology services around the world, and therefore patients are referred earlier to specialized centers, they are treated earlier, and as a result have improved outcome. Secondly, the advent use of biologic has significantly improved the outcome of patients with rheumatic diseases, especially the JIA. In addition to that, there have been several treatment strategies that have been published, such as treat to target, consistent treatment plans by CARA, as well as guidelines and recommendations that have been published by both Share and Printo. But in addition to that, there has been successful quality improvement projects made by special organizations and networks such as the PR Coin. These networks really focus on identifying and benchmarking disease outcome measures in patients with rheumatic diseases. And as a result, we pediatric rheumatologists can track and monitor our patients to ensure they receive those outcome measures. And as a result, equity in healthcare is provided to all patients with rheumatic disease across the globe. However, we have not been as successful in improving the outcome of patients with, especially adolescents with rheumatic diseases, for many reasons. Firstly, we know that adolescents have a much complex and challenging disease course. In the United States alone, there was a study that estimated there were about 5 million adolescents and young adults with chronic diseases, and was found that those patients who were just transitioning to adulthood between ages 18 to 25 has significantly worse outcome than the younger adolescents and the older adults. We all know that all common pediatric rheumatic diseases, the moment they transition to adult care, often have a disease flare within a year of transitioning. And their studies have shown that young adults with rheumatic diseases are most likely to have less college education, maintain employment, and tend to have a lower income than their peers. There are many differences between pediatric and adult healthcare. And the main differences, the fundamental differences lies between differences in disease phenotype, but also healthcare delivery system. So we all know that differences in disease phenotype, there are differences in the common pediatric rheumatic diseases. We know that lupus, for example, tends to have a more aggressive disease course, higher rate of organ damage, and more likely to have higher mortality and morbidity. Similarly, that we know that more than 50% of patients with JIA will go on to have adult disease, and the adult care providers will have to manage complications that they're not used to monitoring, such as uveitis, for example. But also there are fundamental differences between the way we deliver healthcare between pediatric and adults. In pediatric, it tends to be very family focused, where parents are the sole decision makers and children have very little autonomy. We tend to provide them very lengthy appointments because we tackle not only the medical aspects, but we also tackle other aspects such as, for example, education, social well-being, and so on. We also make sure that we address our children in a very developmentally centered fashion, meaning we take into account their cognitive ability, their maturity, and their psychosocial needs. And we have limited focus on fertility and pregnancy, obviously, and we tend to provide them an interdisciplinary care. However, the adult healthcare is very different. It tends to be more patient-focused, where the patient really are the individual and sole decision maker, where they have full autonomy. We fully respect their time, and in fact, we try to get them in and out as fast as possible in the hospital because we know they're very busy. We tend to provide very disease-centered focus and to spend more time discussing fertility and family planning, and to tend to give a multidisciplinary approach. Now, as you can see, there are fundamental differences between pediatric and adult, and we have to manage the expectation for both the adult who transition to adult care, as well as the adult care provider. Now, if we don't manage those expectations, there will be failure in transitioning. For example, if the adolescent goes to adult clinic and finds the appointments are so short, he may feel he's not getting adequate care, and that is not true. Similarly, if the adult care provider finds his patient to be not engaged or not ready for the appointments with questioning, or it just finds them to be not interested in their disease, and again, it may not be true. As a result, we really have to manage the expectation of both ends to avoid the culture shock and hence the failure in transitioning. So we have to think of the process as transition rather than transfer of care. Transition is defined as a purposeful, planned movement of child care to adult care. It's a planned and structured process rather than an event that occurs in one space of time. So in order for us to have a seamless transition, it has to have certain characteristics, meaning one of them is having coordinated care. There has to be a focal point identified in either end, the pediatric as well as the adult, that takes care of the logistics and the organization ahead of time. It needs to be uninterrupted, meaning the study that showed the longer time from the last pediatric visit to the first appointment to the adult care, the more likely is failure of transition. So really aim to have that transition period as short as possible. It also needs to be flexible, giving a range of age of transition, not just a fixed age number, and allow those patients that need longer with high risk factors, for example, such as studies have shown that boys with complex disease with very little support at home tend to need longer time to transition. We should allow them that flexibility. It needs to be developmentally appropriate, meaning we have to take into account the maturity, the cognitive ability, as well as the psychosocial needs in mind. It has to be comprehensive in addition to that, not only focuses on the medical aspect, but the social aspect, education, vocation, and so on. Confidentiality is also very important, and the core center of it all has to be the patient, of course. So believe it or not, as you can see, the importance of transition of care has started emerging in the literature for more than 30 years. And as you can see, multiple organizations have made standard recommendations and policy statements that have been written and published over the years. But overall, the main principles of all these recommendations are quite similar. I'm going to discuss one of them, which is the 6 core elements of principles of transition that have been published by GOT Transition. So you can see across here, the transition is a process that happens over more than 10 years. In this recommendation, they start at the age of 12 to 14 years, where firstly, a transition policy is written, discussed with the patient as early as, in some places, 10 years, but more commonly 12 years of age. Over the next 4 to 5 years, the pediatric rheumatologist tracks the progress as well as monitors the progress and the skills of transition using a validated assessment tool. And finally, when the pediatric rheumatologist feels that the patient is ready through the assessment transitional tool, at that time, he starts finding a coordinator on the other side, preparing all the transfer kits and transferring the patient to the adult care center. But as you can see, the process does not end there. It's just an integration to the adult care practice. It goes on until the patient is well comfortable and dependent. And the most important part of this process is getting a consumer feedback from the adolescent who's transitioned, as well as the adult care provider, how we can improve the system for future generations. So as you can see, the process is considered is not a one-way process. It's a dual process of a push and a pull. Yes, we pediatric rheumatologists push the patients on the other side, but more important part of the process is, in addition, is the pulling by the adult care provider to ensure that the patients have consolidated their knowledge, confidence, and independence in their own healthcare. So you can see it's a continuous process that needs to be developmentally appropriate. So what are some skills or points or aspects that we covered during this transitional process that should occur over a decade? Well, we have to educate our patients. They have to understand their illness, medication rationale. We educate them about the healthcare system, how to make their appointments, how to refill prescriptions, what is their insurance plan covers, and how to navigate through the healthcare system in case they need emergency help, for example, or they need to go and find an earlier appointment and so on. We also help them with some self-management skills, how to remember to take their medications, remember their appointments, and how to get ready for their appointments by getting some questions ready. We discuss with them some routine general medical aspects, such as importance of vaccination, bone health, and healthy lifestyle. We also gradually train our children to be more independent from their parents by attaining life skills. And very importantly, we have to also tackle very important aspects, which include psychosocial and mental health. This is very important, especially in our culture, whether we should disclose our illness, especially in a social area where it's stigmatized to have a chronic disease, especially if those young girls at the age of getting married, for example. Mental health, dealing with anxiety and depression is very important as well. And when the time comes, dealing with long-term planning, such as education, vocational training, as well as pregnancy and fertility. So you can see it's a lot to cover. Therefore, we cannot just throw all this information all at once to the adolescents. However, we should divide them and gradually increase the knowledge and skills as the child matures developmentally across the adolescent period, by gradually making them gain more independence till they're finally able to let go to the adult side. So this is a study. This study was actually done in Denmark, and this is really looking at the consumer end. So they looked at the patients with chronic diseases, and they asked them, what did they think the more important domains to have a successful transitional process? And according to this study, the consumer end, or the patients with chronic illness, identified the domains that leads to successful transition include staff competence, having a developmentally appropriate communication, that the physician focuses on the youth life, including mental health, and also allowing the youth to participate in shared decision-making. This is another study. This study was done in the UK, and they looked at the evidence-based positive impact on successful transitional process. And they found that if it's done in a constant coordinated fashion, it can have a positive outcome on the biomedical outcomes, adherence to therapy, satisfaction to healthcare provision, engagement to healthcare services, self-care practice, as well as achievement of independence. So what are some transitional tools that are out there? So you can see from here, from this list, there are several transition tools are available. Most of them are generic, meaning it can be used in any chronic disorder. The track is the one that used by the ACR kit. However, the only pediatric rheumatology specific questionnaire is the RACER questionnaire that is being validated at the moment. So you can see from this table here, comparing the various transitional assessment tools. Most of them have been validated, some of them as short as 14 questions, and some of them as long as 32 questions. Majority are patient administered, apart from this one, the transitional questionnaire, which is administered by the staff. And this is the one that we use in our center to assess the transitional readiness in a study, which we'll present later on. As you can see, it's quite extensive, and it takes about 20 to 30 minutes to do. The RACER questionnaire, again, tackles various aspects of patients' healthcare system. So what are some transitional outcome measures that we can ensure that we have achieved effectiveness in the process? Unfortunately, there's lack of standardization of outcome measures in the process of transition. This is a systematic review. They reviewed the literature and identified all the programs, transition programs that were clearly defined in the literature. And as you can see, the majority comes from Europe and some from North America, including the US and Canada. And the Vancouver Yard Clinic is where I was trained a very long time ago. As you can see from the ages, some start transitioning as young as 11 years of age, and some continue until the age of 25. Typically, the transition coordinator is a nurse, and the team consists of pediatric, adult rheumatologists, as well as a nurse, and allied health providers, in some centers including occupational therapy, physiotherapy, psychologist, social worker, and in the ER clinic, we also had adolescent medicine specialists with us. So as you can see, when they're comparing the various transitional programs that have been described in the literature, only half of them were really designed based on extensive research, which is done by focus groups, Delphi, surveys, or systematic review. And the other half were merely done by group discussion. And as you can see here, only 2 of the programs included quality indicators within the program. And those are the 2 that were able to show that there was effectiveness of their intervention in the program. In fact, some centers absolutely have no evidence in any way that their program has improved the outcome of their patients, hence really emphasizing the need of including quality indicators in any program that we design. So if we look at the 2 programs that included quality indicators, those were the Don't Retard, as well as Growing Up and Moving On. And these are the different types of quality indicators that they included. So I summarized them here. As you can see in the UK, they looked at various aspects of improvement, various indicators, and you can see they have evidence that they're able to make an impact on healthcare, disease knowledge, patient and parent satisfaction, and vocational readiness. Whereas in Belgium, the Don't Retard transition program, again, was very extensive quality indicators where there have evidence of improvement in certain aspects, and they know that certain other aspects they still have to work on, such as medication adherence, as well as support and autonomy. There's the 2017 EULAR and press recommendations for transitional care of patients with rheumatic diseases. It more or less covers, as you can see, the various concepts that we've already described, finding it, coordinating, starting as early as possible, importance of communications and recording, having an updated transitional policy, having a developmentally appropriate developmental process, ensuring that there's training incorporated in rheumatic diseases, and so on. So the more or less the same concepts that we discussed before. Now that we know that importance of transition, or all have all these recommendations, let's go back and see how are the different pediatric rheumatology centers around the world are doing when it comes to transition. So this is a study that came in 2017, where there were 115 centers that responded from 22 European countries. And you can see the transitional process, it hasn't been that great, and there's definitely a great room of improvement. A designated coordinator was only identified in 64%. They only have used transitional policy in about a quarter of those centers. A transitional checklist was done at 36%, and a validated assessment tool was used in less than 10%, and only 7.6 actuals had some sort of funding or reimbursement. Now, if we look at CARA, comparing North America versus Europe, once again, you see the CARA study in light gray showed they're not doing much better than Europe when it comes to transition and process. And certainly there's great room of improvement. Now we'll look at the gaps and barriers. Definitely gaps has been identified both in North America and Europe, with having saying that we are successful in transition in those regions of the world in less than 50%, despite all the efforts that they're putting. And there's certainly great barriers. And some of the barriers include limited physician knowledge as well as training, limited resources, which include time, funding, and services. And let's face it, separation anxiety, both from the patient, parents, and us pediatric rheumatologists. So we can think actually of transitional process as a structured and planned movement. We do not want it to be a leap of faith that the patient jumps to the other side and hope that it goes well. In fact, we want them to gradually gain independence in self-management, and both ends are comfortable in letting go. So we can conclude by saying that all youth requires transitional support. In the process, we should have the quadruple aim in mind, meaning we need to have the best possible healthcare outcomes, in addition to the best patient as well as workforce experience, and using the utilization of our resources. It's a dual partnership, the push and the pull between pediatric and adult care providers. We aim to remove the gaps and barriers. And in addition to that, because in the Arab world, we're very culturally different than different parts of the world, we need to develop our own local consensus, healthcare transitional guidelines, and ensuring that we incorporate within it outcome measures. And with that, I would like to thank you, and I hope to see you all soon, one day, hopefully. With that, I'll thank you very much.
Thank you, Dr. Reem, for this comprehensive, informative talk. Now, I'm pleased to present Dr. Alrumitha Al-Sabri. She is a second-year pediatric resident in Oman Medical Specialty Board. This is a great chance to have a resident to participate in our activity. Dr. Alrumitha will talk about transition, readiness in adolescents and young adults with chronic rheumatic disease in Oman, today's needs and future challenges. Dr. Alrumitha.
Good morning, everyone. It's my pleasure to present our abstract in the second GCC Rheumatology Conference. This is Alrumitha Al-Sabri, a second-year pediatric resident in OMSB. So I'll be presenting about transition readiness in adolescents and young adults with a chronic rheumatic disease in Oman, talking about today's needs and future challenges. So healthcare transition is a purposeful and planned movement of patients with chronic medical conditions to the adult-oriented healthcare system. Transition of care focuses on medical, psychological, and educational, and also vocational needs of adolescents. This is in contrast to transfer, which is only an event that occurs at a specific time rather than a process. So the American Academy of Pediatrics has proposed the guidelines on transition process that has 6 core elements that happens over 10 years. In Oman, the transfer of healthcare of adolescents and young adults happens rather than transition at a very early age of 12 to 13 years without the necessary healthcare transition process. And adolescents actually make up more than 25% of the population of the Gulf Cooperation Council. That's why an inappropriate transitional process can indirectly affect adolescents and young adults and their outcomes of their chronic diseases, which might put a significant burden on the countries. And around 50% of adolescents and young adults with chronic rheumatic diseases show a disease flare within just 1 year of transitioning. And unfortunately, young adults with rheumatic disease are less likely to have college education or to maintain employment, and they tend to have lower income than their peers. So our study aims to determine the transition readiness skills of adolescents and young adults with childhood onset rheumatic disease using a cross-cultural adaptation of the UNC transition scale. We included Omani adolescents and young adults from Sultan Qaboos University Hospital and the Royal Hospital between 10 to 21 years of age, those who were diagnosed with chronic rheumatic conditions for at least 1 year. We excluded patients who were having major cognitive disorders or any comorbidities that may interfere with their future self-management of their health. We used the UNC transition scales, which is a reliable and validated tool in assessing patients' readiness for transition. This scale has 32 questions, which are distributed under 10 domains. It is administered by a trained healthcare provider, offering many advantages, as it does not only depend on the patient's self-reporting, and it gives the healthcare provider the chance to assess the patient's response and to assess its validity. It also gives a feedback approach where the healthcare provider can praise the adolescents and young adults on the skills that they masters and to help them improve on skills that they have low competencies in. The original English scale of the UNC transition has been cross-translated with the established method of backward and forward translation, where 4 translators translated it to English, to Arabic, then to English, and a committee of Arabic researchers have reviewed it, making the first draft. Then 3 pediatricians and 2 physicians have reviewed it, making minor changes, and the second draft has been made. A pre-testing have been done on 10 healthy children, 6 males and 4 females, and it shows that it is well understood, and it took approximately of 20 minutes to be interviewed. This is the original English UNC transition scale showing the 10 domains. So it assesses the patient's knowledge on type of chronic health condition, on their medication they are taking, on their skills on adherence, on their knowledge about nutrition, and their self-management skills. Issue of reproduction was only asked to those who were 16 years of age and above who were married, and this was actually culturally adapted. We asked them about their trade and school, knowledge about insurance, ongoing support, and new healthcare providers. This is the Arabic version of the scale. Actually, each question in the scale is scored as follows, either 0, 0.5, or 1. 0 indicates no knowledge or self-management, and 0.5 is some knowledge or self-management, and 1 points for a complete knowledge and self-management. The transition readiness assessment score were categorized into 3 categories: low, moderate, and high. Low was from 0 to below 4, and moderate from 4 to 7, and high more than 7 to 10. Our research had 81 patients that they were categorized into 4 groups according to the ages. So a younger age group from 10 to 13 years of age, 14 to 18 years of age, and the older age group from 19 to 21 years. we have analyzed our data using the SPSS software, and we used multiple tests to analyze the data, as you can see here. Now showing the results of our data. Here is a table that is showing the socio-demographic of the adolescents and young adults with chronic rheumatic diseases. Our data, 79% of them were female. And you can see here we had almost equal number of patients in each age groups. Majority of the patients were from Muscat, accounting 33% of them, following by Al-Sharqiyya and Al-Batina. Then for further educational level, 41% of them were having college and higher education level, and 68% of them were employed. For mother educational level, 28% of them were having college and higher education level, and 21% of them were employed. In this figure, we are showing the mean UNC transition scale in 10 subdomains. As you can see, patients have scored higher score in medication, in skills of adherence, in trade and school, and in the ongoing support. But they showed low score in nutrition, issues of reproduction, and insurance. In this graph, we are showing the mean transitional index score in different age groups. The mean of our sample was, the grand mean was 5.22. Then the current age of transfer in Oman, which is 13 years of age, patients actually scored a low score, 4.07, which is considered a low score. But then also the patients in the older group scored only 6.12, which is a moderate score. But then you can notice that there is a linear increase in the mean score of transition as the age increases. Then in this table, we are showing the transitional readiness index score in different categories and in different ages. As you can see, majority of our patients got a medium score. And only 14.8% of them had a high score, and most of the patients who got high score were from the elder group. And in the current age of transition in Oman, majority were low and medium score. Low score of 46% and medium score of 50%. In this table, we are showing the mean transitional index score among different age groups. And you can see the significant statistical data was observed in the types of illness, self-management skills, informed reproduction issues, and new healthcare providers. Here we're showing the significant domains that showed significant correlations in different age groups. As you can see, issue of reproduction and issues of insurance got very low scores. And this can be explained by that children and Omanis, they are getting treated free in the governmental institutes. This might explain why children did not know about insurance. And issue of reproduction was only asked to those who were 16 years of age and those who and above, and those who were married. In conclusion, our study and our results reflects that our adolescents and young adult patients are not adequately prepared for the transfer to adult healthcare at the current cut-off age of 13 years. And we need to increase the transfer age to 18 and 21 years, as evidenced by the results of our study, and in keeping per the international recommendations. The lack of transition care services is a global challenge, and it is not only limited to our region of the world. And we emphasize the need to initiate healthcare transitional services for adolescents and young adults within our country. And further educational measures should be taken at an earlier age are needed to improve the transitional process in Oman. And also, there is a dire need to prioritize the adolescent healthcare practice, clinical education, and researches within the GCC by initiating regional guidelines. Thank you.
I'd like to present now Dr. Banan. Dr. Banan is a pediatric rheumatology consultant in King Salman Medical City in Medina. She's also a Deputy of Pediatric Department, the Ministry of Health, member of Saudi Society of Rheumatology, and also Saudi Rheumatology Fellowship from King Abdullah Specialized Children's Hospital. Welcome, Dr. Banan. You can start your presentation.
Good morning. I would like to thank organizing committee and Dr. Reem for inviting me for this conference and giving me the opportunity to present the talk about TMJ arthritis in GIA. No conflict of interest to disclose. The content, I will start by case, definition of TMJ arthritis, epidemiology, clinical manifestation, diagnosis, management and outcome, literature review. This is 10 years old Saudi girl referred to my clinic from dentist with TMJ arthritis. The diagnosis of polyarticular GIA rheumatoid factor negative was made with TMJ involvement. She suffered for a long time, 1 year before the coming to my clinic. Now she is on Humira methotrexate showing good response. She is on remission on medication. The definition, TMJ arthritis, inflammation of temporomandibular joint. As in this picture, temporomandibular joint is synovial condyle joint, hinge type with fibrocartilaginous surface and articular disc. It is one of the most complex function. It receives less attention. Involvement of TMJ varies according to the subtype of the GIA, and arthritis is the one of most undiagnosed joint, could be result on permanent function and cosmetic complication. Regarding epidemiology, this is one study in USA, estimate TMJ involvement in GIA range from 17% to 87% due to variation in examination method. Also, they formerly known as forgetting joint reported involve around half of the children with GIA. The most common type of GIA TMJ involvement was found to be polyarticular GIA rheumatoid factor negative in 25 of the cases, and the least type, it was psoriatic arthritis, only 5% of the cases. This is another study from Switzerland. They mentioned 223 patients, and 39% they have TMJ involvement, mainly 75 were female. The most common extended oligo and the least is enthesitis-related arthritis. In this table, they show 86, they have radiological criteria only fit for it, and only 11% they have clinical criteria only, about 13%. This study, another study from USA, they involved 11 reported lower frequency of TMJ involvement among category, only 10% from 60 patients. Majority were also female, and in this study, poly-RF negative more common by 32%, and less common type is psoriatic arthritis and undifferentiation went by 3%. About the risk factor, female, white, RF negative, HLA-B27 negative, ANA negative, poly-RF negative subtype, also the involvement of the other joint making higher risk to be involved TMJ. This study from European country between Norway, Italy, and the UK, 387 children with clinical TMJ involvement, about 11.6 of the entire cohort. They show unilateral involvement in 19.4, about 80.6%. The clinical manifestation, the patient usually present with pain, restricted joint movement, or lifting of the jaw, jaw tenderness, morning stiffness, clicking or crepitus abnormal sound, difficulty in chewing, facial and ear pain, tinnitus, headache, and tooth pain. In GIA patient, usually acute TMJ arthritis, up to 71% case may be asymptomatic, and sometimes about 63% normal finding even in clinical examination. This was evaluated 32 newly diagnosed patients. They have TMJ pain and dysfunction only sensitive in 26%, and abnormal physical examination findings suggest TMJ, but their absence is not reassuring. Regarding physical exam maneuver, this is from Cause et al. They depend on 5 maneuver: asymmetrical mouth opening, pain on palpation on masticatory muscle, pain on palpation of TMJ and TMJ clicking, reduce maximum incisor opening. Sensitivity of individual item is different. One from 21%, the other is higher, 65% as asymmetrical opening, combined between two, making the sensitivity higher. In this study from US reported combination of abnormal MIO for age and jaw deviation have a positive predictive value about 100% in long-standing GAA, but no single exam finding could be correlated with MRI finding. In this picture, I have two cases from Denmark, both of them GIA patient. First one is 12 years old and the second one is 14 years old. Both of them, they have severely affected bilaterally TMJ, showing in both radiologically and also in the clinically and picture, they show bird face appearance, which is due to micrognathia, retrognathia, and delay and untreated GIA. This is the worst outcome. In examination, we start by inspection, clicking upon mouth opening, asymmetrical mouth opening, and jaw deviation, as in the picture, and direct palpation to TMJ while rest and while movement. Palpation of the muscle, temporalis and masseter muscle. Also maximum incisor opening measurement, usually by ask the child to introduce 3 middle finger to their mouth, or we have measuring while opening and while maximum mouth opening. Also, we can use disposable terabyte scale Atos Medical for TMJ. It is available for sale and too easy to use. In physical examination, need enough cooperative child to examine and use the measure which I mentioned before. Decreased MIO is likely indicate for TMJ arthritis. The smallest detectable difference in MIO was reported just under 0.5 cm. Clinical examination items protocol, this is from European country. They depend on TMJ palpation while closed mouth and also while open mouth, maximum capacity, assessment of facial symmetry, and assessment for facial profile convexity. As here in the picture, while opening, while MIO, also the facial symmetrical and convexity of the face. Then we're going to radiological assessment. Usually they start by X-ray, panorama view X-ray and lateral cephalogram. Also CT 3D, as in this picture, showing right TMJ involvement. MRI, it is a gold standard for diagnosis, and in this picture, the first one, there is right TMJ involvement, T1 coronal section. They found synovitis and synovial enhancement. The left one, normal TMJ. The other picture, this patient, they have bilateral TMJ synovitis with flattening of the condyle. The diagnosis usually, as I mentioned, by gold standard MRI. What is we found in the MRI? Active arthritis by effusion, bone marrow edema, and contrast enhancement. The sequelae of arthritis, they show shape change of the condyle, also shape change of the disc, and Banus formation, osteophyte formation. Usually in they show acute arthritis if there is synovial fluid or tissue enhancement. In the absence of TMJ arthritis in MRI, patient may still have TMJ involvement. We call it clinical TMJ arthritis. The MRI assessing articular disc, synovial, joint space, bone marrow, and surrounding musculature. Sign and symptoms, the most indicated for disease activity. Indon study from Switzerland show 100% of control patient with joint effusion on MRI had pain, while 0% of GIA patient, they have effusion without pain. This flow chart, they show if when I have to do MRI for the patient, no history of TMJ arthritis, so every time I will do examination for my patient. Then anytime I need the imaging, I will do it. If there is a history of TMJ arthritis, recent change in medication, I will do examination every time, and I will consider MRI every 6 months. If there is recent change and no recent change in medication. So I will do physical every time and consider every 12 months the MRI. This is if stable, no active arthritis. Any change, any complaint, I will do imaging. What about the management? The management is a multidisciplinary team, depend on pediatric rheumatologist, physiotherapist, orthodontist, oromaxillosurgeon, and radiologist and dentist. What is the goal for them? To treat and prevent progression of condyle damage and dentofacial deformity, to decrease orofacial symptoms as pain, prevent progression, and reverse orofacial dysfunction. So that is the goal. What is the category to start management? Reducing TMJ inflammation by systemic intra-articular steroid or articular medication, control signs and symptoms as oral splint, physiotherapy, adjacent systemic treatment, normalize mandibular growth as oral splint, need of surgical correction or facial deformity in skeletal mature patient. This is one study recently published last year, 2021, Comprehensive Management of Rheumatic Disease Affecting Temporomandibular Joint in USA involving the GIA patient. And this is another study published 2020, GIA, the GIA and temporomandibular joint diagnostic challenge and treatment option. We start by management and outcome, as I mentioned, intra-articular steroid injection. A lot of study done to local therapy for TMJ arthritis. They did a lot of the study. There is improvement, decreasing in pain, increase in MIO, but the safety profile, not that good, even in immature skeletal as in children. They have subcutaneous atrophy. They have sometimes of the patient, they have fever and localized swelling. And also some of the patients, they have decreased growth of mandible ramus and also transient subcutaneous atrophy and other abnormality reported. So the current recommendation not to use intra-articular corticosteroid for the management of TMJ arthritis and especially not repeated in skeletally immature patients. Intra-articular heterotropic bone formation has been associated with the injection, especially if used recurrent throughout the disease course. So the management initially of none of minimally invasion treatment, conventionally biologically demarred adjacent and intra-articular may be delay further joint destruction. The demarred and biological are used for treatment of GI-associated TMJ arthritis. Still, the exact effect not remain unanswered in the study. Earlier initiation of treatments is believed to be better. There is Swiss study show improvement on TMJ on systemic management. This is acrylic splint, also used to prevent, decrease the pain and prevent dentofacial deformity from TMJ in the children. So the management and will reach lastly for the surgery, maxillofacial surgery for severely affected patient, either function or cosmetic reason. With biological era, no more complication and severe growth retardation or need for surgery, even bird face appearance or respiratory compromise during sleep as before. Maxillofacial surgical option, orthognathic surgery, destruction osteogenesis, and TMJ reconstruction. This is the flow chart. They show MRI result and what is the action we have to do it. If normal, repeat if clinically indicated. If borderline, repeat if 1 year sooner if clinically indicated. If active and no damage, maximize the systemic therapy and repeat after 3 to 6 months. If stable, repeat annually. If there is active and damage, we have to give intra-articular corticosteroid and maximize the systemic and repeat every 3 months. If no improvement, consider repeat intra-articular corticosteroid. If no improvement on all this medication, we have to refer to maxillofacial and surgery. So the management summarizes the management should receive systemic treatment, skeletally mature patient should receive intra-articular corticosteroid and can treat with orthopedic device and physiotherapy. In extreme cases, need surgical intervention. Regarding our local experience, we have our study, temporomandibular joint involvement in children with GIA idiopathic arthritis. The study done in Saudi Arabia. It will be explained by Dr. Jubran later. In conclusion, TMJ arthritis occur frequently and can have devastating impact in function, facial growth, and development. Diagnosis need for MRI to initiate diagnosis and management. outcome improve with early diagnosis and initially of treatment, improve oral, maxillofacial, and quality of life for our patient. Need rheumatologists to be aware of potential involvement of TMJ, monitoring TMJ during each clinic visit through a standardized clinical examination is necessary. Thank you for your attention, and all questions are welcome.
Thank you very much. We are going to now for lunch break and prayer. We'll be coming back, inshallah, at 1:30 Omani time. And question and answer will be later. Thank you.
In the last few decades, there have been major advances in the understanding of the causes and development of spondyloarthropathies. A key element of this has been the recognition that enthesitis may be considered the primary pathological process underlying SPA-associated skeletal inflammation. Previous studies in PSA patients have identified risk factors for developing enthesitis to be high body mass, more active joint disease, and young age. This association between young age and enthesitis observed in PSA patients may be due to mechanical load being a trigger for enthesial inflammation, as physical activity is usually higher in younger individuals. It is likely that the overall burden of enthesitis may be higher than clinically estimated, primarily due to there being more enthesial sites than those assessed in standard clinical examinations. We also know that the application of imaging techniques yields a substantially higher prevalence of enthesitis than palpation. Enthesial pain can be disabling, and the management of enthesitis is still seen as a challenge for rheumatologists. The HEAL trial was the first randomized, placebo-controlled, multi-center study of an anti-TNF agent for the treatment of patients with SPA with refractory heel enthesitis to show significant clinical benefits. In this trial, patients receiving Enbrel had significantly greater improvement in the PGA of heel enthesopathy activity versus placebo, with a significant change from baseline beginning at week 8. Patients also experienced an improvement in heel pain and lower limb function. These results suggest that Enbrel could be of significant benefit to patients with SPA suffering with heel enthesitis.
Tremfya is a human immunoglobulin G1 gamma monoclonal antibody that binds selectively to the P19 subunit of IL-23 with high specificity and affinity. IL-23, a regulatory cytokine, affects the differentiation, expansion, and survival of Th17 cells and innate immune cell subsets, which are sources of effector cytokines, including TNF-alpha, IL-17A, IL-17F, and IL-22 that drive inflammatory disease. Tremfya inhibits the bioactivity of IL-23 by blocking its interaction with the cell surface IL-23 receptor, disrupting IL-23-mediated cell signaling and activation, as well as downstream cytokine cascades. This regulates the production of effector cytokines, decreasing lesion levels of IL-17 and TNF-alpha, downregulating T cells, resulting in controlled inflammation. This is how Tremfya exerts its clinical effects in psoriatic arthritis and psoriasis, improving joint and axial symptoms, enthesitis and dactylitis, as well as providing sustained skin clearance. Additionally, the mechanism of action of Tremfya is not expected to block effector cytokine functions and hence decrease the chance of adverse events such as IBD and opportunistic infections. Tremfya is the first and only IL-23 P19 for PSO and PSA. Tremfya acts to restore homeostasis of the immune response and provides control of inflammation and symptom improvement. Tremfya offers an effective treatment across PSA domains, a favorable safety, tolerability profile, and the convenience of infrequent dosing. Inhibition of the master cytokine IL-23 with Tremfya regulates inflammation in PSA and PSO and results in sustained improvement of enthesitis, dactylitis, and joint symptoms versus placebo, so patients can keep moving, combined with proven skin clearance for confidence that keeps going, helping patients to get back to their lives with fewer interruptions, take part in activities with less burden of joint pain and skin manifestations, knowing that their disease is under control, not only their symptoms. giving patients the possibility to go out and seize the day, no matter the weather. This resolution of joint and skin symptoms brings impactful improvements to patients' quality of life. Inhibiting IL-23 with Tremfya helps keep the master cytokine of psoriatic arthritis and psoriasis under effective control for a life that's non-stop. Tremfya is a human immunoglobulin G1 gamma monoclonal antibody that binds selectively to the P19 subunit of IL-23 with high specificity and affinity. IL-23, a regulatory cytokine, affects the differentiation, expansion, and survival of Th17 cells and innate immune cell subsets, which are sources of effector cytokines, including TNF-alpha, IL-17A, IL-17F, and IL-22 that drive inflammatory disease. Tremfya inhibits the bioactivity of IL-23 by blocking its interaction with the cell surface IL-23 receptor, disrupting IL-23-mediated cell signaling and activation, as well as downstream cytokine cascades. This regulates the production of effector cytokines, decreasing lesion levels of IL-17 and TNF-alpha, downregulating T cells, resulting in controlled inflammation. This is how Tremfya exerts its clinical effects in psoriatic arthritis and psoriasis, improving joint and axial symptoms, enthesitis and dactylitis, as well as providing sustained skin clearance. Additionally, the mechanism of action of Tremfya is not expected to block effector cytokine functions and hence decrease the chance of adverse events such as IBD and opportunistic infections. Tremfya is the first and only IL-23 P19 for PSO and PSA. Tremfya acts to restore homeostasis of the immune response and provides control of inflammation and symptom improvement. Tremfya offers an effective treatment across PSA domains, a favorable safety, tolerability profile, and the convenience of infrequent dosing. Inhibition of the master cytokine IL-23 with Tremfya regulates inflammation in PSA and PSO and results in sustained improvement of enthesitis, dactylitis, and joint symptoms versus placebo, so patients can keep moving, combined with proven skin clearance for confidence that keeps going, helping patients to get back to their lives with fewer interruptions, take part in activities with less burden of joint pain and skin manifestations, knowing that their disease is under control, not only their symptoms, giving patients the possibility to go out and seize the day, no matter the weather. This resolution of joint and skin symptoms brings impactful improvements to patients' quality of life. Inhibiting IL-23 with Tremfya helps keep the master cytokine of psoriatic arthritis and psoriasis under effective control for a life that's non-stop.
In the last few decades, there have been major advances in the understanding of the causes and development of spondyloarthropathies. A key element of this has been the recognition that enthesitis may be considered the primary pathological process underlying SPA-associated skeletal inflammation. Previous studies in PSA patients have identified risk factors for developing enthesitis to be high body mass, more active joint disease, and young age. This association between young age and enthesitis observed in PSA patients may be due to mechanical load being a trigger for enthesial inflammation, as physical activity is usually higher in younger individuals. It is likely that the overall burden of enthesitis may be higher than clinically estimated, primarily due to there being more enthesial sites than those assessed in standard clinical examinations. We also know that the application of imaging techniques yields a substantially higher prevalence of enthesitis than palpation. Enthesial pain can be disabling, and the management of enthesitis is still seen as a challenge for rheumatologists. The HEAL trial was the first randomized, placebo-controlled, multi-center study of an anti-TNF agent for the treatment of patients with SPA with refractory HEAL enthesitis to show significant clinical benefits. In this trial, patients receiving Enbrel had significantly greater improvement in the PGA of HEAL enthesopathy activity versus placebo, with a significant change from baseline beginning at week 8. Patients also experienced an improvement in heel pain and lower limb function. These results suggest that Enbrel could be of significant benefit to patients with SPA suffering with heel enthesitis.
This is Noah. He is 22 years old law student who loves to play soccer and hang out with his friends. In the past few months, Noah has been feeling pain in his back and left and right buttocks, along with stiffness in his low back. The doctor diagnosed him with ankylosing spondylitis based on radiographic evidence of sacroiliitis. Noah started treatment with non-steroidal anti-inflammatory drugs, which partially reduced symptoms during the first month. In the past weeks, however, his back pain is as severe as it was at the beginning, and it's affecting his performance at school. But there is still a chance for Noah to live a normal and healthy life with Symphony. Symphony has shown a good long-term efficacy profile in patients with ankylosing spondylitis and insufficient response to non-steroidal anti-inflammatory drugs. 57% of patients with active ankylosing spondylitis maintain assessment in Spondyloarthritis International Society 40% respond to over 5 years of treatment with Symphony. 34% of patients with active ankylosing spondylitis meet and maintain ankylosing spondylitis disease activity score, partial remission. Over 104 weeks, 2 years of treatment with Symphony. Trust Symphony for a better quality of life for your patients.
Assalamu alaikum wa rahmatullahi wa barakatuh. Welcome back. I hope you had a good lunch. Now we're going to, for the second part of this talk, it's going to be presented by Dr. Jubran. It's about TMG in children with the GIA. Dr. Jubran is a consultant. Dr. Jubran is a consultant pediatric rheumatologist in King Abdullah Specialized Children's Hospital in in Saudi Arabia. Is also a clinical lead in developmental of child care as part of the strategic plan. The chairman department of pediatric King Abdullah Specialized Children's Hospital. Dr. Jubran, the mic is with yours.
Hello, everybody. Good morning. I'd like to thank the scientific committee for inviting me to present our experience regarding temporomandibular joint involvement in children with juvenile idiopathic arthritis, a single center experience from Saudi Arabia. This is the outline of my presentations. As you know, juvenile idiopathic arthritis is the most common chronic inflammatory arthritis in children. It's a heterogeneous group of disease that's classified by EULAR across 7 subtypes, and we know that the heterogeneity is also among each subtypes of them. Children diagnosed with juvenile idiopathic arthritis often develop inflammations of temporomandibular joint. And temporomandibular joint is a very complex joint that's responsible for movement of the jaw in over different planes. And diagnosis of TMJ involvement in children with JIA remains difficult. Thereby, would be beneficial to know or to be able to identify the children who's at higher risk of developing TMJ arthritis. Prevalence of TMJ arthritis in children with JIA was estimated in the previous study from 17 to 87% due to variation in assessment tool and examination methods. There were two local studies from Saudi Arabia, one old in 1997 by Dr. Sultan Bahabri and his colleagues, which described the clinical laboratory manifestations of 115 patients diagnosed with JIA. Another study in 2016 by Dr. Hameri and his colleagues that described 82 patients with JIA, and none of these studies came across TMJ involvement in, or described the TMJ involvement in JIA cases. In the state, among 330 JIA patients, 6 patients only had evidence of synovitis or degenerative changes over TMJ and diagnosed with TMJ arthritis. It was found that the mostly affected patients were female, Caucasian, HLA-B27 negative, ANA negative, rheumatoid factor negative subtype was the most category of the disease that's been affected with TMJ involvement, and the patient who have multiple joint arthritis as well. So the rationale of this study, we're knowing that arthritis of TMJ is the least diagnosed joint in children with JIA, and also TMJ arthritis, if left untreated, may result in mandibular growth limitations, cause jaw asymmetry and malocclusions, limited maximal mouth opening. Since the frequency of TMJ involvement among the different EULAR criteria categories of JIA patient in the local studies is yet to be determined, we thought that we need to describe the clinical laboratory characteristics, state the treatment and outcome of patients with juvenile idiopathic arthritis who have TMJ involvement. So the objective of our study was to determine the frequency of TMJ involvement and to define the most common type of JIA associated with this condition, and to identify the possible risk factors, as well as to describe the treatment and outcome of TMJ arthritis. This study was conducted at King Abdullah Specialized Children's Hospital, which is a tertiary hospital located in Riyadh, constitute of 300 beds for children, and the service have 3 pediatric rheumatologists. The study design was a retrospective study, so since we are providing descriptive analysis, we didn't need to have estimations of the sample size, as we conclude all patients that been diagnosed between 2015 and 2019. and diagnosed with juvenile idiopathic arthritis. We are lucky to have electronic medical records called Best Care, which include the clinical data, laboratory, and imaging of the patients in one platform. So we utilize the EULAR criteria to include the subject with JIA, where the subject diagnosed with TMJ arthritis were based on either clinical musculoskeletal examinations or using contrast-enhanced MRI. All patients should have no less than 2 clinic visits to be enrolled in the study. And this study received IRP approval from KMark. The result of our study, we found that we have 123 subjects diagnosed with juvenile idiopathic arthritis during the study period. Mostly were female, 57%, and cases were splitted across all the categories of juvenile idiopathic arthritis, and surprisingly, the 36% of them were oligoarticular JIA, and the least subtypes was undifferentiated arthritis. 20% of those 20 cases of those 123 patients were diagnosed with TMJ involvement, and 70% again were female. Polyarticular JIA was 45% of those cases, 15% was systemic onset JIA, and none of them were undifferentiated JIA. ANA was positive in 45% of the cases, 25% was rheumatoid factor positive, and HLA-B27 was negative in all the cases with TMJ involvement. We found that all patients had been treated with biologic therapy, which may indicate that TMJ involvement happened in those patients who will have a severe course of the JIA disease. And also contrast-enhanced MRI was done in 11 out of 20 patients. The main reason for not to do it in the rest of the patient was parenteral refusal due to general anesthesia. Worth mentioning that mean age for our group was 13.5 years of age, which is at the diagnosis of JIA, and 11 plus minus 4 for the diagnosis of TMJ arthritis. The diagnosis of TMJ arthritis clinically was based on pain in 80%, a click in 15%, tenderness in 25%, deviation of the mandible in 55%, and the contrast-enhanced MRI was positive in 35% of the cases, and 50% of the cases were found to have bilateral disease. The rate of TMJ involvement in our cohort was 16%, and lower than this rate has been reported in previous literatures. Lower than the rate that's been reported in previous literatures. However, as I mentioned earlier, in previous studies, estimations of TMJ involvement has been ranging from 17% to 87% due to variations of using assessment tool and examination method that's been used. 45% of our TMJ cohort was polyarticular JIA. In addition, that our study showed that 15% of TMJ cohort was systemic onset JIA. Higher and lower percentage has been previously reported. And we found 50% of the patients, as I mentioned, have bilateral disease, and mostly those patients will have polyarticular subtype. Ibrahimovic et al. Reported a lower frequency of TMJ involvement among JIA categories in only 10% of 60 symptomatic patients, and the majority of them were females. Polyarticular rheumatoid factor negative was reported in the same study. 32% have TMJ involvement, and also the least subtypes that's been reported with TMJ involvement in Ibrahimovic study was psoriatic and undifferentiated arthritis. This finding was in agreement with our cohort finding. As I mentioned earlier, the clinical diagnosis was varying from pain, clicks, tenderness, and deviation of the mandible. However, from the literatures, we know that clinical examination or self-reported finding only provide a poor performance of TMJ arthritis diagnosis. Therefore, the possibility of detecting real TMJ arthritis is improved by combination of physical examinations and the use of imaging. Canizar et al. In cohort of 223 JIA cases, HLA-B27 was positive in only 3% of them, in those patients who have TMJ, and was also positive in 18% in the same study that I presented earlier by Ibrahimovic. So the finding is inconsistent with our finding, knowing that all patients who have TMJ involvement in our cohort was HLA-B20 negative. But again, we know that the prevalence of HLA-B27 in Saudi populations is low, as been documented using the cord blood and healthy organ transplant donor database in previous studies. So the limitations of our study, as any retrospective study, you may have that limitations. However, we are fortunate to have electronic medical records to overcome of these some of these challenging and missing data. And the other source of bias is having the experience of musculoskeletal radiologists and clinical physicians who's examining the TMJ. And I think to some extent we are overcoming this as well, because we have expert musculoskeletal radiologists and we have a certified pediatric rheumatologist who's examining these cases. It's possible if MRI was performed in all subjects in our JIA cohort, including asymptomatic patient, we may identify additional cases. Given the risk of general anesthesia, some of the parents had understandably refusing the MRI for their children, and the mouth opening assessment was not done objectively in all the cases. To conclude, TMJ involvement can occur in all subtypes of JIA. And in our cohort, 16% of JIA patients were diagnosed with TMJ arthritis. Females with polyarticular rheumatoid factor subtypes and HLA-B27 are at more risk of developing TMJ arthritis in our populations. So we recommend that careful assessment of TMJ arthritis, early treatment are required in all JIA subjects, particularly those patients with higher risk, being female polyarticular subtypes, as well as HLA-B27 negative. Pediatric rheumatologists need to provide also sufficient information for children and their parents performing MRI under general anesthesia to make sure that we include all the patients who need these studies. We are fortunate enough to have this study being published in Saudi Medical Journal. I'd like to provide some references for people who need to read more about the subject if they scan this QR. And also I'd like to acknowledge the effort of my colleagues in these papers, Dr. Aswari, Dr. Abdurrahman Rashid, as well as our former fellows, Dr. Banan Ruwaiti, who presented the topic of TMJ earlier this morning. Thank you so much, and I'll be happy to take any questions. And I would like also to declare that we have no conflict of interest of this work. Thank you.
The next presentation will be about the similarity and variability between patients with the GIA among the GCC country, and this will be presented by Dr. Fatma. Dr. Fatma is a second-year pediatric rheumatology fellow at King Faisal Specialist Hospital and Research Center in Riyadh. She graduated from King Faisal University, and she obtained her Saudi board in 2019. Okay, so Dr. Fatma, go ahead with the presentation.
Assalamu alaikum and good morning all. First, I would like to tell you that I'm so thankful for this great introduction. It's my pleasure today to presenting our paper regarding the demographic similarity and variability in between the patient with GIA and GCC countries. Actually, I don't have any disclosure regarding this study. And as you know, the GIA is the most common chronic childhood rheumatic disease. It's had a heterogeneous clinical presentation and course, and it's a primary affect the musculoskeletal system, but also may impact the growth and vision too. It also had a distinct epidemiological presentation, disease pathogenesis, and genetic background. The prevalence, incidence, severity, and outcome of the disease are different among the ethnic group and vary greatly among the published data. The available published data over the last 30 years from Arabic country about GIA incidence and prevalence remain limited. And the most of this clinical study from Arabic country were retrospective single-centered, and just interestingly, the most of these data originated from the GCC countries. And just recently, at December 2021, a new study published regarding the epidemiology and demographics of GIA in Africa and Middle East. But why we choose to focus on GCC countries? We choose that just because they share the common features of ethnic background, high consanguinity rates, and also they have the availability of health services like diagnostic and therapeutic resources are comparable. So our objective was to highlighting the demographic similarity and variability between a patient with GIA across GCC countries. So in our research strategies, we conducting an electronic search using PubMed and Google Scholar from January 1988 till October 2021, using the following image term: GIA, GRA, GCA, or childhood arthritis, as a complete word and as abbreviation, and using geographic filters for the Arabic Gulf country like GIA in Oman, GIA in Bahrain, and etc. Our inclusion criteria was for any children had diagnosis of GIA based on EULAR criteria or ACR criteria for GIA. Take in consideration that all included patients must be citizen of the GCC countries or residing in these countries. Articles describe a different type of arthritis or arthropathy were excluded. Also, single case report, editorial, letter to editor, or articles with insufficient data were excluded too. To avoid any duplication, reports of similar data from the same center were not included, and the only English medical literature were reviewed. This is the flowchart. This is the flowchart for the data selection, as 53 articles were identified. The articles that have irrelevant information, which was 19 articles, were excluded. So the 34 articles only remained, at which we exclude further 27 articles because either it's only cases reports or had a duplication or insufficient data. So finally, we remained with only 7 retrospective studies. Unfortunately, we couldn't find any published data from Bahrain or Qatar, so we remained with only with KSA, Kuwait, UAE, and Oman. Here, the extracted data highlighting with a red square. Also, as you see here, we gathered the data of familial GIA too. The relevant laboratory data like ANA, RF, NTCCB, and HLA-B27 were also collected. Statistical analysis, the continuous variable were reported as a mean plus minus standard deviation, and the categorical variable were summarized as frequencies and percentages. So, as a result, the 757 patients were collected, and the mean age was almost 10 plus minus 4.6 standard deviation, were all these reported from the 4 different GCC countries. There is two studies, one from Kuwait, another from Oman, identified the estimated prevalence rate, which is nearly 20 per 100,000. There was a female predominance counting for approximately 62.1%, and the highest female to male ratio was from Oman with 3.6 to 1. The mean age at onset of GIA manifestation was 6.3 plus minus 3.9 years. And the mean disease duration was 4.3 plus minus 4.4 years. The 32 out of 377 patients, as we don't have any available data for the other patients, had a positive family history of GIA. And interestingly, the Oman cohort showed that the highest frequency with 9.8% of affected siblings with GIA. The most frequent GIA subtype were oligoarticular GIA, which followed with polyarticular with marginal RF negative polyarticular GIA predominance, which both had the highest female to male ratio compared to other subtype. The psoriatic arthritis, ERA, and undifferentiated GIA were the least reported GIA subtype throughout the cohorts. 38 patients had a uveitis during their disease course, mostly in oligoarticular category. There are 149 positive ANA in tested patients. In contrast to RF and anti-CCB were detected in 21% and 10.5% respectively, while HLA-B27 was positive in 5.3% of attested GIA patients. And in general, the patient from Saudi Arabia had the highest frequency of autoantibodies, while the patient from UAE showed the lowest frequency of these antibodies. According to the disease distribution, oligoarticular GIA was most prevalent in UAE and Omani cohorts. And just in contrast to systemic GIA was more prevalent in Saudi and Kuwaiti cohorts. And interestingly, the systemic GIA was only in 10% of the UAE patients. And furthermore, there is one study from Kuwait reporting the predominance of RF positive polyarticular GIA as comparing to other cohorts. So, and just at the end, the precise comparison and interpretation between these different cohorts was challenging, just because of paucity of adequate studies, the heterogeneity of available data, as well as the time span of this study was varied. And as some studies were conducted as long time ago. So in conclusion, our finding estimates the number of the children affected by GIA in GCC countries and showed a demographic similarity between these patients. However, the more studies are needed to address the incidence, prevalence, and the true burden of this disease in GCC countries. And just lastly, our future direction is to generate more study addressing the disease subtype and course medication use, long-term outcome of GIA in GCC countries. This is all what I have, and thank you.
The next topic will be presented by our pediatric resident from Saudi Arabia. I'm glad to see our residents have been given a chance to present their study in this conference. So Dr. Bashair is a pediatric resident R4 at King Faisal Specialist Hospital and Research Center in Riyadh. Go ahead, Dr. Bashair.
Good morning, everyone. This is Bashar Al-Nazi speaking. I'm a pediatric resident in my 4th year at King Faisal Specialist Hospital and Research Center in Riyadh. I'm very glad to have this opportunity to share with you my research project that is supervised by Prof. Al-Mayouf. My research project is entitled as Development and Validation of Red Flag Index for Early Referral of Children with Features Suggestive of GIA. So to start with, as most of you know, that GIA is a chronic inflammatory disease of presumed autoimmune etiology. It is the most common chronic childhood rheumatic disease affecting approximately 1 in 1,000 children. The initial signs and symptoms of GIA, such as arthralgia, can be nonspecific and sometimes overlap with symptoms of many diseases, contributing to the diagnostic delay that we usually see in patients with GIA. The rationale behind conducting this project was to help in identifying those patients earlier, as prompt diagnosis and treatment are very important to prevent morbidity. And in our countries, a tool for early referral of children with symptoms and signs suggestive of GIA is lacking. The aim was to develop and validate a simple red flag index to help non-pediatric rheumatologists to identify those children with symptoms suggestive of arthritis and facilitate their referral to pediatric rheumatologists. Speaking of methodology, this study targets parents of Saudi children who aged 1 to 14 years of age, of 3 groups. The first group, we have patients with GIA in whom diagnosis was confirmed within the past 12 months as per EULAR criteria. The second group were patients with general MSK pain, and a third group were the healthy controlled children. This is a multi-center study, and the patients were recruited from 7 different pediatric rheumatology clinics from different provinces of Saudi Arabia. Those contributing centers, as you can see, King Faisal Specialist Hospital in Riyadh, King Saud Medical City in Riyadh, Maternity and Children Hospital in Abha, King Abdulaziz University Hospital in Jeddah, King Fahd Central Hospital in Rizan, King Salman Armed Forces Hospital in Tabuk, and University of Hail. Regarding the study design, it's a cross-sectional study, and a convenient sampling technique was used for patients in this study. Regarding the data collection, initially 35 pediatric rheumatologists participated in an online survey to quantify the appropriateness of 15 symptoms that's usually seen in patients with GIA. Those symptoms, as you can see, morning stiffness, joint pain in the last 7 days that's not related to trauma, joint pain in the past 30 days, joint swelling in the past 7 days, joint swelling in the last 30 days, and limbing, inability to do daily activity or playing due to joint pain, fever lasting more than 30 days without unknown origin, presence of skin rash, joint contractures, night pain, sleep disturbance, eye redness, pain or blurred vision, weight loss, and finally family history of juvenile arthritis. Each participated pediatric rheumatologist scored each symptom as appropriate or inappropriate based on a 10-point scale. And a red flag index was composed of the 5 items with the highest scores as highlighted in red. Then the 5-item questionnaire was prospectively administered to a total of 145 patients of 2 groups, GIA group and non-GIA group, which includes the healthy patients and the patients with MSK pain. Parents were asked to recall the signs and symptoms that the children had experienced during the past 6 months prior to their visit to a pediatric rheumatology clinic. This is the data collection sheet that we use to collect our data. As you can see here, we have 3 different groups: the healthy, the MSK, the children with MSK pain, and the children with the GIA. Each participants with GIA or MSK pain were asked about the age of onset, the age of diagnosis, the number of physicians seen before the first appointment with pediatric rheumatologist, and the interval from the onset of symptoms till seen by a pediatric rheumatologist, and the specialty of the referring physician. Down here we can see the 5 red flags that we were asking each patient. Regarding the results, I'll start with the demographics of our patients. The validation analysis was conducted in a total of 154 patients. Among those, 57 were GIA patients, 40 were having MSK pain, and 57 healthy patients. The mean age was 7 years, and 52% of them were males. The age of onset, the median age of onset was 5 years, and you can see here J was suspected after a delay of approximately 4 months, and the patient had visited a median of 3 physicians before seen by a pediatric rheumatologist. Most of the patients were referred by pediatrician in 63%. Here you can see that all the red flag, the 5 red flag were positive and were statistically significant in the GA group compared to non-GA group with a p-value of less than 0.05. So we conducted a multivariate analysis, and to assess its accuracy, we conducted ROC curves. As you can see here, the curve is near the upper left corner, indicating higher specificity and sensitivity, with an area under curve of 0.96 and a p-value and significant p-value of less than 0.05. The prediction power of the model was good, with R-score of 0.79, indicating that 79% of the variables are related to the outcome. And there was no statistical difference between the observed and expected data when we conducted the Hosmer and Lemshow test with a p-value of 0.067. So to conclude, our questionnaires seems to be an easy and useful tool to help in identifying children with symptoms suggestive of GA and facilitate their early referral to prompt treatment. With this, I conclude my talk. Thank you so much, and thank you for listening.
The next speaker will be Dr. Khulud, is a senior consultant pediatric rheumatologist in Abu Dhabi. She's a program director of adult rheumatology fellowship in Sheikh Shakhbout Medical City in Abu Dhabi. Dr. Khulud is going to present regarding the juvenile idiopathic arthritis diagnostic, delay, treatment, and remission rate in a single center in Abu Dhabi. Dr. Khulud, you can start your presentation, please.
Assalamu alaikum. Good morning, everyone. Thank you to Dr. Reem and the organizing committee for the invitation to present our small work in this fabulous meeting. So the title is Juvenile Idiopathic Arthritis Diagnostic Delay, Treatment and Remission Rate in a Single Center in Abu Dhabi. As we all know, juvenile idiopathic arthritis is a chronic inflammatory disease that affects 1 in 1,000 children worldwide. It's the most common cause of chronic arthritis in children. and it's a heterogeneous group of autoimmune conditions classified into 7 different subtypes. The classification is about to change, but for now, this is what we are sticking with based on clinical features in the first 6 months of presentation as per the International League of Association of Rheumatology for the classification system of arthritis. Our population in the United Arab Emirates is diverse. The total population is just over 9.5 million. 42% of our population is Emirati and other Arabs. 50% is South Asian. 8% is Western and other ethnic backgrounds. But when it comes to children under 14 years of age, they only represent 1.5 roughly million of the population, with equal distribution between boys and girls. And that's because a lot of South Asian and other Arab population, young professionals and workers who do not have young children or live alone. The population of Abu Dhabi is 2.3 million. We previously described our experience with focus on access to care back in 2017. So the aim of this work is to look at the diagnostic delay in juvenile arthritis subgroups and briefly look at our experience with treatment and outcome. This is a retrospective electronic medical records review of patients with juvenile arthritis. We used ICD-9 code and ICD-10 relevant to the diagnosis. And obviously patients older than 16 of age were excluded, and patients not diagnosed with juvenile arthritis were also excluded. So we looked at the basic demographics of our patients, and then we looked at the clinical disease in remission as per Wallace criteria. Clinical remission with medication was defined as inactive disease for 6 consecutive months while on medication. Clinical remission without medication was defined as inactive disease for 12 consecutive months or more while the patient off all medications. And we also looked as JADAS 10. So results, total number of patients, 138 patients. The majority of our patients are Emiratis, 62%. Other Middle Eastern ethnic background is 20%. Asian background, 8%, Western European and American, 6.5%, and African, 3.5%. Subtype distribution, the most common subtype for us was persistent oligoarticular juvenile idiopathic arthritis, followed by polyarticular disease, mainly rheumatoid factor negative, obviously, then systemic enthesitis-related psoriatic and extended oligoarticular, following that other subtypes. So the subtype diagnostic delay, which I've highlighted here in yellow, the worst was for enthesitis-related arthritis, with a mean delay from onset to diagnosis of 11.4 months, with wide range, 6 to 25, and probably even more than that with 1 or 2 outliers. When we presented similar data of access to care, our onset to distribution was 9 months for Emirati patients and 12.4 months for non-Emirati. And we have improved significantly for other subtypes, but clearly there is a lot of work still to be done for all subtypes, but particularly for enthesitis-related arthritis. Subtype comparison distribution to other literature. I've put here our study, and as you can see, we're very similar to the literature from the United Kingdom and also from Canada, which is surprising. We do not have the same distribution with the majority of enthesitis-related arthritis. We're pretty much very similar to England and Canada. All our patients with oligoarticular disease receive joint injections, more than 90% with long-acting steroid, triamcinolone hexaacetonide. The rest of the patients, majority also had systemic steroids in one way or another at diagnosis to initiate treatment. Biologic treatment for us, 49% of our patients did receive biologics, and these percentages, obviously, they do not add up, but this reflects switching from one biologic to another. But this is interesting. We have high number of patients starting biologic treatment. The distribution between Emiratis and non-Emiratis, 53% of the Emirati patients, 43%. This might be because of more severe disease, maybe due to consanguinity, and just generally more significant disease. In terms of outcome, so remission on treatment, 37% of the total number of patients, and remission without treatment, so off treatment, of 30%, which is comparable to published literature. So in summary, higher percentage of our patients receive biologic treatment. This could be due to type of patients presenting to our center. We are one of 3 centers in the country. Now we have Dr. Sadiq in Dubai, Dr. Najla in Al-Ain, and our center in Abu Dhabi. Our remission rate of treatment is 30%, which is comparable to the published literature, and our percentage of patients in remission on treatment is 37%. The most common subtype in our cohort of patients is oligoarticular disease. All our patients with oligoarticular GIA did receive long-acting intra-articular steroid injection as first-line treatment. There is still limited access to care and need to increase awareness and referral, especially for the enthesitis-related subtype. Higher percentage of our patients receive biologic treatment. Our remission rate of 30%. Our percentage of patients in remission on treatment is 37%. We need to do collaborative work with our colleagues in the other 2 centers to have a more representative picture of our population with juvenile arthritis in the United Arab Emirates. I would like to thank all the families, their children, their data been included in this work, and Rama and Na'mat for their hard work, and we open it for question either now or at the end of the session. Thank you very much.
Okay, I would like to thank all the speakers. It was really excellent talks. Now with the Q&A question, I think I have a question here to Dr. Jubran. A question from Dr. Reem. Did you find the TMJ arthritis associated with higher disease activity or disability? Dr. Jubran? Dr. Jubran, are you online? No? Okay. If not, we'll move to Dr. Jubran. No. Okay, we'll move to another question. Dr. Sulaiman, do you have any question from the screen?
Yes, I'm here. Can you hear me now?
Do you hear the question? Let me repeat again. I think the problem with Dr. Jubran.
Can you hear me now?
Yes, go ahead.
Yes, thank you, Dr. Reem, for the question. Definitely, yes. There is, we noticed two things. First, that all the patients that they developed TMJ were those patients who has a severe disease in general among all the categories, particularly the patient with polyarticular JIA. And there was cases that's been presenting during their active disease with TMJ. So I think there is quite tight link between disease activity and also TMJ involvement, particularly in poly-JIA subtype.
Okay, thank you. Dr. Sulaiman, do you have any question from your screen?
There is one question, but I will modify it for Dr. Reem. I believe one of the audience asked about the IQ in children with the GIA. And as per his or her experience, he said they have higher IQ. I will modify it. Do you think those patients will accept that transfer easily, or they may have some, struggle during the transfer to adult service? At least from your experience, Doctor.
Right. So in terms of IQ, as you know, it's not something that we routinely measure IQ from our children, but they tend to definitely, because if they have active disease, they need to be عقلين. They're not very hyperactive. So maybe that's another way of thinking that they're different than their peers. But in terms of transfer, the ones that I found who had a higher transition transfer score were those who actually had the disease onset longer than those who had recently. So for example, those especially lupus patients have their disease onset at an early age, 3 or 4 years, those monogenic type, because they've had their disease duration for longer periods and were able to have longer time to talk about the disease. I found actually those patients at the time of 13 or even 14 were ready to be transferred because we had the time of preparing them for the transition. However, I found those children who had their disease onset at the later age, around 10 to 12 years, that disease, they were nowhere ready to be transferred. So age of onset of disease is an important factor for me in terms of readiness of transitioning. The other point I found that, yes, JIA patients tend to have easier transitional readiness than lupus, for example. They tend, partly because their disease is less complex, they have less medication to deal with, a lot of less psychosocial issues to deal with, and most of the JIA patients nowadays are more disease stable. With the use of biologics, they get into remission much faster, whereas lupus, it's very hard to control. They have flares up and down and very difficult to predict their clinical course. So yes, the factors was age of onset, is definitely a factor for transitioning of disease, as well as stability of the disease at the time of transfer. These are the two really main risk factors that I found to allow patients to transition to adult in a better way than their peers.
I didn't see Dr. Thank you, Dr. Reem, for this answer, but I will come back to you with another question. I didn't see other question. Do you allow me, Dr. Safia, to ask?
Yes, go ahead. Yeah.
of course, I don't have a question for my fellows. I'm proud of them. They did great. But I have a question to Dr. Khulud. Dr. Khulud, you told us all your patient with the oligo-GIA underwent joint injection. Can you tell us how easy to go for this approach? I mean, do they need sedation, or you can do it at outpatient? Probably this will help other people to adapt the same. We know joint injection is one of the modality, and it should be. But how easy to perform it in your center?
Thank you, Professor, for your questions. Can you hear me? Sorry, I think you've gone.
صوت اختفى شوي. If you don't mind to repeat.
Okay, I'm going to talk. Hopefully you can hear me. So we use joint injections for all our oligo. They've for some time and they need pain relief and control of the inflammation, because it gives the patient a boost time until the rest of the medications can work. Actually, since COVID, I've been doing more joint injections in clinic, just using EULAR cream and almost play therapy, because I have a very nice nurse with me in clinic who's a pediatric nurse, and just for the majority of patients, we do it under general anesthetic, which can be time-consuming and exhaustive. Lots of paperwork, and now COVID testing. But because we know it works, we persevere with the complexity of the procedure and go ahead with it. Previously, I have done it under Entonox, but obviously for that you need the supportive team. You need a lot of support from the anesthetic team. So the experience with joint injections is really great. Fat atrophy. We use triamcinolone hexacetonide, the can get it available in our hospital and for the country. Yeah, not straightforward, but very rewarding.
Thank you, Dr. Safia.
Yes, I cannot find any question here actually, because it doesn't show in my screen. I don't know if I can have a help here. I cannot see it.
There are some questions on the Zoom chat.
We cannot access it, Dr. If you can read it.
We cannot see it.
Sure, I can read them for you.
Yes, okay.
This is a question for Dr. Fatma. Can you explain the variation in the most prevalent JIA subtypes among the different GCC? You mentioned the UAE and Oman have more oligo versus systemic onset is more prevalent in the UAE in Saudi Arabia. Do you think there might be some bias, a referral bias that can explain this, or what is your explanation for that?
Assalamu alaikum all. Actually, as we said before, the precise comparison between the cohorts was challenging, as the accessibility to their data was so difficult, and there was maybe just secondary to insufficient publication regarding these issues in our countries, or also maybe due to the paucity of rheumatologists in past time. So is it there is a difference? Yeah, it's maybe this just regarding what we found in our research, but the more similarity may appear in the further study if it's done in this field. So this is the most explanation I have.
Okay, there's one more question, Dr. Khulud. Dr. Khulud, the frequency of uveitis within UAE cohort. Is Dr. Khulud around? I cannot see. Dr. Khulud? I think she...
Hello, can you hear me?
Aywa.
Aywa.
Did you hear the question? Huh?
Sorry, we're having... Yes, so yes, we have previously published our experience with uveitis. Oligoarticular and psoriatic, obviously, and it's about 22%.
I think there's a problem with the voice, with the connection, Dr. Khulud.
Because of the time.
Yeah, because of the time, I think we'll end the session. I would like to thank all the speakers. It was really a very nice presentation. Thank you very much, and we hope we'll enjoy our next our talk. Prof. Sulaiman, want to say anything?
Really, thank you very much. And again, we should thank Dr. Reem and Dr. Safia for their great job in organizing this activity. Thank you very much.
Thank you.
So welcome everybody again. It's my greatest pleasure now to start the workshop. The workshop is offered by Dr. Marco Gaturno. He's the past president of the International Society of Systemic Autoinflammatory Diseases. He is also the head center for the autoinflammatory diseases and immunodeficiency, as well as the head of clinics of pediatric rheumatology. He's also the coordinator of your fever registry on autoinflammatory diseases, as well as a member of the steering committee of RITA-ERN, which is European Network on Rare Immune Deficiency and Autoinflammatory and Autoimmune Diseases. So we're all very excited to start the workshop with Dr. Marco Gaturno. Please, Dr. Marco.
Okay, thank you very much. It's a great pleasure to be here. Unfortunately, not in person, but it's a great pleasure to have again a discussion about my favorite topics. Of course, that is autoinflammatory disease. I changed a little bit the title, Autoinflammatory Disorder in Children 2.0, because things are changing very rapidly. So I will have two parts of my workshop. One is a sort of summary of what you already know, what we are the typical diseases that we are following, and which is the expanding spectrum of the condition, and also how to handle with all these new disease, especially when we face patients with undifferentiated autoinflammatory disease. You know very well that autoinflammatory disease are monogenic disease that are caused by mutation of genes involved in the innate immune system, leading to a sterile inflammation. This is Doncaster that discovered the field and also named the field with the terms autoinflammatory, just to distinguish from autoimmune disease, as you know very well, because the absence of a typical class 2 HLA association or gender disproportion, and also the absence of, I would say, pathogenic autoantibodies of antigen-specific T cells. The story started theoretically since 1997, but we'll see start many years before. You know that the cells of innate immunity here are more involved with a strong activation, because thanks to their ability to recognize molecular pattern of damage and also pathogen molecular patterns, they are able to screen and sense these danger signals in the membranes, in the endosomes, and also in the cytoplasm, just to activate the cells of innate immunity for the inflammatory response. And this leads, of course, to an overactivation of the pathway that lead to the inflammatory response, the production of a number of cytokines. And you know very well that these diseases are related to some alteration, genetic defect that increase the activation of this pathway or decrease the regulation of this pathway. And this lead to this rheumatic condition that are genetic and are really relevant in terms of symptoms. As I told you, the story officially started in 1997, but as you know, here is much longer. During the year, in the last century, there was the appearance of different disease clinical condition, rather characteristic, you can see here, that were thought to be genetic because they were familiar, but just after 1997, thanks to an approach, a classical approach of linkage disequilibrium, so looking to very large families, we were able to identify the first gene, mainly with recurrent fevers, and then with other conditions. And not only those that has been already described in the past in red, but also new conditions. And you can see how many are these conditions that are in the last years identified, thanks of course to the next generation sequencing you will see later on. And this number is much higher if we also consider the so-called interferonopathies. And it's interesting to see that the first ever autoinflammatory disease that from the clinical point was described was the Nakayo-Nishimura syndrome, that is indeed in 1939, that is indeed the Campbell syndrome. You can see here in this rather old table that every year and now every month we discover new diseases. We start with the classical recurrent fever, periodical recurrent fever, FMF, hyper-IgD, and TRAPS, and maybe with cryoparinopathies. But then there is a number of other conditions and also clinical picture that can be linked to a monogenic autoinflammatory disease. So at the beginning of the story, at the end of the last century, saying autoinflammatory disease was the equivalent of saying recurrent fever. And as you can see here, the situation is completely changed because there are a number of different clinical conditions that are related to this condition and to new genes. Very quickly, I have a sort of summary of what we know and which are the more relevant picture, the periodic fever, the beginning of the story, the three big ones, the classical ones that are FMF, you see, you know it very well, also in your country. IPHD, very important that you have to let's say, distinguish from PFAPA for the number of, for the days of episodes, and also for the tonsillitis and lymphadenopathy. But as you know, these patients are much sicker rather than PFAPA, diarrhea, vomiting, rash, and so on. And then from TRAPS, TNF receptor 1, that are associated, as you know very well, with very long episodes of 2-3 weeks, and at the beginning of the story, few episodes during the year. You know very well as pediatrician that PFAPA is indeed by far the most frequent form of autoinflammatory disease. This is not a genetic one. At least we know that there is a predisposition for that, maybe a genetic predisposition, but not for sure a gene for PFAPA so far, and is a multifactorial disease. And this is typical for many of autoinflammatory disease, which there are a multifactorial counterpart for the monogenic one. The monogenic recurrent fever have this multifactorial equivalent that is PFAPA, that is clinical different because the patients are quite well despite the fever episode. The second point that was very important for the development of autoinflammatory disease was the combination of recurrent urticaria-like lesions and inflammation. And in the picture that you know now very well, that is related to mutation of NLRP3, the so-called cryurinopathies, in which there is a large spectrum, in which the urticaria rash and fever and inflammation is associated, according to the severity of the disease, to a different and a very important, sometimes very important, and the dramatic multi-systemic, multi-organ inflammatory manifestation like in zinc and non. This, of course, was very important because told us a lot about the NLRP3, but also the role of inflammasome, the role of IL-1. I make a seminar yesterday on this. Of course, I will not go into detail. But as I told you very quickly, there are many other clinical presentations for autoinflammatory disease. Arthritis can be part, a possible starting manifestation for the onset of autoinflammatory disease. This pyogenic arthritis that you can see here, very painful, especially when is associated with severe acne and also pyoderma gangrenosum or hidradenitis suppurativa is linked to the PAPA syndrome, a polyarthritis with a huge and florid tenosynovitis associated with a panuveitis, and this rash, I hope you can see very little papules, red, that are typical of Blau syndrome. If you make the biopsy, you see the granulomata. And very recently, we have Professor Sulaiman, that was the discoverer of this gene, LAC1, and this condition, genetic condition associated with a familial arthritis, sometimes polyarticular and sometimes systemic, that is so important, so relevant, and that came from Saudi Arabia as the first indication some years ago. So arthritis can be sometimes the presentation, but also skin manifestation like pustulosis, sometimes associated with a CRMO-like condition with periostitis and some lesions, inflammatory lesion of the bone. This is very dramatic in the DITRA for the alteration and from the genetic deletion of IL-1 receptor antagonist. The same very severe picture can be present for the same mutation, but in IL-1 36 receptor antagonist. That is very important. Is a very important cytokine inflammatory cytokines at the level of keratinocytes. And again, these patients have this flare of pustular psoriasis that can be, of course, very severe, leading to UTI admission because of the high fever, dehydration, and possible risk of infection. This is quite important because there are other conditions that mimic some multifactorial condition like panarteritis. This is something that we know more and more. It's less frequent that we know, has been described in 2014, the deficiencies of adenosine deaminase 2, in which the patient can have a livedo reticularis or achemosa, and they can have a clinical picture very consistent with a PAN, together with very early onset ischemic or hemorrhagic strokes. This is a very important disease, very important to define, also as for the other condition that I told you before, because in comparison to the previous one that had a fantastic response to IL-1, this condition have to be, let's say, treated with completely different drugs. For example, inhibitor of IL-17 for DITRA, and what is quite important, as you know very well, anti-TNF treatment for ADA2. What is important for ADA2 that is now clear, and you know, I think very well, that in parallel and with the very huge inflammatory phenotype with this vasculopathy that of course can lead to a number of different manifestations that you can see here in this very elegant view from PLE from Boston. Is now clear that these patients also have some relevant immunological features that sometimes can be predominant. Some of them can have a quite low immunodeficiency with hypogammaglobulinemia, but some patients have some very, very big troubles with bone marrow failure because of poor red cell aplasia, thrombocytopenia, or pancytopenia. So this is interesting, very interesting, because sometimes it could be very complicated to treat. Sometimes in this patient, you have to go through hematopoietic stem cell transplantation because of bone marrow failure. And this is important to know, but also this raises the concept of a new area of diseases that we now call as immune dysregulation, in which, and ADA2 is a typical prototype of this kind of disease, in which we have a lot of monogenic defect, in which beside inflammatory phenotype, typical inflammatory phenotype of autoinflammatory disease, we have also or for immunodeficiency or for the selective dysfunction of some immune cells, sometimes also severe infection and an immunodeficiency phenotype. So a combination of the two that make this condition really, really difficult to treat. This is an important concept in the field of autoinflammatory disease that make a link between autoinflammation and immunodeficiency. As you know very well, there is also a genetic form of a Behçet-like disease that sometimes can have a clear-cut picture of an of a Behçet disease with the pathogy and the gastrointestinal inflammation and apoptosis and so on, that is related to the mutation of A20 with A20 haploinsufficiency. That is rather relevant in many families with a Behçet-like condition. And then just to finish, what is the classical phenotype? This new condition that sometimes mimic the multifactorial autoimmune disease, because sometimes are rather similar to lupus or dermatomyositis for the kind of clinical manifestation. You can see the chilblains, the rash, and so on, the vasculopathy of SAVI that have sometimes also a very severe inflammatory phenotype at the level of the lung with interstitial disease. This is another example of a Candle syndrome in which there is alteration of the proteins that lead to an overactivation of a cytokine that are different from the classical pro-inflammatory cytokine TNF, interleukin 1 or interleukin 6. In this condition, what is play a major role is the interferon of type 1 interferons, alpha and beta. These are the kind of cytokines that we usually produce when we have a viral infection, when there is this pathway that is activated, leading to this antiviral activity that is an inflammatory activity completely different from the bacterial one. And in these diseases, there is an alteration of this pathway and overactivation of this system, leading to overactivation of type 1 interferon. Very recently, we were able to identify that a new disease in which there is the combination of severe arthritis, rheumatoid factor arthritis, and interstitial lung disease. Indeed, we provide evidence that that was the COPA syndrome was an interferonopathy. The patient had a very huge interferon signature, and now relevant studies have shown why COPA is related to an overactivation of interferon, type 1 interferon, and should be treated as all the interferonopathy with different drugs, as you know very well. Not the classical anti-L1, anti-TNF, or other anti-cytokine treatment. Also, even the immune modulator, immune suppressants do not work very well. What is the best strategy so far are the JAK inhibitors, as you know, that try to cancel this loop of continuous stimulation of the receptor. Okay, this is a very short overview of what we know and how is expanding the spectrum of the clinical condition that we consider in the field of autoinflammation, and that can be different in presentation. And as you can see from this slide that I love very much, is my favorite one, particularly every tissue of the body can be, let's say, in a way involved in autoinflammatory disease. I have to say that all the specialists, that every subspecialties can meet a patient with an autoinflammatory disease according to the organ that is involved at the beginning. This is very important. We have to increase the knowledge to recognize. And if we include also the concept of immune dysregulation, very recently with my resident Riccardo Papa, very talented, is an encyclopedic. He make this review that tell you about the first 100 genes of autoinflammatory disease and immune dysregulation that are in a way linked to an hyperinflammation. So the number from the 3 periodic fever, FMF, hyper-IgD, and TRAPS in the last years of the last centuries grown enormously. And so that is the point that we have when we have to face new autoinflammatory disease. Of course, this is make you a little bit uncomfortable when a patient arrives in your office to, let's say, evaluate for a possible diagnosis. The patient have an inflammatory phenotype, and you have to decide which kind of disease. Here you're in trouble because the situation is rather important, rather large. Of course, we have few classical monogenic autoinflammatory disease. Very quickly, we have remember you which are. Besides that, you have a larger number of patients with multifactorial autoinflammatory disease, PFAPA, systemic onset juvenile idiopathic arthritis, Still's disease, Schnitzler, gout, recurrent pericarditis, several manifestations in which there is classically an overlap from the clinical point of view and also pathogenetic point of view, but not a genetic disease. But however, the situation is even more complex because sometimes, many times, you have also to consider other conditions that have an inflammatory phenotypes, autoimmune disease, tumors, immunodeficiency, that enter in differential diagnosis. And we have also a relevant number of patients that have a clinical picture consistent with monogenic disease, in which you make a careful differential diagnosis and exclude the confounding disease, and we can define them as undifferentiated autoinflammatory disease. These patients are plenty, many, and is our daily activity. Of course, if you add also the disease with immune dysregulation that we alluded before, you understand that the picture, the clinical, the general picture is rather complex, and we have to be very careful, and we have to have a lot of skills from the clinical point of view, but also some helps to understand and to orientate. As you know very well, when we define a disease, a genetic disease, and of course the same is for the monogenic autoinflammatory disease, you have to combine the clinical picture with the genetic analysis. If we are very lucky, the clinical picture can be very typical for the clinical manifestation, and the genetic analysis can be confirmatory. We have a typical phenotype, and we make the genes, and it came out a pathogenic or two pathogenic mutation. You are very lucky, and you're very good, and you have your diagnosis. But as you know very well, the situation is not that easy. Sometimes the clinical picture is atypical, not described, or very rare. And sometimes the genetic analysis, many times I have to say, genetic analysis is not completely informative, because it's complete, for example, heterozygous for an autosomic recessive disease, for the presence of polymorphism or variant of unknown significance, for the negativity, but also sometimes even from redundant information. For example, variant for more than one gene. So the situation is rather complex, and the interpretation of the combination of clinical picture and genetic analysis can be rather tricky, rather difficult. Of course, we try to make some order in this, at least for the historical ones, IgG, FMF, TRAPS, and CAPS, with the new classification criteria, in which, with an evidence-based way, we try to combine the clinical manifestation, the phenotype, with the genetic analysis. And so, for the first time, we have classification criteria that make a combination of clinical manifestation and genetic analysis. That is rather logical for a genetic disease. But as you know, what's changed completely our way to work on this condition is the advent of next generation sequencing. You know very well, since many years now, that the cost is reducing a lot. We have a lot of possibility to analyze the whole exome, that is take account of 90% of a human genome, of the coding system, genetic disease involved in the exome, or the whole genome sequencing. You have the possibility, and the costs are decreasing a lot, as you know very well, and this makes for us a lot of opportunity, and sometimes also some troubles. Of course, we need to interpret it very well the variants that came out from genetic analysis. As I told you, sometimes can be very precise, sometimes can be confounding, and especially when we have to face many different conditions and a lot of differential diagnosis, we have to be sure that what we find in our genetic analysis is informative and is not, let's say, misleading. This is very important. So we have a lot of tools, even as a clinician, not only, of course, we have the tool to talk with our geneticist, but we have to get used to enter in some of these, for example, tools, in which you can, of course, find which is the meaning of the different variant that come out from the genetic analysis in your patient when you have the result back, so you can understand. Beside the comment of the report, in the field of autoinflammatory disease, as you know, we are particularly lucky also because we have the fever database, that is a website in which some expert has provided consensus on the pathogenicity, the level of pathogenicity of all the variants that are included in the fever database. You know, it's a database for all the variants that has been described in the all autoinflammatory disease, and for many of the conditions, a panel of experts has judged the pathogenicity. This is very useful and help you a lot in the interpretation. Which are the possible application of next generation sequencing you have to use? As you know very well, we can make the diagnostic panels. This is absolutely normal, many diagnostic panels with different number of genes. This is what we observe, what we did during the years from Sanger in our institute in Genoa, from Sanger sequencing, and then to the different panel, more large, up to what is now what we are doing. The whole exome sequencing, of course, is much intelligent now that the costs are really low, to make the whole exome sequencing, at least the whole exome sequencing, and then make an in silico panel to evaluate the genes that can be of interest. Of course, NGS can also help us when we consider patients with a picture consistent clinically from an autoinflammatory disease that come out to be negative. We have to consider also the possibility to a somatic mosaicism. This is a possibility in many of conditions, so in which only a percentage of the cells are carrying the mutation. And you know, practically all the autosomical dominant disease that we have in our field of diseases has been described also as possible mosaicism. This is important because only a deep sequencing of NGS can detect the mosaicism. So we have to look carefully, and we discuss carefully. If we have a very strong suspicion of an autoinflammatory disease based on the clinical ground, we really have to exclude the possibility of a mosaicism. NGS can help us, of course. What else? Of course, NGS can also help to identify unexpected or new phenotype in diseases that has been already discovered. This is important. This is a paper that we did some years ago, properly on patients with undefined autoinflammatory disease. 60 patients in which we with a clear picture of an inflammatory disease, follow in our center for at least 2 years, and they came out to be negative with a classical, let's say, method for the more typical genes. So we study this 60 gene panel just to understand if this panel can be of help. And I have to say that unfortunately, in very few patients was helpful, particularly in these patients that have a very strange phenotype with a persistent inflammation, a polyarteritis, and a periostitis. You can see a huge periostitis, a frontal bossing, a very pachygyria, so very strange phenotype. We did some genes, DITRA or CAPS and LRP3, but we didn't think about mevalonic aciduria, and we didn't screen for it. And just the panel indeed turned out the fact that he had 2 mutations of MVK and the final correct diagnosis. This is important. Sometimes the panel or the whole exome sequencing can help you, especially in some strange phenotypes that you do not expect. Sometimes also you have to be suspicious of a negative, like for mosaicism, This is another example. This patient, a young lady from Sardinia, that have fever, livedo reticularis, myocarditis, three strokes, and hypogammaglobulinemia. She had the typical picture of adenosine deaminase 2, including the complete response to anti-TNF, but no other two mutation at all. The enzymatic activity in our centers was absolutely positive in terms of no enzymatic activity at all. So we were sure that was a defect over there. We went for whole exome sequencing of the trio, just to understand maybe if there was another genes that were close to this system to explain this manifestation and the lack of enzymatic activity, but that was not the case. So we have to go to the whole genome sequencing in this patient, and that was the only way to detect two very important tandem duplication, homozygous tandem duplication of the gene, ADA2, that lead to a complete block of the transcription of the protein and lack of enzymatic activity. So the genetic, let's say, result was really, really tricky to reach, and it took a lot of time. And then finally, of course, NGS, whole exome sequencing, whole genome sequencing is also very important to identify new diseases. And now we have the possibility to find new genes and find new diseases. This is an example of ADA2, but there are many. I just show you in respect to the previous slides here, the new genes that we discover in the last year. So the number is increasing a lot, and this is very, very relevant because now the number of genes and number of diseases, as I told you, is increasing. And so this is important because thanks to the whole exome sequencing, we have the possibility to identify new disease. So some of these undifferentiated autoinflammatory disease indeed became monogenic disease or disease of immune dysregulation. So the number of condition is increasing. This is very, very, let's say, exciting. I have to say, very difficult and very exciting. But this is also very important for us from the practical point of view, because new disease every month coming out. So you have to come back to your patient and reevaluate your patient periodically to your diary to see if there is something new genes related to strange phenotype that you have discovered. And if you have done the NGS, you have to come back to that data and reanalyze the patient. This is very important and a new aspect of our disease. That's why now I try to change the paradigm and I talk about autoinflammation 2.0, because things are going to change and are already changed in the last year. So the advent of the big data in the clinics, how to connect the phenotype with the genotype, with a lot of information that we have, it's so more and more important. We do not have to lose our clinical skill, but we have also to make and to use the tools that can help us, because now we are facing a situation in which the number of diseases are so high that the classical holistic attitude of the clinician cannot be enough to detect all the conditions that are included. This is very important. And so the balance is so important. Of course, we need to have tools also for making this communication among the different situations and the information. Important to have the clinical variables that can be with code that can be linked to in this system. Is important. One of the most important is the human phenotype ontology. Is an important tool that link all the genetic disease, the genes with the phenotype. This is quite relevant because since last year we didn't have the terms, the HPO terms for autoinflammatory disease, immunodeficiency, and immune dysregulation. Thanks to these efforts from a number of colleagues, we were able to identify the terms and extract the HPO terms from the literature with a consensus. And now in this paper, we have the first list of HPO terms that are linked to autoinflammatory disease and immune dysregulation. This is important because this is the system that can help the bioinformatics to evaluate the data and to link the genes to the phenotype. This is so important. So to finish, what to do beside the deep sequencing? You know very well, you send the DNA of the trios of the patient and you wait for the reply. And unfortunately, there are several times in which even the whole exome sequencing, sometimes also the whole genome sequencing, is not informative. So this is frustrating. So what to do? There are evidence of the possibility of the strategic implementation of bioinformatic analysis. So there are programs, for example, in Europe, through the European Network for Rare Diseases, in which there is this link among the different laboratories in which the whole exome sequencing or patient that has not been solved are re-evaluated with different platforms, the different tools for the bioinformatic analysis, just to understand if a different approach can lead to different results to identify a gene. This is so sharing data again in the big data approach. This is important, but there are also some very interesting initiatives and very original. For example, inverting the paradigm. This is what our colleague from NIH they did. They do not start from the phenotype like we did for the monogenic diseases, but they start from the genotype. So they had a lot of number of patients with undefined autoinflammatory disease, and they have a list of genes that were related to ubiquitination. They are very important. They are very, let's say, interested in the ubiquitination. And so they make this gene in this group of autoinflammatory disease, and they understand that there were patients that have somatic mutation of UB1 gene on the X in some males, in which have this kind of new condition, late onset condition, autoinflammatory condition called VEXAS. This is interesting because, of course, this is another approach for autoinflammatory disease. But we have also to consider that sometimes not all the picture, even in young children, that we see are monogenic diseases. Some could be multifactorial. And we have an example of periodic fever. There is a huge number of patients, and we studied some years ago, that have a typical feature of periodic fever. They are not monogenic disease because the genes are negative. They are not PFAPA, but they have recurrent fever. We understood that these patients have a different phenotype. They respond very well to colchicine, and we call them SAND syndrome of undifferentiated recurrent fever, SURF. Very recently, we have described our cohort of 50 patients. I have to say you that the response of colchicine also in the long term is very, very good. And the clinical picture is rather similar to FMF, but they are genetically negative. It's very important to understand how this disease, why these patients have inflammation, how is important the pyrimidine inflammasome and NLRP3 inflammasome. This is what we are doing now. So in conclusion, you understand that the clinical picture is going to be very, very wide from the classical monogenic autoinflammatory disease. We have to be very careful in interpretation of genetic tests. NGS can be of great help to us, but we have take advantage of new tools to identify and also to describe and to interpret everything in a correct way. So an integrated multi-specialistic approach is more and more important. And we do not have to forget that sometimes we can face multifactorial disease, and as we did for PFAPA, we have to characterize also this multifactorial disease. So I conclude. We have 5 minutes for possible questions. This is the acknowledgement, of course, all the people in Gaslini Institute working with me. And of course, I thank you for your kind attention. Thank you.
Thank you, Dr. Qatar. That was a very good, comprehensive talk. Again, the question of when you get a case and you could swear this is an autoinflammatory disease, and then your genetic testing of the autoinflammatory panel comes back negative, you do your whole exome sequence and you're stuck because it's not very conclusive. Again, so if you can talk to us, how to go about managing such a patient.
Yes, of course. It's really dependent. At a certain point, even when you are waiting for the results, you have to treat this patient.
Yes.
And so this is very important. The possibility to treat with colchicine in patients with a recurrent fever is, of course, very easy, and is rather important to do that. And they respond very well. And if they respond, of course, you have pretty much the feeling that could be. If you have a manifestation like lymphoproliferation, some also autoimmune condition, gastrinopenia, neutropenia, of course, we are maybe suspecting different condition, maybe an ALPS, lymphoproliferative disease. So the double negative maybe can help you in this patient, and maybe they need a completely different treatment with sirolimus or mycophenolate and so on. So the interferon signature can help you to identify a possible interferonopathy and the use of immunosuppressants or even JAK inhibitors. So according to the phenotype and some functional study, maybe you can start to orientate yourself on what kind of drug you can use.
Sure. So the new disease of SIRF is really interesting, and the potential treatment with colchicine. A question from Dr. Khulud is asking, how long do you think we should continue with colchicine in patients with SIRF?
This is a very good question. We in the paper that I show you that we have tried to withdraw the drug after at least 1 year, sometimes even after 2-3 years. In 14 patients of 50, I have to say that all of them, excluding one, at a certain point relapsed. So they have to come back to the colchicine again after 1 or 2 years of treatment. So that is, we don't know already how long we have to treat them.
One very last quick question, again from Dr. Khulud. She has multiple patients with recurrent mass.
Yeah.
There's no identified genetic explanation. I presume they looked into IL-18 as well.
Yeah.
But they apparently respond well to colchicine. What's your explanation?
Wow, this is true. There was a slide that I was in a hurry, so I didn't get. But there is another kind of a disease in which recurrent mass, sometimes pulmonary involvement, very severe. And I do not have any experience of this patient of colchicine. If this information of the usefulness of colchicine is true, I'm sure it's true, it's very important to describe, because of course that means that the pyrene inflammasome or what is around can make a role in the activation of this pathway. So please, it's very important to describe, and of course, and then to try to understand which is the mechanism, of course.
Very last question, another interesting one. Now this post-COVID era, change our autoimmune system altogether. Should we be anticipating new autoinflammatory disorders post-COVID?
my God, we have it already. We have MIS-C, and this is the new autoinflammatory disease, that's for sure. We know very well, and this is a prototype of post-infectious autoinflammatory disease that we have to treat with our drug, immunoglobulin, steroids, IL-1 inhibitors, and so on. I hope that we stop here and we will not have new autoinflammatory disease related to the new pandemic, because the classical ones are enough, and
yes.
we have to face it.
Thank you very much. That was really truly excellent.
My pleasure.
Thank you very much, and hope to see you in Oman and somewhere in the GCC soon, inshallah.
Sure.
Take
Bye.
care.
Bye.
Bye. Ciao.
Welcome back, everyone. It's my pleasure to moderate the third session of the day along with my colleague, Dr. Khurud Khawaja. We are going to have six interesting talks that will be presented by distinguished speakers. So please stay tuned. Our first speaker will be Dr. Muna Al-Mtairi. Dr. Muna is a faculty of medicine at Kuwait University. She's pediatric rheumatologist at Al-Adan Hospital. Dr. Muna did finish her residency program at King Fahd Medical City in Riyadh, followed by her fellowship program at King Faisal Specialist Hospital in Riyadh as well. She did an additional training in lupus in Sikis Toronto Hospital, where I met her for the first time, and she's currently the vice president of Kuwait Association of Rheumatology. Dr. Muna will be talking about the genetic analysis in MIS-C patients.
Assalamu alaikum wa rahmatullahi wa barakatuh. My name is Dr. Muna Al-Mtairi. Thank you for the organizing and the scientific committee for inviting me to present our abstract. Our abstract and the ongoing research talking about the clinical characteristic and genetic analysis of multi-system inflammatory syndrome in Kuwait It is the initial result from a national pediatric registry analysis. I have no disclosure. As we know, COVID-19 caused by severe acute respiratory syndrome, coronavirus 2, has been causing a global epidemic since December 2019. A variety of clinical outcomes have been reported with COVID-19, ranging from no clinical symptoms to severe respiratory diseases and even death. In children, SARS-CoV-2 infection can lead to multi-organ manifestation needing intensive treatment, defining a novel disease known as multi-system inflammatory syndrome in children. Family clusters of MIS-C have been reported, suggesting heritable traits predisposing to severe infection. The underlying cause of phenotypic heterogeneity, susceptibility, and disease severity among affected individuals is still unclear. It has been thought that both viral and host genetic variations could probably probable factors that influencing the disease severity and susceptibility also. Our study aimed to have clinical and genetic characteristics of children with MIS-C in Kuwait, utilizing 28 large kindreds with familial MIS-C clustering. We review the literature through a database, PubMed, Science Direct, and Little COVID. This is the question, where is it up? And our goal in this research is twofold: to describe the clinical signs, lab finding, imaging, characteristic, treatment, and outcomes of patients with MIS-C, and also to have analysis of the host genes in children with MIS-C. The method and data collection we used the Nation Pediatric COVID-19 Registry in Kuwait that has been used to identify children 12 years or less who met the WHO criteria of MIS-C. Details, demographic and clinical phenotype data were obtained from medical charts. All subjects and their families were invited for blood molecular genetic testing. Genetic analysis using whole genome sequence has been performed in the affected individual and their parents. The parents and legal guardians of the identified patient were invited to join the study through a phone call or approach them if the affected child was admitted to the hospital. Consent was obtained from the parents as well as the consent from the child or the children who can provide it. Blood samples were collected from the patient and the parents by the research assistant at the setting of the OPD or from the study group members in the either of the patient in the ward or in the ICU setting. Our case division was based on inclusion and exclusion criteria. The inclusion criteria include children less than 12 admitted to the Ministry of Health hospitals in Kuwait and the new hospital Ahmadi, children fulfilling the Kuwait COVID-19 task force and WHO criteria for diagnosis of MIS-C. Consent was obtained from the parents and legal guardian with explanation of our research aim and why we are collecting the blood. The exclusion criteria: children more than 12, not following the MOH hospitals, not filling the criteria of WHO, and if the patient refused or the parents refused the study or to participate in the study. This is the WHO criteria that we use for diagnosis of MIS-C, including children with fever more than 3 days and 2 of the following: rash or bilateral non-purulent conjunctivitis or mucocutaneous changes, hypotension or shock, features of cardiac involvement in the form of myocardial dysfunction, pericarditis, valvulitis, or coronary abnormalities, evidence of coagulopathy, acute gastrointestinal problems such as diarrhea, vomiting, or abdominal pain, and elevated markers of inflammation such as ESR and CRP or procalcitonin, and no other obvious microbial cause of inflammation, including bacterial sepsis, staph, strep shock syndromes, and evidence of COVID-19 infection or likely contact with patient with COVID-19. The data presentation and finding, we collect around 86 children has been identified in the period between April 2020 and until November 2021. Out of them, 70 cases were diagnosed with MIS-C, 12 cases with Kawasaki, and 6 cases with atypical Kawasaki. Median age was 5.5 years. More than half of them boys, around 55.8%, and non-Kuwaiti around 54.6%. Around 52 children, accounting for 60%, has evidence of recent SARS infection, either by positive reverse PCR test or a positive IgG rapid antigen detection. All children were symptomatic, presented with fever with average of 5 days duration, and with GI symptom around 77.9%, respiratory symptom around 39.5%, skin rash in 60% of them, involvement of the mucocutaneous changes in 30% of them. Around 22% of children required oxygen therapy, and only 6 patients required intensive mechanical ventilation. Total of 34 patients required admission to the ICU, with a median length stay was 4 days. Only 16 children required enterobic support. The treatment with IVIG in around 82% of them, antibiotic received by 80% of them, and steroid in 63% of them. Echo finding showed cardiac abnormalities and dysfunction in 16 children. 1 death occurred due to severe pneumonia and septic shock. Molecular genetic testing was performed in 28 subjects and their biological parents. Genetic analysis, whole exome sequencing of 3 families was completed until now. All of the 3 children were previously healthy, non-obese, and with none to have any comorbidity or no family history of MIS-C. They all have evidence of recent SARS-CoV-2 infection. 1 child aged 9 years, he's the one who developed myocarditis as a complication of MIS-C. He presented with hypotension, hemodynamically unstable, and required enterobic support. All the 3 children were fully recovered after receiving the respiratory support in the ICU. Consanguinity was observed in 2 families, and until now we didn't find gene mutation that make them prone to COVID-19 or post-COVID-19 MIS-C with severe manifestation, but we find there is association. There is a proband harbored various homozygous variant in this gene, BTNL8 and interleukin-17RA and IRS4 genes. And this is still under study. Still, we didn't complete other families to see if there is a mutation or there is an association. In conclusion, this is the first study in Kuwait to review demographic, clinical, epidemiological, and genetic characteristics of children with MIS-C in Kuwait. Although familial clustering of severe COVID-19 has not been observed in our cohort, but our data showed utilizing a family-based study allows for significant enrichment for homozygous genetic variants that may impact our standing of MIS-C. Knowledge of the genetics contributing to pediatric MSc may benefit the clinician of terming of choosing the therapeutics. Genetics may thus tailor the therapy for children with MSc. Further study are needed for better understanding of the disease mechanism as well as better management and outcomes. Acknowledgement, really we'd like to thank the dedicated and steadfast researcher and the clinician as well as the participant patient and their families for their effort for better understanding the ongoing and helping us to understand the mechanism of SARS-CoV-19 for better outcome and better therapeutic options. And thanks for the SMAN Center for their participation and Kuwait Foundation for Advancement of Science. And also special thanks to our resident for their great help. And thank you so much. Thank you, Dr. Amana, for this really very interesting talk. Now we're going to move to our second speaker, Dr. Hilal Saif Hashami. Dr. Hilal is a pediatric infectious disease consultant. He graduated from Sultan Qaboos University and he did finish his pediatric residency under the Oman Medical Specialty Board. He did his fellowship at Hospital of Sick Children in Toronto and he's currently working in Royal Hospital, Muscat, Oman. Dr. Hilal will present the his abstract about Missy's experience in Oman.
Hello, everyone, and thank you for the organizing committee to invite me to share our experience of multi-system inflammatory syndrome in this international conference. Actually, I'm representing and presenting the work of the excellent team that participated from different centers during the last year. As you know, the multi-system inflammatory syndrome, it's one of the syndromes that occurred during the pandemic of COVID, and basically it was initially started on early 2020s on April, when it was initially they start to notice in the UK that children who present unusual with multi-system involvement, they require ICU admissions. After that, they have, features that are similar to the Kawasaki disease, and there are challenging diagnoses. Is it Kawasaki? Is it something else? And what exactly caused this inflammatory syndromes? And very good number of them, they require ICU admission. So it was a challenge to the intensive care units and to the people. After that, papers start to come up from the US, from Italy, describing the same features of the same syndromes. And here we have the WHO's of multi-system inflammatory syndromes, which include fever for more than 3 days and involvement of more than one system, in addition to have high inflammatory markers and epidemiological link to COVID infection, and there is no other explainable cause. CDC also, they have their own definition of multi-system inflammatory syndrome. In our study, it is a retrospective chart review studies that look into the clinical characteristics, treatment, and outcomes for all the pediatric patients here in Oman, and we used the WHO criteria for the diagnosis. It included 6 centers, and it was conducted over a 7-month period from May to November 2020. We have a total of 133 patients were admitted during the study period. 58% of them, they were a male patient, and more than 50% they were from 2 centers, the Royal Hospital and the Sultan Qaboos University hospitals. In this cohort, the absence of documented COVID infection was observed in 60%, like 60% of them, they were having no symptoms of COVID or URTI symptoms. But 66% of them, they have history of contact with COVID infection in their family members and in close contacts. All these cohort, all these patients, they were managed as inpatient, and less than 3% of them, they were admitted for more than 2 weeks, and 56% the admission period between 3 to 5 days, and 42% they require intensive care unit admissions. Regarding the COVID testing, all the cohort except one patient only, they were tested for COVID PCR. Out of them, the positivity rate of COVID PCR was 43.5%, which is incomparable with the international studies. Serological test was done for only 38 patients. Out of them, 30% turned to be positive for COVID serology. And again, this is in comparison with the international studies. Regarding the clinical features, as we mentioned earlier, it has symptoms and signs that also mimic the Kawasaki disease. So the lymphadenopathy was documented in 27% of the cohort. 44% of them, they have skin rash during the admission, and they have also non-virulent conjunctivitis observed in 40% of the patients. 25 of them, they have swollen also hand and foot. And as you can see, it's mimic the Kawasaki disease. Gastrointestinal manifestation, it was observed in 46% of the patient, and abdominal pain was observed in 60% and vomiting in 55%. Respiratory symptoms as a cough was there in 23% of the patient. Shortness of breath was observed, and it was there in 20% of the patient. 23% of them, they have cardiovascular manifestation in form of left ventricular dysfunction or hypotension or cardiovascular shock, especially during the initial presentation in the emergency room. Investigation-wise, 17% only they have respiratory viral panel tested apart from the COVID, and only one patient was tested positive. Positive blood culture was seen in 5% of the total patient, and they're treated with appropriate with the antibiotics. Radiological investigation and chest X-ray, we had it in almost 91.5% of them, and that's because it's mainly during the pandemic. They also presented with URTI symptoms, shortness of breath. Abdominal ultrasound was conducted in 27%, and that's because a good proportion of them, they present with pictures like acute abdomen or appendicitis. Supportive management for this patient, fluid boluses was given to 58% in the emergency unit, and 30% of them, they require vasoactive support. 1.5% they require high frequency ventilation, and one patient only require renal replacement therapy in the intensive care unit. Regarding the specific treatment, 95% of them, they receive intravenous immunoglobulin as part of the national treatment protocol. Aspirin was given to 83.5% of the patient. 16% of the cohort received anticoagulant therapy as per the protocol. Antibiotics were given to 92.5% of them. It bit high percentage, but that it was people, they are initially when the patient was sick, initially they are starting the antibiotic empirically, which was stopped later. Antiviral agent, interesting enough, the anti-COVID antiviral agent in form of favipiravir was used only in two patients, Tamiflu in one patient, and acyclovir, interesting enough, it was given to 6 patients, and mainly these are the patients who have skin manifestation or atypical skin manifestations. Regarding the comorbid conditions, 2% of the patient, they have congenital heart disease, and 3% of them, they have hematological disease in form of sickle cell disease, and some of them, they have hematological malignancies as well. 4.5% of children were obese with BMI more than 95% for their age. We observed the clinical complication in 4% of them, and on subsequent follow-up, 72% of the patient, they had follow-up echocardiography. Our mortality rate, it was 3% in this cohort, which include 133 patients. And it's again comparable to the other regional centers and international centers. It's almost it's not that high, but you know, people, they stick to the treatment protocols, and the early use of immunoglobulins contributed to the low mortality rate of 3%. So with that, I would like to thank you for allowing me to share our research on multi-system inflammatory syndromes with you, and thank you so much.
Thank you, Dr. Hilal, for this great presentation. Now we are moving to the third speaker, Dr. Jibran Al-Ganatish. Dr. Jibran is a senior consultant pediatric rheumatologist and the chairman of pediatric at King Abdullah Specialized Children's Hospital in the King Abdulaziz Medical City for National Guard. Dr. Jibran as well is a clinical lead in development of childcare. Dr. Jibran will share with us his abstract regarding the clinical characteristic and outcome of MIS-C patient.
Hello, good afternoon, everybody. I'd like to thank the scientific committee for inviting me to share our experience regarding MIS-C in Saudi Arabia. In this presentation, I'm going to present to you the clinical characteristics and outcome of MIS-C, a multi-center experience from Saudi Arabia. I have nothing to disclose in regard to this presentation, except that we have to limit the outline of the presentation to our experience in COVID-19 infections and MIS-C Saudi experience to make sure that we meet the time allocated for these presentations. So by now, we know that children and adolescents who develop SARS-CoV-2 infections 4 to 6 weeks later, they might have a cytokine storms that involving innate and adaptive immune system and result in hyperinflammatory immune response. And the end of the cascade of this response may result in tissue damage, including coronary involvement. And the question comes, why not every child who developed COVID-19 infections will have MIS-C? And our understanding about this now is much better. So if a kid gets infected with certain variants of COVID-19 infections in a genetically predisposed host who have genetic mutations in encoding signaling cascade, as well as mutations in suppressors of cytokine signaling 1, will result in hyperinflammatory response, and the end of this cascade will lead to activations of or production of antibodies and extravasation of innate immune cells, including T cells. The antibodies will result in complement activations, and with extravasation of T cells will result in tissue damage, and that will result in end organ damage. So CDC developed the case definition for MIS-C to make sure that practitioners have something to refer to, and we know that age less than 20, in a patient who's age less than 21 years, who have fever for 24 hours, subjective or objectives, and have evidence of hyperinflammatory state by laboratory, as well as they presented to the hospital in ill conditions with 2 system involvement, and no alternative diagnosis has been entertained, as well as they test positive for COVID-19 or have epidemiological link with exposure to COVID-19 within 4 weeks of their presentations. And this is the major difference between WHO and CDC case definition, where in WHO, they didn't mandate the 4 weeks durations between the exposure to COVID-19 and the clinical presentations. When it comes to our experience in Saudi Arabia regarding the COVID-19 infections, the first report came from our centers reporting 742 cases. 10% of them require hospital admissions, and among them, 7 cases admitted to PICU. 5 of them were diagnosed with MIS-C, and we have 2 mortality, and unfortunately these mortalities were MIS-C cases. The second report came from 3 centers in Saudi Arabia reporting the patient who's admitted to the hospital with MIS-C. 88 patients were admitted, and 7 of them were admitted to PICU. 3 of them received the diagnosis of MIS-C, and 4 mortalities, 3 of them were MIS-C cases. And the other reports came from Eastern Province of Saudi Arabia reporting 10 cases with MIS-C, and all these cases had clear exposure to COVID-19 infections. They had 2 mortality of these cases, and obviously G6PD is quite common in Eastern Province, so some of these cases they have G6PD. The other report was a prospective report from Southern region in Saudi Arabia of 5 cases, and they all have epidemiological link to COVID-19 infections. They all presented with shock, and they had also 2 mortality among these cases. So understanding the seriousness of MIS-C cases, we thought that we should conduct a multi-center study in Saudi Arabia describing the clinical, laboratory, and radiological characteristics, as well as the outcome of children who's affected with MIS-C. So we have 7 centers participated in the study from different regions in Saudi Arabia, and we get total of 54 cases, 1/3 of them less than 2 years of age, and 1/3 more than 5 years. The rest were in between. 55% were male and 44% were female. Unfortunately, we have 9 deaths among these cases. BMI was normal for these cases, so there was no link to obesity, and ethnicity was mainly Arab, but there were cases that they are non-Arabs, and knowing that many centers near Al-Haramain were involved in the study would explain that. 70% of the cases had COVID-19 exposure. PCR was positive in 87%, and serology was positive in 5.6 cases. Most of the cases were healthy. However, there were cases who have comorbidity, including neurological, heart disease, hematological, immunodeficiency, renal, as well as respiratory problems. And we looked up the factors that might be associated with or linked to the mortality in these cases. We found that patient had, or the fever was a universal presentation in all cases. Respiratory symptoms was almost in near 60% of the cases, and GI symptoms as well in 63%. CNS was almost 10%, and rash was skin rash was also 64%. Pediatric risk of mortality score was very high in the cases, particularly those patients who died and with significant p-value, as well as we found that acute kidney injury as well as arrhythmia was also linked to the mortality. Platelets count was higher in patients who died, and also procalcitonin D-dimers, LDH, were also high in those cases who passed away. Also urea and low albumin was associated with significant p-value for those patients who had died. When we review the treatment modality that has been received in these cases, 93% of patients received IVIG, 87% received steroid, 50% received aspirin and antiviral therapy as well as inotropes, and 40% biologic therapy, namely anakinra, and 31%, and tocilizumab, and 15%, and 1/3 of the cases received low molecular weight heparin. Comparing our result to similar cohorts from different continents, we find that our cohort has low or lower mean age compared to the previous reported studies, and we found that shock is quite common in our cases, as well as that PCR testing is 87%, which is a bit high compared to any previous studies, while serology is only 5.6%. When it comes to the treatment options, almost the same way of treating a patient that's been reported in previous studies. However, ECMO was not used in our cohort, and 16% mortality, which is a bit higher compared to a previous study. The nearest study that reported almost the same percentage was 14% from India. Why we have higher mortality rate? I think previous study report cases that been admitted to the general ward as well as ICU, while we only reported cases that's been admitted to ICU. And our cohort also has high PRISM score to start with at their admission to the hospital, and sizable number of them have left ventricular dysfunction, as well as they are younger age, which had been tightly linked to mortality with patient who has MIS-C. ECMO also is not available in all the centers that's been included in the study, so that may change some outcome of those patients if it's been received. And lack of standardization protocol that's been practiced in Saudi Arabia may allow some variability in approaching these cases when it comes to the management across all the centers. What would be the major limitations of the study? I think being retrospective as well as being multi-centers may give a chance for missing some data, and the age limit in pediatric care in Saudi Arabia is limited to age of 14. As we learned from literatures that mortality may vary according to the age, and if we include the higher age, probably will have a better outcome. There are currently no agreed upon management protocol for MIS-C in Saudi Arabia, which may allow some difference in approach of treatment in these cases among practitioners. So to conclude, I think we were able to describe clinical laboratory characteristics in 54 patients who had been diagnosed with MIS-C in different centers in Saudi Arabia. And the finding is almost similar to previously reported finding, apart of the mean age that I have mentioned, younger in our groups, and also the higher mortality rate. And higher mortality rate might be explained by younger age, high PRISM score at presentations, and also being positive PCR in most of the cases may, we speculate that those patients are presenting early in their course of the disease rather than the typical presentation of MIS-C, which is 4 to 6 weeks after the COVID infections. So I think in any emerging conditions similar to COVID-19 or MIS-C, it would be great for people to standardize their protocol approaching these cases, and they, if they consistently follow the protocol, that will make sure that they unify their practice. We're fortunate to have this paper published in Current Pediatric Research, and I would like to thank all the participating centers from different regions in Saudi Arabia, the colleagues who co-authored these papers, and I'll be happy to take any question. Thank you so much.
Good afternoon, everyone. It gives me great pleasure to be share the meeting with my colleague, Dr. Buthaina. We will continue the theme of multi-system inflammatory syndrome. It gives me great pleasure to introduce Dr. Banan Saud Al-Ruwaith. She's a pediatric rheumatology consultant in King Sulaiman Medical City, Medina, Deputy Director of Pediatric Department, Ministry of Health, and member of Saudi Society, Ministry of National Guard Health Affairs. And she will be talking about pattern of clinical manifestations and outcome of multisystem inflammatory syndrome. With great pleasure, Dr. Banan.
Assalamu alaikum. Good afternoon. I would like to thank organizing committee to give me the chance to present my research work about pattern of clinical manifestation and outcome of multisystem inflammatory syndrome in children. No conflict of interest to disclose. My outline, background, study aim, objective, methodology, result, discussion, conclusion, and reference. Initially, reports suggest that children infected with COVID-19 present with mild upper respiratory illness. Earlier in May 2020 investigation in London, they reported 8 severely ill patients with hyperinflammatory shock and multi-organ failure. So, MESI is a rare but serious complication associated with COVID. It is variable clinical presentation based on age, time of presentation, and clinical subtype. Our aim to describe the clinical and laboratory characteristics as well as treatment and outcome of the patient with MESI. Primary objective to determine the clinical and laboratory characteristic of patient with MESI, to determine the treatment of outcome of the patient with MESI. About secondary objective to identify the risk factor associated with MESI patient. This is a retrospective cohort study including a total of 13 patients. Inclusion criteria: all the patients diagnosed with MESI at King Salman Medical City in Maternity and Children Hospital, Medina, Saudi Arabia from May 2020 to June 2021. All of them hospitalized and younger than 14 years old. MESI diagnosis was considered based on patient symptoms, physician assessment, imaging finding, depend on CDC and WHO criteria for MESI. This is study variable. Our study variable, demographic data, comorbidity, onset of the symptom before admission, date of admission, and date of diagnosis. Then clinical manifestation, fever and Kawasaki symptoms, even the sore throat, GI involvement, renal and respiratory involvement, cardiac involvement, and need for mechanical ventilation and anthropic support. History of previous COVID infection or exposure to COVID patient. About the lab, lymphocyte count, neutrophil count, and platelet count, renal and liver function, cardiac enzyme, ferritin and inflammatory marker, sodium albumin, and COVID PCR. About radiology, echo, abdominal ultrasound, and chest X-ray, management-wise, systemic immunomodulator involve IVIG, systemic corticosteroid, and biological DMARD. Lastly, PICU admission, duration of hospital stay, and outcome. The result, as you show here in pie chart, there is 13 patients, mainly female, 7 patients were female, 53.8%. Median age of presentation was 7 years old. Also here, mostly of the patient, no comorbidity, about 92%. 8% there is comorbidity in between bronchial asthma and febrile convulsion. In this slide showing history of contact with COVID-19 patient or previous infection, yes, positive in about 69.2%, and COVID PCR negative, most of the patient, about 84.6%. The median time between exposure to COVID or COVID infection to presentation, about 4 weeks. We found 100% they have fever, and most of the patient, 92.3%, they have conjunctivitis, puffy eyes, and GI symptoms. They have depressed cardiac function in about 84.6%, requiring mechanical ventilation in 30.7%. Labs-wise, we have 100% they have anemia and hypoalbuminemia. Anemia, the median hemoglobin level, it was 9 gram per deciliter. Hypoalbuminemia, median albumin level 16 gram per liter. About the hyponatremia, they have 92.3%. They have hyponatremia, median sodium level 128 milliequivalent per liter. There is neutropenia and lymphopenia. Also high triglyceride in about 92.3, median triglyceride level 4.5 millimole per liter. About renal function and liver function high in about 84.6%. Management-wise, about immunomodulator, 100% of our patients received IVIG and systemic steroid. About biological medication, tocilizumab used in about 61.5% and anakinra used in about 15.3%. At that time, the tocilizumab is the first choice from the biological agent. Outcome, our patients showing good response and excellent outcome, survival rate about 92.3. About international and local data, I will start from USA. There is a lot of the study there. I choose the earlier one, it's about reported case series, report 6 critical patients, and there is this. After that, they start by systemic review and meta-analysis, and lately a scoping review in about 875 patients from 15 countries. All of them, they have fever 100%, abdominal pain is more prominent, and GI manifestation about ranging from 80 to 70%. From Brazil, there is a case series also and multi-center, the cohort study from multi-center about 56 patients, GI symptoms 71% with cardiac and shock about shock about 59 and cardiac 20. The dimer, it was very high in about 80%. From Spain, there is a multi-center study, 45 patients. They have more prominent GI symptoms and fever. From the France, they have they found GI manifestation about 92% and cardiac vascular affection about 80%, near to our result in our study. From the Middle East, also there is, we'll start from Egypt. They have one study, the patient suffering from MESI, they treated with IVIG, corticosteroid, infliximab, tocilizumab, and anakinra. Here also another genomic and phenotypically characteristic, one study from, between multi-center between Jordan and Emirates. They have 45 patients, average age 7 years. Also, they found GI manifestation about 80% and neurological manifestation 31%. They did gene study for all the patients. They found 19 patients, they have gene mutation. In Saudi Arabia, we have a lot of study. I chose the earlier one, case series from the East region. They have 10 patients from Al-Ahsa hospital. And also after that, from South region, from Abha, reported 5 patients of the MESI. After that, there's a national multi-center cohort in Saudi Arabia, present 54 patients, mainly of them, it was boys, and GI manifestation in about 63%. From Qatar, this is a earlier case series in Asia, and first one in earlier 2020, they report 7 patients, median age younger 5.6 year, and fever and GI manifestation are prominent. From Oman, also there is 6 children case series. All of them, they showed complete recovery with supportive management, IVIG, and steroid. 1 patient only required tocilizumab. Our study showed the clinical presentation of patients similar to other MESI patients in previous study. In contrast to our study, our patients are older than them. Most of our patients present with GI symptom, conjunctivitis, puffy eyes, and sore throat without upper respiratory symptoms. Early detection and high index of suspicion, along with early intervention associated with low mortality and better outcome, short duration of BICU stay, so decreased duration of decreased duration of admission. Our study limitation, the current study is limited due to retrospective nature, single center study, small number of patients. In conclusion, multi-system inflammatory syndrome in children is a serious condition that require high index of. However, early diagnosis and early treatment with adjuvant anakinra and use of anakinra or tocilizumab may improve the outcome. This is, you can scan it. And this study reflects King Salman Medical City Pediatric Rheumatology team experience. I want to thank my research team, Shahad and Dr. Masoud, Dr. Reem, and Dr. Shaima. Thank you for your attention. All questions are welcome.
Thank you, Dr. Banan. I have multiple questions for you, but we'll leave it till the end. It gives me great pleasure to introduce our fifth speaker, Dr. Zaid Al-Hinai. He did his medical education at Tufts University and his fellowship in pediatric infectious diseases at Brown University in the United States. He's assistant professor and consultant, pediatric infectious diseases consultant, College of Medicine, Sultan Qaboos University. Disease and osteoarticular infections. Dr. Zaid, please go ahead with your abstract on Kawasaki disease scoring system. Thank you.
Very much, Dr. Khulud. Thank you for the Bismillah ar-Rahman ar-Rahim. Hello, everybody. Thank you for joining me in this lecture. My name is Zaid Al-Hinai. I'm a pediatric ID doctor and assistant professor at the College of Medicine and Health Sciences at Sultan Qaboos University. And I'll be talking to you today about Kawasaki disease in Oman and our research where we made a new severity scoring system named the Muscat Index of Kawasaki disease severity, or the MIX score, which helps to predict IVIG resistance and coronary artery dilatation. So Kawasaki disease, as you know, is the leading cause of acquired heart disease in developed nations. Coronary aneurysms occur in about 25% of untreated cases. This can be reduced to about 5% with IVIG treatment. However, some challenges do exist, such as IVIG resistance, which happens 10 to 20% of the cases. Also, among those 5% of cases that have coronary aneurysms, there are other treatments that maybe can help. In Oman, we don't have a lot of data, but we do have a study from 1995-2002 that showed a 12.5% incidence of coronary artery lesions among cases. So if there is IVIG resistance, or if the case is determined to be at high risk for IVIG resistance or other complications such as coronary lesions, there are additional treatments now that are recommended, such as the steroids or other immune modulators. Currently, the Kobayashi score is really the only kind of scoring system that is widely used around the world for predicting IVIG resistance. However, it has been shown to have variable performance in other populations outside of Japan. So it's not always clear that it's the best score to use in every population. So the main questions we had are, how well does the Kobayashi score perform in a population in the GCC area? And does the prediction of IVIG resistance, is that sufficient, or should we also look at predictors of coronary aneurysms directly? And the third is, maybe can we develop our own score here in the GCC? So the primary objective of our study was to predict the presence of IVIG resistance or coronary artery dilatation at the 6-week follow-up. In other words, this was a composite primary score. We looked at IVIG resistance alone and coronary artery dilatation alone, but we decided in the end that we want to be able to predict both of them early on and use that as the basis to find high-risk patients. Our secondary objectives were to describe recent trends in Kawasaki disease in Oman and also create the predictive score. This was a retrospective study, included all children under 13 years of age at Sultan Qaboos University Hospital and the Royal Hospital. These are the two main tertiary care referral centers in Oman. This was conducted between the year 2008 and 2019 in children with a diagnosis of Kawasaki disease. Cases were excluded if the diagnosis criteria was not fulfilled based on the documentation, the chart, or if the patient was lost to the 6-week follow-up where we didn't have any follow-up at 6 weeks. We did a bivariate analysis to identify significant predictors of the primary outcome and multivariable logistic regression to determine independent predictors. And we created the Muscat Index of Kawasaki disease severity mix, the mix score, based on the results of these statistical results or analyses. In terms of definitions of terms, IVIG resistance was defined as fever after 48 hours from administration of the initial IVIG dose. Coronary artery dilatation was determined or defined based on accepted definitions in the literature, as you see. The statistical analysis was done using SPSS software, and ethical approval was obtained from both institutions. So 520 charts were identified. There was a number of them that were duplicate, and a number where there was another diagnosis after review of the chart, or there was no follow-up, or data was missing. And so a total of 156 patients were enrolled or included in the study. The median age was 2.1 years. Majority were male, 1.9 to 1. And age under 1 year was 39 patients, which was 25% of the total group, which is a little bit high. And this is the age distribution. You can actually see that the most represented age group was younger than 1 year of age, and followed by the other ages. And as you can see, the majority were under 5 years of age, as would be expected. What is not expected, though, is that the peak is at under 1. So our sample skews a little bit younger, and we think this might be related to the referral nature of the centers where the studies were done. So probably a child under 1 year of age with Kawasaki disease was more likely to be referred than older children. So we might be, our sample might be skewing towards more severe or high-risk patients. This is a trend of diagnosis. So these are the cases identified each year. You can see there's actually an increase in recognition over time. Here in 2016, there was the opening of the heart center at the Royal Hospital, so that maybe increased the cases by increasing referrals. However, there is increasing numbers, and even if you control for the number of children under 10 years of age, so you go cases per 100,000 children under 10 years of age, still there is rising numbers. So it's not just explained by population growth. We think this is more likely to be increased recognition, as there is now a pediatric residency training program in Oman, and so there is an increasing number of pediatricians in the country who are probably recognizing Kawasaki disease more readily than in previous years. We try to look at seasonality, and as you can see, there is a peak in May and a peak in October. So there might be a slight peak of cases in the spring and a peak in the fall. However, it's not really very clear that there's a seasonality of this disease. In terms of presentation of the cases, the preceding duration of symptoms was 7 days, mean interquartile range 5 to 8. Days from presentation to IVIG was only about 1 day. So we don't think there was a major delay in diagnosis and treatment in most cases. Days from onset of symptoms to IVIG was about 8, with the interquartile range of 6 to 9. So about 24% of the cases did receive IVIG on day 10 or later. So 24% had kind of a late treatment. There's also 18%, and that's mostly accounted by late presentation to the hospital. So 18% presented to the hospital with 10 days of symptoms or longer. About 33% had incomplete Kawasaki, and the remainder had fulfilled all the criteria. In terms of treatment, everybody got IVIG and aspirin. About 17% got steroids. Use of steroids increased in recent years, but the study goes back to a time when when steroids weren't used very commonly. 12% of the patients were found to have IVIG resistance. 53% were deemed high risk by the European criteria, which is Kobayashi score of 4 or higher, or age under 1 year, or coronary lesion on initial echo. Length of stay median was 5 days. Coronary lesion on initial echo was found in 26% of the cases and 18% at 6 weeks follow-up. So we looked at a whole lot of predictors of IVIG resistance, you can see in these tables. And what we did find as the more significant or close to significant variables were young age, hemoglobin, this is mainly anemia for age, high WBC count, high neutrophil count, high CRP, male gender, and elevated ALT. So these were deemed significant enough to be entered into multivariable logistic regression. And after that, we got a model, a predictive model based on high CRP, male gender, and high WBC count. With this model, we simplified the calculation, and that's how we got the mixed score. So if you had a CRP greater than or equal to 150, you got a score of 2. If your white count was greater than 13.5, you add a score of 1. Greater than 19, you add a score of 3. And if you are male gender, you get a score of 2 added. And so altogether, the maximum score is 7. The optimal cutoff was 4. So if you're male gender and you had a high CRP, you were considered high risk. If you had a high WBC count and you're male gender, you're considered high risk. Or if you had a high WBC count and a high CRP, you were high risk. So basically, you had to have essentially 2 of these categories fulfilled to be considered high risk based on the mixed score. So this is the receiver operating characteristics curve for the mixed score compared to the logistic regression model, compared to the Kobayashi score, compared to the IGAMI score. Here we unfortunately had to use an approximation of the Kobayashi because one of the institutions did not actually measure the AST, they only measured the ALT routinely. And so we had to use that as a surrogate marker for elevated liver enzymes. So the Kobayashi score, we have to admit here as a limitation of the study, is not exactly the Kobayashi score. In half of the patients, we had to use an approximation. But you can see that the ROC curve for the mixed score follows the logistic regression model very well. And it also seems to perform a little bit better than the Kobayashi score, although this is not statistically significant, the difference. Now, this is the this compares the different risk criteria in terms of sensitivity, specificity, and the significance. So that you can see the Kobayashi score in terms of predicting the composite outcome, which is IVIG resistance or coronary dilatation, was only 40% sensitive. So it cannot be relied on by itself. And that's what's been found in other populations where the recommendation is to also look at young age and look at coronary lesions on presentation. And this was almost statistically significant. The mixed score on its own seemed to have higher sensitivity but similar specificity to the Kobayashi score. So it seems in our population, the mixed score is better at predicting IVIG resistance or coronary dilatation. And then if you combine the mixed score with other high-risk criteria, such as age under 1 year and or coronary artery dilatation, then you get a sensitivity of 95% and a specificity of 56%. So basically, you almost don't miss any high-risk cases if you take the mixed score with the high-risk criteria. Whereas if you take the Kobayashi with the high-risk criteria, you get 85% sensitivity, so you miss some. So we think this looks really promising for our scoring system in our population. We can apply the mixed score in addition to the other criteria, which are young age and coronary lesions at presentation. And that we think will allow us to identify almost all high-risk patients and treat them appropriately. Limitations of studies is retrospective. The Kobayashi score we used is not exactly the Kobayashi score, is an approximation. The numbers could be larger, and this was being retrospective, but there is no control exactly of the management. So the protocols shifted during the study period. There's also referral bias, so we're seeing more severe cases at the referral centers. So in conclusion, we think we have observed that there's increasing recognition of Kawasaki disease in Oman. We believe the mixed score is showing very good promise in being the severity score of choice for the Omani population, and maybe it can be expanded to the GCC. So what we're looking for is to find prospective validation for the mixed score in Oman and in the other GCC countries. So we would like to open our arms to anybody who would like to collaborate and try to test the score and maybe improve it further, or at least validate it prospectively in the GCC. Thank you for your time.
Thank you, Dr. Zaid, for an excellent presentation. I'm sure most of us will be interested in validating and contributing to your excellent scoring system. Okay, moving on. A great pleasure to introduce our last speaker for this session, Dr. Abdulrahman Al-Rashid. He's a pediatric rheumatology consultant, and he's also pediatric rheumatology fellowship director in King Abdullah Specialized Children's Hospital, Ministry of National Guards in Riyadh. His abstract is on inflammatory myositis. Please, Dr. Abdulrahman, go ahead.
I would like to thank the organizing committee for choosing this subject, inflammatory myositis, and for choosing me to give this subject. I would start with, it's really difficult to go over the every aspects of inflammatory myositis. So I would just go over myositis specific and associated antibodies. So my outlines overview of myositis specific and myositis associated antibodies. And this is going to be from adult literature. Then I will go over some examples from different pediatric cohorts. We have 3 large cohorts from Japan, UK, and North America. Then I would just speak a little bit about our ongoing cohort from Saudi Arabia, which is now ongoing. We have some data, and I will give you the available data from our project. First, overview of myositis-specific antibodies and myositis-associated antibodies. Juvenile idiopathic inflammatory myopathies are a heterogeneous group of diseases with different manifestation, different organ, specific organ involvement, and also with different response to therapy. It's subcategorized subcategorization of inflammatory myopathies or myositis was formed on the basis of phenotype to dermatomyositis, polymyositis, and overlap. In adult, also they have the muscle biopsy or the pathology phenotype. The pathogenesis result from interaction between environment and genetic susceptibility, and this would be clear by different manifestation in different cohorts. 60 to 70% of patients with inflammatory myopathies have positive autoantibodies, and it's helpful in diagnosis and predicting the phenotype, prognosis, and may affect the treatment decision. The myositis-specific antibodies initially was discovered back to 1976. They discovered anti-MI2. Then subsequently, the other myositis-specific antibodies were discovered till recently anti-MDA5, anti-HMGCR, which is associated with the statin intake. The biggest revolution for the myositis specific antibodies and associated antibodies was beyond 2005 for pediatric patients. So we have 55% discovered since 2005. Still, we have 30% with negative autoantibodies. Almost the same thing for adult patients. They have 35% of unknown autoantibodies. The manifestation is clustered according to the myositis antibodies. So probably you could see MDA5, they present usually as acute, and sometimes with the rapid progressive lung involvement. Mainly they have a skin manifestation with less muscle involvement. Some of them, they may have amyopathic picture. The other manifestation like TIF1 gamma and NXP2 associated with malignancy. TIF1 gamma usually or specifically associated with malignancy in adults more than 40 years of age. The anti-RNA synthase antibodies, it's a chronic sort of disease. They associated with the chronic disease and with involvement of lung, with interstitial lung disease, which develop over time. So we'll speak first about anti-amino acyl tRNA synthase. There is 8 different antigen for those antibodies. The commonest is anti-Jo1 antibodies. The patients have common clinical manifestation in form of fever, Mechanic's hand, Raynaud's phenomena, interstitial lung disease, and usually it's a chronic progressive, and this is the cause of mortality in adult patients. Interstitial lung disease usually associated with the presence of Mechanic's hand, plus myositis with high CK and arthritis, especially with anti-Jo antibodies. Also among those, the interstitial lung disease usually associated with PL7 and PL12. Those antibodies constitute less than 5% of childhood myositis. The next is anti-melanoma differentiation associated gene 5, MDA5. It is a the MDA5 is a cytoplasmic retinoic acid inducible gene 1 like receptor that upon recognition of viral RNA induce expression of type 1 interferon. It detected in almost 50% of adult patients. They have low CK level with a picture of amyopathic dermatomyositis. And high frequency of ILD, up to 90%, especially in the Far East Asia, with the rapid progressive interstitial lung disease in 50 to 80% of patients. Also, they may have elevation of the hepatobiliary enzymes. They also do have elevation of ferritin, and the serum ferritin, in fact, it may correlate with activity of interstitial lung disease. Anti-MDA5 titer could be used to monitor disease activities and a good predictor for relapse. Upon upregulation of interferon in this type inducible, there is upregulation of interferon inducible gene in patient with ILD. So probably JAK inhibitor may be helpful in in some refractory cases. There is a study done by Japanese people. They combine cyclophosphamide plus calcium urine inhibitor and high-dose glucocorticoids, and they found, they used it in patients with interstitial lung disease, and they found a high rate of survival after 1 year as endpoint of their study. Up to 89% they survive, compared to the historical cohort, which they had a significant mortality rate. Anti-MI2 patient present usually the classic dermatomyositis associated with the mild myositis, fair response to therapy, and good prognosis. There is a relation between ultraviolet light exposure and MI2 positive dermatomyositis, as the antigen predominantly expressed in the skin. Anti-TIF1 is first reported as anti-155 over 140. Then 155 KDA protein was identified as transcription intermediary factor 1. It's found in 20% of dermatomyositis patients. It has positive association with malignancy, especially for those more than 40 years of age, has negative association with interstitial lung disease, and is associated with cutaneous manifestation and moderate CK elevation, and it's associated with calcinosis. Anti-NXP antibodies originally reported as anti-MJ. It occurs in 30% in adult dermatomyositis patients, and they manifest with severe muscle disease and lower remission rate, with high frequency of calcinosis in children. It has association with the malignancy. The next is anti-signal recognition particle, and this detected in up to 15% of adult patients and in 2 to 4 of juvenile patients. It's associated mainly with polymyositis with less skin involvement. Patients, they have severe acute muscle weakness, disability, dysphagia, and very high CK. It's associated with immune-mediated necrotizing myopathy and muscle biopsies. Patient usually refractory to treatment. Then I would speak about myositis-associated antibodies to include the following: anti-polymyositis SCL antibodies, anti-U1-RMP, anti-Rho52 antibodies, and this is the commonest the commonest antibodies associated with other myositis-specific antibodies, anti-Q. I would speak just a little bit about anti-polymyositis scleroderma. Patients, they manifest with dermatomyositis rash, with sclerodermatous skin changes, mainly sclerodactyly, and there is muscle involvement. It's associated with calcification, and those patients, they have high risk for interstitial lung disease. This is just summarizing the all myositis-specific antibodies. Then I will go over the pediatric cohort. So I will first speak about Japanese cohort. It's a multi-center retrospective study from 9 centers. Juvenile idiopathic inflammatory myopathies was defined as definitive or probable case of JDM or juvenile polymyositis according to Bohan and Peter criteria. Patient fulfilling the classification criteria of other autoimmune disease in addition to juvenile idiopathic inflammatory myopathies were included. Patients with typical cutaneous symptoms without evidence of muscle involvement were diagnosed with juvenile amyopathic dermatomyositis. They define the inactive disease that the patient doesn't have any clinical or serological or inflammatory or laboratory features of active disease. And they define drug-free remission if the patient is not taking any medication and he has inactive disease. So they included 96 patients. Myositis-specific antibodies were detected in 85, which constitute 89%. It's mainly on female, it affects mainly female patients. 31 patients has had MDA5, and 25 anti-TIF1, NXP2 in 25 patients, and anti-MI2 in 4, and anti-ARS antibodies in 1. all anti-MDA5 and TIF presented with juvenile dermatomyositis. There was any case of macrophage activation syndrome. Interstitial lung disease was the initial symptoms on almost a third of patients with MDA5, and calcinosis occurs in 4.3%. Interstitial lung disease in it occurs in 80.6 with anti-MDA5 over the disease course. Anti-MDA5 were more likely to have fever, arthritis, fatigue, and weight loss. And anti-TIF1 more likely to have malar rash and heliotrope rash. Anti-NXP2 more likely to have muscle weakness and myalgia, but less likely to have interstitial lung disease. Treatment with glucocorticoids and methotrexate for most patients, except for those with anti-MDA5, where they used calcineurin inhibitor and IV cyclophosphamide in more than 50% of those patients. One death have occurred among all 96 patients, and the cause of death was interstitial lung disease, an MDA5 patient who received glucocorticoids, MMF, and cyclophosphamide. 20.8% patient achieved drug-free remission. Patients with anti-MDA5 have a lower rate of relapse and higher rate of drug-free remission. The relapse rate of patients with anti-MDA5 plateaued by 50 months after therapy. Patient with NXP2 relapsed more frequently within 2 years of treatment, and the incidence of relapse in these patients was trending down. Patient with TIF1 experienced a steadily increased relapse rate and associated with a chronic disease. This is probably you could appreciate the relapse rate. The anti-MDA5 plateaued after 50 months, where there is increment in the relapse rate in patient with TIF1. In patient with TIF1, again, they compare anti-MDA5 positive with negative, and they found those with positive MDA5, they have less relapse rate in this graph. And the one down, they compare TIF1 positive with TIF negative, and they found the TIF positive have more relapse rate, and NXP2, it's almost the positive, and the negative one, almost they were same with time. And they look to a drug-free remission, and probably you could appreciate anti-MDA5, it's increased steadily with time. Same thing in the second graph. The third is the TIF1 positive compared to TIF negative. And probably you could see that the drug-free remission became static with time. And with the NXP2 positive, there is increment with time, but less than a patient with NXP2 negative patients. Then I will speak about North American cohort. They had 374 patients. Among them, 253 had positive myositis-specific antibodies, around 68%, and 121 no myositis-specific antibodies were detected. Most frequent myositis-specific antibodies was anti-TIF1 in 32%, NXP2 in 20%, and anti-synthase in 4.4%, anti-signal recognition particle in 1.4%, and MI2 in 4.4%. In this study, they didn't include anti-MDA5, but they included in another one, which I will go through it. Several patients had more than one myositis-specific antibodies. Most common myositis-associated antibodies was anti-Rho, 51. 2/3 of their patients were female, and anti-signal recognition particle mainly happen in older children. Probably you could see here different myositis-specific antibodies and the main features. So anti-synthase usually happen in older children, mainly with arthralgia, mechanics hand, and interstitial lung disease. While anti-signal recognition particle, a large proportion in a Black patient, and a severe or very severe phenotype. They present mainly with distal weakness, falling episode, and Raynaud's phenomena, and they have very high CK level. While anti-MI2 patient constitute larger proportion of non-white patient, mostly Hispanic, and they have high CK level. While the anti-P155 over 140, which is TIF1, larger proportion of white, those patients presented mainly with cutaneous feature, malar rash, shower sign, photosensitivity, cuticle overgrowth with lowest CK level, while patient with MJ, which is NXP2, they have muscle cramps mainly, and they have, some of them, they may have monocyclic course, however, they have high hospitalization rate. While those with myositis negative patient, they have arthralgia and monocyclic course on just above third of the patient. Then they reported from North America the anti-MDA5, and it was present in 35 out of 453, which constitutes 7.7, which is a low percentage. And probably this because this cohort constitute mainly Caucasian patient. And this would reflect the effect of ethnicity on the type of antibodies present in a population. It happened in more older and had low serum CK and aldolase, more frequent weight loss, adenopathy, arthritis, and interstitial lung disease, fever, oral and cutaneous ulceration, and palmar papule. 26% they had interstitial lung disease, 6% of them with rapid progressive interstitial lung disease, and 1 death due to MDA5. 3 patients has had hepatic involvement. They have less frequent dysphagia. MDA5 associated interstitial lung disease received longer steroid duration and cytotoxic or biologic medication and had no documented of therapy. And this is probably the effect of those antibodies on the treatment choice. The frequency of remission did not differ from other, but was higher than anti-synthase. It is a monocyclic course in 26% of patients. Then the UK cohort of anti-MDA5, 7.4 out of 285 patients had anti-MDA5. It was associated with oral and skin ulceration, arthritis, and milder muscle disease. A greater proportion achieved disease inactivity at 2 years post-diagnosis. 4 out of 12 have had ILD, none had rapidly progressive ILD. 225 out of 380 had positive myositis specific antibodies or myositis associated antibodies in another cohort in UK published later, which constitute 59%. None of patients with, they include also in this study patient with GIA, patient with SLE, patient with muscle dystrophy, and healthy children, and none of them have the those antibodies, which indicate the specificity of those antibodies to myositis. Anti-TIF1 was the most prevalent. It was associated with cutaneous ulceration and greater muscle weakness, as determined by CMAS. Those patients more likely to receive biologic and or IV cyclophosphamide. And probably you could see here the different percentage among their population. Anti-NXP2 was associated with greater muscle weakness and calcinosis. Anti-MDA5 was inversely associated with muscle weakness associated with cutaneous ulceration and arthritis, and 19% had ILD. Anti-synthase was inversely associated with muscle weakness, anti-PL7 and anti-PL12. Among the anti-synthase have high risk for ILD. Antipolymyositis CL associated with calcinosis and lipoatrophy. This is our just preliminary data of our cohort, which involve some hospital in Saudi Arabia. This is, by the way, my email if there is anyone who wants to participate in this ongoing study. The method, it's a retrospective multi-center study, and we included patients with JDM, juvenile polymyositis, or overlap myositis. with definitive or probable according to the Cohen and Peter criteria. So those patients with positive MCA or myositis-associated antibodies included, and the aim of the study to describe clinical manifestation, course of the disease, treatment, and outcome. So we had till now 16 patients with JDM, juvenile myositis, and overlap myositis with positive antibodies, 12 girls and 4 boys, and the age of presentation ranging from 18 to 156 months. 14 patients with myositis-specific antibodies, and we have 2 patients with myositis-associated antibodies, 11 patients with JDM, while 3 patients manifested with polymyositis and 2 with overlap. 7 patients had positive anti-MDA5, 4 patients with anti-NXP2, 2 patients with anti-Jo1, and 1 patient with TIF1. And there is a 3 patients with polymyositis SCL, with among 2 of them isolated in 2 patients as the only myositis-associated antibodies, and 1 patient was associated with MDA5. Patients with anti-MDA5 tend to have systemic symptoms, including fever, weight loss, skin ulcer, inverse Guttman papule, and high ferritin. Patients with NXP2 have calcinosis, 1 patient with GI perforation, and 1 patient with undifferentiated non-keratinizing nasopharyngeal carcinoma. Calcinosis with scleroderma, JDM manifestation was the main feature of polymyositis SCL. 4 patients had leukopenia, and 1 with high liver enzyme and positive anti-smooth muscle antibodies. 1 patient with anti-MDA5 has laboratory and clinical features of macrophage activation syndrome. Treatment include high-dose steroid, methotrexate, IVIG, cyclosporine, rituximab, and cyclophosphamide. And there was 2 patients also JAK inhibitor were introduced to them. Treatment tends to include cyclophosphamide and biologic for anti-MDA5 plus JAK inhibitor. Most of the patients achieve remission, and 2 patients continues to have calcinosis. They were having NXP2. 2 patients died with rapid progressive interstitial lung disease. Both had anti-MDA5. Both of them below 5 years of age, and the bad outcome occurs at the first 6 months of their illness. This is just to show you the inverse Guttman papule and some probably ulceration at the interphalangeal, at the palmar side of the interphalanx. This is one of our patients. Probably, I'm not sure if you could appreciate the inverse Guttman papule here and here. And this is also a patient with anti-MDA5 with ulcerations. Again, patient with ulceration. So in conclusion, myositis-specific autoantibodies are present in the majority of juvenile idiopathic myopathies. The discovery of those antibodies provide insight about pathogenesis of juvenile idiopathic myopathies. Anti-TIF1, NXP2, and MDA5 autoantibodies are present in over half of patients. They can identify distinct subset of disease. Anti-MDA5 antibody is a risk factor for rapid progressive interstitial lung disease, which carries the highest mortality in juvenile idiopathic inflammatory myopathies. Anti-NXP2 antibody has risk for calcinosis and malignancy, and anti-TIF1 has association with chronic disease course. And I am happy to take any question. Thank you very much.
Thank you everyone for excellent and very interesting session, full of fantastic science. We'll open it to questions now. While we're gathering some questions from the audience, I'll start with a small question. I think we'll start with Dr. Zaid. You gave excellent talk about Muscat scoring system for Kawasaki disease, and this is fantastic. And hopefully everyone will get interested and validate and make it GCC wide. What I wanted to, I think you've explained very well everything. I was writing the questions and then you answered them straight away. But I wanted to, so you rely on high CRP male, high WCC, you pick up the very high risk, the ones who present with coronary artery dilatation. And obviously, speaking with pediatricians, always the aim is to pick these ones before. Can you envisage a next score or a way derivation from this score that we're going to be able to pick these very high risk ones a bit earlier so they don't get to this stage?
Yeah, I mean, that's all the criteria we have are on presentation. So basically the idea is a child comes in, diagnosis of Kawasaki is made. At the same time, you look at the gender, CRP, and the white count, calculate the mixed score, and look at also other high-risk criteria, like if the child's under 1 year of age, or if the echo already shows some coronary lesions. And so if you have a mixed score 4 or above, or coronary lesion on echo, or age under 1, our data, which is retrospective, it shows that basically have 95% sensitivity and 54 or 56% specificity that this child is going to have either IVIG resistance, or in the 6-week follow-up will have coronary dilatation, which would probably be a reasonable indication to give additional treatment to IVIG, basically give steroids or your preferred immune modulator. So when we did this with the Kobayashi score that we could calculate, it was 85% sensitive. So we think it could be an improvement, and it is designed for our population here in the Middle East. The elements of the score, especially the CRP and the white count, make a lot of sense because those are indications of very high level of inflammation on presentation. The male gender is interesting, but there is, we do know that there is some increase. It was the weakest of the 3, so it needs to be validated before we can fully use it. So if anybody has an interest in Kawasaki disease or has a database, would be wonderful. We can just quickly validate the score and see if it works, or see if we can improve on it and make a better score. But I think this is a very good way to improve the management in the Middle East. And the main impetus is that the Kobayashi score has been found that it works very nicely in Japan, but didn't really have the same results in other populations. So there's room for improvement on it.
Lovely, thank you. Do you want to answer a question, or do you want me to answer another question, Dr. Buthaina?
So I have just 2 questions actually for Dr. Hilal. Again, first of all, thank you everyone. They were like a really great talks. And I have just 2 questions for Dr. Hilal. You mentioned in your cohort there was one patient with renal involvement who needed the renal therapy. Any renal biopsy was done for that patient, and any interesting finding? And the other question is, with the previous wave, we used to code for MISC patients. Now, I don't know if my colleagues have the same experience, but now we've been involved more with the severe COVID patients having the MISC-like picture during a positive PCR. Do you have the same experience?
Thank you, Dr. Buthaina, for this excellent two questions. For the first patient, this is the patient who presented, he's one of the patients who acquired prolonged ICU admissions. And no, actually, I don't have that information that if we had to go for the renal biopsy or not, but I don't have that bit of information. He is currently followed with our nephrology team. Regarding the second question is that, so you are alluded to the second wave of COVID, is that right?
Sure.
Yeah, interesting enough with the second wave, first of all, if we talk about the first wave, our multi-system MIS cases, it typically mimic the international outbreaks, which almost it appear 1 month after the peak in the adult populations. Currently, after that, that cohort, and if you can see, our cohort is one of the 133 compared to our regions. We haven't seen much, like the number of cases are there, but very sporadic and are not as in the first wave. Is it because of the herd immunities and the exposure to the COVID in larger number of children and the whole population? Is it related to the vaccine that is giving to the adult side? But interesting enough, this second wave of COVID, we haven't noticed increase in the number of MIS cases. Although, if it will appear in the coming 3 weeks from now, because we are just having our peak here in Oman.
Okay, then good luck.
Thank you.
I'm going to ask the next question to Dr. Abdul Rahman, myositis, inflammatory myositis. Thank you. Great comprehensive talk. So the management has changed dramatically over the last 20 years of JDM patients. Do you think we are ready to, we're already changing lots of clinical practice, but something that came to mind, especially now with the international shortage of IVIG, are we going to be rewriting management plans for our myositis patients with emerging confidence dependent on myositis antibodies?
Oh, sorry. Sorry. Thank you for your question. So now, thanks God, we have many modalities of treatment other than IVIG. So we have steroid, methotrexate, calcium inhibitor, cyclophosphamide in severe cases, rituximab, and also now JAK inhibitor is coming in the way. So probably with severe subtypes, especially with MDA5, probably we will maybe change the treatment or the way how to treat those patients. Because if we use the standard of the treatment like methotrexate, steroid, and IVIG, probably those patients, especially at the beginning of the disease, they have the highest risk for interstitial lung disease. And usually they are not enough. So, and from the literature also, people, they tend to intensify treatment when they face a patient with anti-MDA5.
Okay, thank you. Dr. Banan, was there any long-term outcome that you have come across from your multi-system inflammatory patients that you didn't share with us today? It's a common question that I'm sure most pediatric rheumatologists are getting asked now. We know the data is limited, but have you noticed any sequelae or outcomes or long-term of steroid use that you would like to share with us.
Okay, thank you for this. Actually, the outcome, as I mentioned before, most of the patients, they have a good recovery, about more than 93%. And regarding long-term outcome, still statistical analysis not done, but most of the patients, when receive pulse steroid or 2 milligram per kg steroid, they have, after that, tapering over 2 to 4 weeks. Then the good response, even the echo follow-up, no more coronary involvement, survival rate is very high, or even no morbidity, actually. They get out of treatment and all of them are well, alhamdulillah.
Alhamdulillah. Okay, our experience is a little bit longer than that with steroids and maybe some with some lasting sequelae, but it will be interesting to see collective data. Dr. Buthaina, do you have other questions?
So the majority of the question actually for Dr. Abdurrahman, it seems that they're very interesting with your talks, but I'll have a question to Dr. Jabran actually. Dr. Jabrani presented your abstract regarding the clinical data for missed experience and the multi-center that you were talking about. I know there is no universal kind of guideline treating those patients, but from your review, usually how long you treat those patients with the steroid, and if you blush to start biology, how long you keep the biology for?
Thank you, Dr. Buthaina. If you allow me, can I just say one comment regarding the long-term outcome? I think the only study that I came across regarding long-term outcome, and probably some of you have seen this as well, was the report from the UK group, who was the group who first reported MIS-C. And they reported cardiac outcome of patient who had developed cardiac complications of MIS-C. Patients, they recovered, most of them by 70 plus days of their illnesses. However, 6 patients remained until 1 year with coronary dilatations. So I think for now, maybe this is what our practice in our center. We are following patients with MIS-C for over a year with follow-up with cardiologists, especially those patients who developed coronary artery inflammations. Until now, we are still telling parents that we are not sure what would be the expected long-term outcome, but we may need to keep eye on those patients, probably my personal opinion, for the 2 years following MIS-C, to see if any data come in literatures regarding the other long-term complications. My concern is other systems that we are not strictly following, like CNS, especially in developing children. This is my personal view of long-term. When it comes to the standardization of therapy, I think, yes, we have no standardization of therapy, but we kind of agreed that we usually deal with these patients in general, similar to the way we treat patients with Kawasaki disease. So you'll find that IVIG will be guided with presence of fever. If patient has persistent fever, then he may receive the second dose of IVIG. And steroid, again, we use the same regimen in tapering steroid, the same way that we treat Kawasaki disease. For biologic therapy, our experience in our center, because this mainly the center that we have used biologic liberally in patients, especially early in cases with MIS-C, and IV. I know many people have not used anakinra as IV for critical patients in critical care. We use those biologic therapy, anakinra, mainly for 3 to 4 weeks. Some patients exceed that. So we have used it with patients more than 5 weeks treating MIS-C. I hope that answered your question, Dr. Buthaina.
Yeah, great, thanks. Also, Dr. Abdurrahman, couple of questions or 3 questions for you. First of all, you talked about MDA5 that at least in the Japanese cohort, 80% they will have lung involvement. So is that, would you encourage in adult, true. Would you encourage screen for lung, or it's based on the symptoms? I.e., if you have a patient that you suspect NDA5, let's say low CK, but completely asymptomatic, would you go for CT scan of the lung, especially if the kid is younger than 5 years and PFT would not be an option?
Yeah, well, those patients, they found a good correlation between ferritin and interstitial lung disease. So if an asymptomatic patient with normal ferritin, probably I would not go and do CT per se, but you could do chest X-ray, PFT, unless the patient is having symptoms or high ferritin.
Great. And the second question I've noticed in your cohort, there's kids like 18 months. Would you consider genetic testing in those patients?
Well, probably. Unfortunately, it wasn't done, but we have the positivity of autoantibodies, and I have noticed that those young patients, they are the highest risk for mortality. Especially those below 5 years of age, whom they have positivity for anti-MDA5. So probably there is another genetic factor make them liable for the bad sequelae.
And the last question for you regarding the muscle biopsy, any rule, or let's say when you would go for a muscle biopsy?
Yeah, now people, they tend to be doing less and less muscle biopsies, especially if the diagnosis is clear. I mean, the patient is having skin rash and also the muscle finding, especially with the availability of MRI now. Probably for patients with those who have only muscle disease, if they have positive autoantibodies with the known phenotype, probably maybe I will not go and do muscle biopsy for those. Unless they have negative antibodies, we have to do it to differentiate them from muscle dystrophies. And in fact, we had one patient with polymyositis. He is following really the phenotype of anti-synthase antibodies and positivity of anti-Jo, and for that patient, we didn't do muscle biopsy.
Okay, I don't know, do we have time to go with this question? Because we have a few questions as well. One of them is a request, Dr. Zaid, if you don't mind, people is asking about your contact. So if you can just type it in the chat. Okay.
Dr. Buthaina, if you allow me to comment on a question in the chat regarding the incidence of MIS-C and people experience across GCC with this over the past period.
Sure, but just that should be quickly, Gibran, because we are running out of time.
So I think I do agree, and I think we speculate the same thing that some of the colleagues mentioned earlier, that probably this is related to the mass vaccination of adults and children above the age of 12. But recently with Omicron, I think we are seeing a peak of including children with COVID in general, not MIS-C. But over the past month, we have seen 2 cases, and we think it's related to Omicron. However, the phenotype is very mild. And due to lack of IVIG, we used steroid and they recovered quickly without any need for further treatment.
Doctor, thank you. That's helpful. We're watching for it. We haven't seen anything yet in Oman, but we're watching for it.
Great. So I think with this, we concluded this session.
I have last month 4 patients like this, acute COVID infection without MIS-C feature. Most likely, this is the feature of Omicron, not the.
So I encourage everyone, if they still have a question, to type it in the chat, and I encourage all the speakers, if you have time, just go through that chat and answer, because we have, especially for you, Abdurrahman, a lot of questions. So if you have time, just please go through them and answer the people. With that, I think we will end our session. Thank you so much for all the speakers, amazing talks with a really great work that all of you did. Stay tuned, because in a few minutes we have another session as well, which we're going to be also interesting. Thank you so much, guys, and see you
very much, everyone. Thank you.
Tremfya is a human immunoglobulin G1 gamma monoclonal antibody that binds selectively to the P19 subunit of IL-23 with high specificity and affinity. IL-23, a regulatory cytokine, affects the differentiation, expansion, and survival of Th17 cells and innate immune cell subsets, which are sources of effector cytokines, including TNF-alpha, IL-17A, IL-17F, and IL-22 that drive inflammatory disease. Tremfya inhibits the bioactivity of IL-23 by blocking its interaction with the cell surface IL-23 receptor, disrupting IL-23 mediated.
It's my great honor to share in chairing this session. So first we'll introduce Dr. Ali Sarhan to present the challenging case, the first challenging case. Dr. Ali is a pediatric resident, BGY4, accredited by Saudi Commission for Health Specialists. He's affiliated with Mohammed bin Rashid University of Medicine and Health Science. Dr. Ali, the floor is yours.
Hello, everybody. This is Dr. Ali Al-Sarhan, one of the pediatric residents in Al Jalila Children's Hospital in Dubai, UAE. I'm in my post-graduation year 4. And today I'm going to talk to you briefly about sarcoidosis. I have nothing to disclose, and I have no conflict of interest. As you know, pediatric sarcoidosis is one of the rare granulomatous inflammatory diseases that affects adults and kids, but to a more extent in adults. It's kind of rare in kids. The diagnosis usually in sarcoidosis is made based on clinical suspicion, laboratory finding, and diagnostic imaging. And usually collectively, you need all of this to diagnose this patient. The disease is affecting all the organs in the body, so virtually it can affect any organ, and you can find that the spleen, the liver, or the kidney, or other tissues in the body can have the non-caseating granuloma that is well known in sarcoidosis. The important and essential part here in the diagnosis is to exclude other causes when you get the non-caseating granuloma, and you have to exclude other diseases. When you hear about sarcoidosis, it means rheumatology, and when you hear about rheumatology, usually it means challenges, because always rheumatology is an evolving and still in the process of discovering a lot of diseases in this field. So it's always challenging to diagnose patients in rheumatological field, and the main reason is that we don't have a conclusive and a definite diagnosis in many of these diseases, including the sarcoidosis. Here I will just brief to you about our case that presented to us. She was 14 years old. She was Arab from Yemen, and she presented with 2 months of fever and high-grade fever reaching up to 39. She had night sweating, she had anorexia, she lost weight, and also she had no other symptoms other than this. Her vitals on initial presentation were all normal, and she came in with a report from different hospitals because she was investigated thoroughly in different institutions and hospitals, and we found that she has low hemoglobin, so she was anemic, slightly elevated AST. Her creatinine was significantly elevated, it was 2.9, and her ESR, C-reactive protein, and other inflammatory markers were all high. But we also noticed that ferritin level was significantly elevated beyond the 1,000. Upon physical examination, we couldn't detect any abnormality apart from a small built lady with pallor face and conjunctiva. Part of her workup, we had to send her for a ophthalmological examination, and they diagnosed her with bilateral anterior uveitis, which made the presentation more complex. Upon repeating her inflammatory markers and blood test, we found that her creatinine increased from 2.9 to 3.2, and her urine had some protein, and her urine protein creatinine ratio was slightly elevated as well, and it was 0.39. We did a thorough investigation for this patient, and we tested basically every single thing, and we would think about it for in the differential diagnosis for her, including stool occult blood, calprotectin, and we're all normal and negative. Infectious disease workup as well was done for her, including the quantiferon for TB, Bartonella, parvovirus, EBV, even for Brucella, and everything was reassuring. Rheumatological workup included the ANCA, the ANA, the anti-double-stranded DNA, and even anti-glomerular antibodies, but nothing was significantly elevated or even positive. Immunological workup, including her C3, C4, CH50, and immunoglobulins were all normal, but we could find that CD4 and CD8 were both low in her TNB subsets analysis. Then, because of her very high level of ferritin that I mentioned initially, which was more than 1,000, we tested her, or we investigated her for macrophage activating syndrome or secondary HLH. And we found that her PTT was slightly elevated with a normal PT and INR, and her D-dimer as well was elevated, but her soluble interleukin-2 receptors came super high, reaching 18,589. And the upper normal for this marker is 710 only. We did a bone marrow to rule out the macrophage activating syndrome and HLH, secondary HLH, and it was reassuring, and it ruled out this disease. But at this point, we were thinking of sarcoidosis now. So we sent for ACE levels and D3 level. ACE, I mean angiotensin converting enzyme, and it came high, and also for activated vitamin D, and also came high. And this is one of the 2 markers that we usually use for sarcoidosis. Diagnostic imaging, ultrasound showed a slightly enlarged liver and spleen. Both kidneys were a bit bulky, and chest X-ray showed bilateral infiltration. So we did a CT scan for the chest and the abdomen, and we found widespread enlargement of her lymph nodes in different sites of the body. And also the CT scan of the chest confirmed the bilateral infiltration. And when I'm talking about infiltration, I'm just describing it as this snow is infiltrating this land. This is north of Iraq in Kurdistan region during the winter, and it is fully infiltrated with snow. This city is called Al-Imadiyya, and this is the city after treatment. So it's green and nice. I recommend all of you to visit. Other diagnostic tools that we used and also were kind of reassuring. The bronchoscope was negative. Here, pulmonary function test and diffusion of carbon monoxide. The PFT was negative, but her diffusion of carbon monoxide was 62% only from the expected, but it can be explained by Buthaina filtration and the possible fibrosis. And renal biopsy finished the discussion by finding diffuse interstitial nephritis and non-casanic granuloma with fibrosis, and this patient was labeled as a patient with sarcoidosis at the end. And the treatment was started with steroids and MMF. As you see, and as you saw, sorry, and as I discussed already, the markers were used for sarcoidosis were multiple and they were non-specific. So I'm going just to discuss them quickly and briefly. First of all, the 125 dihydroxycholecalciferol, or the activated vitamin D, it was high in our patient. And why sarcoidosis have elevated vitamin D activated? Because there is high level of activity of alpha hydroxylase enzymes in the granulomas. So that's why it converts the vitamin D to activated vitamin D, and it becomes high. And at the same time, you will find that parathyroid enzymes are low. Few case reports has been there describing a patients because of the activated vitamin D3 having hypercalcemia and even stones, but it's not a common presentation. Other tests from the past, from the history, is the KS skin test and the lysozymes, and both of them are non-specific. By the KS, usually they inject a substance in the skin and they take a biopsy after 6 weeks. It takes too long. The results usually are so late and it's not useful clinically. And for the lysozymes, it is one of the products of the monocytes and polymorphonuclear cells. And also it's useless, not much, because of, it's not much of use because of the elevated LZM levels in other diseases like bacterial infections, leukomoid reactions, anemia, even, and when there is a granulocytic turnover. The other marker is the ACE, angiotensin converting enzyme, and it's also described initially in 1976. It is one of the markers, and it's by some studies in adults, they found that sensitivity was 72 and specificity was around 60%. Unfortunately, the ACE level can be affected by other causes like hyperthyroidism, like hyperparathyroidism, when the patient is taking ACE inhibitors or with malignancies, so it's not much reliable. And for the last marker that I'm gonna mention now is the soluble interleukin-2 receptors. It is one of the receptors that can be expressed on the activated T cells and regulatory T cells. It's also called CD25. It's not yet well known if this is part of the pathogenesis of sarcoidosis or it is a byproduct, while the body is trying to activate his immune system, and these are the byproducts of this activation. The sensitivity is 88 and the specificity is 85%. So it is way beyond the ACE inhibitors, ACE markers, and it is more specific and sensitive. In our patient, I'm just demonstrating to you that 3 markers that we used were high initially, but when the patient flared up again, that you can see in this graph, the 2 stars, this is when the patient flared up again. ACE didn't go beyond the normal range, but soluble interleukin was elevated again. So if we depended only on ACE, we could not really diagnose and detect this flare-up. And at the end, I would really mention that soluble interleukin-2 is a promising marker for diagnosing and following up the patient. Still, we need a collective data from the clinical presentation markers, diagnostic imaging to diagnose these patients, but also we need further studies to study these markers, these are promising markers, and see how much useful they can be in such a rare diseases. And thank you so much.
Thank you very much, Dr. Ali, for this interesting case. And now the second challenging case will be presented by Dr. Ilham Bishir. Dr. Ilham is a senior pediatric resident and chief resident at Al-Jalila Children's Hospital, Dubai, Emirate. Dr. Ilham participated in multiple research and posters, and she has interest in the field of rheumatology. Dr. Ilham, please go ahead.
Good afternoon, everyone. My name is Ilham. I'm the current Chief Pediatric Resident at Al-Jalila Children's Hospital. Today, I'm very excited to present an interesting, unique case, a unique presentation of a common disease we all know, and the challenging therapeutic approach we use as an MDT in our hospital. So a little bit of background before we start. As we all know, lupus is a disease with 1,000 faces, and due to its variable presentation, it initially poses a diagnostic challenge. The reported incidences in the pediatric age group for neuropsychiatric presentation is hugely variable. Peripheral nervous involvement, specifically GBS, accounts for less than 10% of the cases, which makes our case very unique. The exact pathogenesis is unknown. It still remains speculative. Regarding the treatment, there has been no consensus made for the SLE GBS in the pediatric age group, and only 2 cases has been reported to our knowledge in the pediatric age group. So here today, we describe a third pediatric patient who had a classical presentation of GBS, and which was later found out to be triggered by SLE. I would also like to discuss about the multidisciplinary approach and therapeutic outcome in our patients. So I'll begin with the case presentation. We present a 14-year-old previously healthy female teenager. She presented with a 1-week history of bilateral ascending muscle weakness, 10-day history of disparate eye movements, with a 4-week history of on and off numbness and paresthesia in both legs. The child reported that weakness is more pronounced on the left side and was progressively worsening over the past week. 2 days prior to admission, she developed mild swallowing difficulties, which are suggestive of bulbar symptoms. And by the time of presentation, she had been non-ambulatory for 7 days. On further history, there has been no fever or immunization preceding the onset of the neuromuscular symptoms. She did not report any headache or seizures, no rash or joint pain, no constipation or urine retention, and no hematuria. She did not report, parents and family did not report a change in mood or behavior or academic performance. There has been no history of recent travel or sick contacts with COVID. She is a fully immunized child according to the UAE national schedule, and she has a positive family history of presumptive SLE, hypothyroid, and G6PD. Now, regarding the clinical examination, she was bed-bound, wheelchair-bound, but conscious and alert, with no signs of respiratory distress. Her cranial nerve examination showed right eye convergent squint and bilateral gaze palsy. Her motor examination was significant for severe muscle weakness in the lower limbs, 1 out of 5 in the MRC scale at the hip and knee joint. And also we can evidently see the ascending muscle weakness with the MRC scale of 1 to 2 out of 5 in the shoulder and the arm, and 3 out of 5 in the wrist. She was hypotonic with total areflexia. There was no signs of any vasculitic lesions or arthralgia on initial examination. and systemic examinations otherwise unremarkable. We performed initial labs. The CBC was essentially normal. Her creatinine clearance were normal. Her kidney functions were normal. She had a slightly elevated CRP of 11, which was not impressive. Serial COVID test and antibody testing was done, which was also negative. However, she had an elevated ESR at 92, which was suspicious of a rheumatological disease. So the neurology team was called on board given suspicion of GBS. They recommended to perform a lumbar puncture for CSF studies and MRI spine. And we can see here evidently there's protein cell dissociation suggestive of GBS. And the MRI spine, as indicated in the image, we could appreciate some caudal equina root enhancement, which is also consistent with GBS. Therefore, according to the Brighton criteria, she was diagnosed as having acute GBS. Treatment was initiated with 2 gram intravenous, 2 gram per kg intravenous immunoglobulins, as per the recommended guideline for pediatric GBS. She had received them over 2 days with no clinical improvement. In fact, she progressively worsened and on serial clinical examination. And by day 7 of admission, she developed a decline in vital capacity. And this prompted elective intubation and ICU care for further support. In view of this progressively worsening clinical picture, we performed follow-up investigation, including a screen for SLE lupus. And it showed positive ANA and anti-Abdwani DNA antibodies, along with low C3 and C4 and proteinuria. Given our high suspicion, on day 8, we performed the kidney biopsy, and methylprednisolone pulse therapy was initiated thereafter. And I would just like to highlight the laboratory investigations that we did for our child. And as you can see, she had positive antibodies. And these are the images from the renal biopsy, which showed class 2 lupus nephritis, which is a classic full house picture. And this was diagnostic of SLE according to the SLIC criteria. So now I would like to move on to detail the timeline of the therapy. So from where we last stopped, at day 8, we started on methylprednisolone therapy, followed by maintenance dosing. On day 9, unfortunately, she developed uncomplicated pneumonia, for which she was started on antibiotics. By day 10, we also gave a second dose of IVIG, given no clinical response to the methylpred pulses. Unfortunately, she remained intubated and ventilated. And given that there's been difficulty even assessing the neurological improvement, we have escalated the therapy for GBS SLE. An MDT approach using the neurology team, rheumatology team, ICU team, and the GenPeds team was taken to make a decision regarding what is the next further management in this case. It was suggested to start on rituximab, a B-cell depleting agent, based on our suspected pathogenetic cause for SLE GBS. And then, given that her situation did not improve on the singles of rituximab, and based on previous studies in adults that PLEX therapy was initiated, on day 14, we decided to do the same, and it was initiated to good response. Given the good response, we have gone to the direction of starting immunomodulators, and she was also given 2 additional doses of rituximab. So here is a summary of the disease evolution and treatment. I just wanted to highlight that you could see that the plasma exchange therapy was started on day 14, and she has received about 12 sessions, and after the 10th session is when we started to gradually wean off the ventilator, and after the last session, she was off the ventilator, and she was starting to communicate and as well as participate in physiotherapy, so which was a big push towards improvement. And as you can see, unfortunately, with the multiple lines of therapy that is usually recommended in GBS or solely or SLE solely, she has failed to show a response. However, with the plasma exchange and the rituximab, she has shown some improvement. Obviously, the disease course is not without complications. We have noted hair loss during early course of the disease. She was also complicated by labile blood pressure, mainly hypertension due to autonomic dysregulation. Post-tracheostomy, she developed a brief episode of hyperactive delirium, which responded to haloperidol. And she also developed painful dysesthesia, which initially required opiates, and then finally it was managed well by high-dose gabapentin. So our outcome. Luckily, our patient had developed a good neurological outcome. She showed significant improvement in her neurological symptoms with the plasma exchange therapy. She was continued on ambulatory physiotherapy to improve muscle power. And on day 70, she was discharged home safely. At her first follow-up visit, she was ambulating freely and she was able to perform all her daily activities without any assistance. So this case, the main idea behind us highlighting this rarity is that first, GBS has not been frequently reported as the initial presentation of SLE. In a study in China, they found that out of a subset of adult SLE patients, 1.5% were presenting with peripheral neuropathy, out of which a single patient was presenting with GBS. The pathophysiology of GBS in SLE is still speculative, but it's thought to be due to lupus-induced autoantibodies against myelin tissue, leading to the neuropathy. So in the absence of treatment recommendations, there's varying reports of glucocorticoids, cyclophosphamide, plasma exchange, and IVIG being used in different combinations. Current guidelines for pediatrics for pediatric GBS emphasize IVIG over plasma exchange. However, for pediatric SLE, the primary effective treatment approach is pulse steroid therapy, which was not so effective in our case. Therefore, prompt recognition of SLE as a trigger for GBS is vital because the management of GBS is also changed accordingly. So in conclusion, there are currently no treatment recommendations available for SLE GBS. We propose that targeting the underlying autoimmune disorder and removal of this presumed pathological antibodies would help decrease the inflammation and the inflammatory effects of these autoantibodies. Another potentially effective strategies are B-cell depleting agents and plasma exchange. The dissemination of further experiences is definitely warranted to establish efficacies and to further develop a treatment consensus regarding pediatric GBS SLE. I would like to acknowledge my supervising author and mentor, Dr. for his expertise and guidance, and I would like to thank all my co-authors for their contribution. I would also like to acknowledge all the physicians, nurses, and allied health professionals who contributed to the care of this patient. Thank you.
Thank you very much, Dr. Ilham, for the interesting case. Now it's turn to Dr. Nashat Al-Sukaiti. Dr. Nashat graduated from Sultan Qaboos University in 2000. She received full training in the University of Toronto Hospital for Sick Children with the pediatric residency, then followed by pediatric allergy and clinical immunology, followed by 1 year training in bone marrow transplantation. Currently working as a senior consultant in allergy and clinical immunology in the Division of Child Health, Royal Hospital since 2010. Dr. Nashat, the floor is yours.
Good afternoon. I'm Dr. Nashat Al-Sukaiti. I'm a pediatric allergist and clinical immunologist. And the title of my talk today is Self and Non-Self, Understanding the Immune System. The main aim of this presentation is to highlight the relationship between inborn error of immunity and immune dysregulation, and to understand the role of regulatory T cells in maintaining immune system in balance. So the case that I'm going to present today is for an 11-month-old boy born at term to a consanguineous parents with positive family history of neonatal deaths and stillbirth. On day 2 of life, the patient developed hyperglycemia and was then diagnosed with neonatal onset diabetes mellitus with positive anti-GAD and anti-islet cell antibodies. As part of screening, he was also found to have hypothyroidism, so he was diagnosed with autoimmune hypothyroidism with positive anti-peroxidase antibodies. The patient was well until the age of 6 months when he presented with fever and abdominal distension with hepatosplenomegaly. The symptoms persisted for the next 3 months until he manifested with evidence of liver failure with signs of hepatosplenomegaly, jaundice, low albumin, deranged coagulation profile, and the involved team questioned the possibility of autoimmune etiology for the underlying liver failure. So blood work was sent for autoantibodies, and initially the liver biopsy was deferred, which the antibodies came back later as positive to anti-LKM and anti-SM positive. In addition, the patient also had urinary tract infection with positive cultures for Enterococcus faecalis, and he was managed well with cefotaxib. Few weeks after discharge, around the age of 10 months, the patient presented with cough and excessive crying. And you can see the X-ray, the chest X-ray on the right side showing opacities more on the periphery. And this is actually when I came across this child during my on-call, and I questioned whether these opacities are caused by pulmonary hemorrhage versus opportunistic infection. So I proceeded with bronchoscopy, which showed that the patient was having frank blood. And we also considered sending after seeing the frank blood, we proceeded to send antibodies, which came back positive at high titers to P-ANCA, C-ANCA, and anti-GBM antibodies. The patient deteriorated further and got admitted to intensive care unit. And during the admission, pulmonary hemorrhage became refractory. And by this time, we knew that all the infectious workup was negative. And the autoimmune liver disease also continued, and he had a new onset of autoimmune cytopenias. So at this stage, we managed his pulmonary bleed and his other autoimmune manifestation with 3 pulses of methylpred, and later on maintained on 2 milligram per kilogram per day of prednisone. Unfortunately, this did not control his symptoms, so we proceeded with cyclophosphamide, and he received only a dose. Because of severe neutropenia, it was stopped. So we gave him 4 doses of rituximab, and only then his pulmonary hemorrhage was controlled. The patient was off oxygen, the cytopenias improved to normal counts, and the coagulation bilirubin improved as well. During this admission, he also tested positive for anti-TTG. However, the patient at this stage did not manifest with diarrhea. At this stage, we started questioning ourselves. What is going on with this patient? Why is he producing antibodies that are attacking his own self and causing organ damage one after the other? And the answer is that this patient could be suffering from a primary immune deficiency that manifests with autoimmunity, especially given the multiple manifestations of autoimmune and also evidence of infection. So we thought that putting things together, it seemed that the primary problem was in T regulatory cells. An example of that is IPEX-like. We also entertained other possibilities like autoimmune lymphoproliferative syndrome, APICID, and mutation caused by AIR. So what are the regulatory T cells? Regulatory T cells are a subpopulation of T cell They are CD4 plus, CD25 plus, and they carry also a protein called FOXP3. And its main role is to maintain the tolerance to self-antigen, preventing autoimmune disease. But it also has other important roles as anti-tumor immunity, and it's also relevant for allograft rejection. And they are in small quantities, so they are about like 5 to 10% of your total CD4 T cells. This slide just shows an example of how do these T regulatory cells get rid of these abnormal cells that tend to attack yourself or they tend to become malignant. So on the left side, you can see that the regulatory T cells have produced cytokines. These cytokines are called inhibitory cytokines, so they resulted in inhibition of the function of the effector T cell. On the right side, you can see that another mechanism, which is it produces substances that will attach to the cell, and then they will create a hole. And at the same time, the T regulatory cells will produce enzymes that will end up in cytolysis of these cells. IPEX is just an example of, it's actually the commonest example of human diseases that are caused by T regulatory cells. And another example is IPEX-like phenotype, like CD25 deficiency and STAT5B deficiency. IPEX is an acronym that stands for immune dysregulation, polyendocrinopathy, enteropathy, and X-linked syndrome. And this is caused by a mutation in FOXP3, which is one of the important markers and proteins that are important for the function of regulatory T cells. The first description of IPEX was in 1982, and it was published in the Journal of Pediatrics by Paul, where he described a patient who came from a family in which 17 male infants died in the first year of life. That's when they concluded that this is most likely an X-linked. The most common presentation was intractable diarrhea, eczema, hemolytic anemia, diabetes, thyroid autoimmunity. And 11 of those males died in infancy due to infection or shortly after immunization. IPEX-like syndrome is one of the common conditions that gives you an IPEX-like phenotype is CD25, also known as IL-2 receptor alpha. The first description of this condition was in 1997, where Roifman described, an immunologist described more of a SCID, severe combined immune deficiency phenotype. But in 2007, there was more description of immune dysregulation affected individuals with CD25 deficiency. So going back to our case, we see that we had an infant with early onset, multiple organ-specific autoimmunity causing end organ damage, and with positive autoantibodies. So we thought, because of the family history of neonatal death in multiple males in the mom's family, we thought of IPEX as a possibility. So we ruled it out and we found no pathogenic mutation in FOXP3. Then we proceeded to the next possibility and we found that the patient was having homozygous novel mutation in interleukin 2 receptor alpha, or also known as CD25, confirming the diagnosis of CD25 deficiency. So the patient was kept and maintained on immunosuppressant drugs. We offered transplant, bone marrow transplantation as a curative treatment option. However, the parents initially rejected it. Over time, we started noticing severe neurological deficit, probably because of brain bleed at the time when the patient had refractory pulmonary bleed. And the patient died around the age of 3 years from aspiration pneumonia. Over the last 10 to 20 years, there have been more and more articles published associating immune deficiency or inborn error of immunity to autoimmunity or immune dysregulation in general, with lymphoproliferation, granulomas, colitis, and so on. And they highlight, in fact, the strong association. So at the end, I would like to conclude my presentation by reminding you of the definition of inborn error of immunity. We now moved away from calling it primary immune deficiency to inborn error of immunity. So these are conditions where they are inherited and they predispose individuals not only to infection, but immune dysregulation and malignancy. So you might be the first person encountering these cases. Remember that delayed diagnosis can result in poor outcome in patients with the inborn error of immunity. Therefore, there have been more recent recommendations to add immune dysregulation into the early warning signs of primary immune deficiency to increase the diagnosing such patients and giving them the appropriate label. So by this, I would like to end my short presentation. Thank you so much for attending, and you are welcome to ask any questions in the discussion.
Okay, thank you, Dr. Nashat, for this interesting case. Now we'll move to another challenging case, which will be presented by Dr. Mahadev Lohano, who is a specialist in pediatric rheumatology department, Sultan Qaboos University. Dr. Mahadev, you can start with your challenging case, please.
Hi. So I'm going to present a case of systemic vasculitis. A 4-month-old girl was referred to us for her persistently elevated inflammatory parameters following a prolonged 4 weeks febrile illness. There were no other symptoms apart from the fever. Initially in the local hospital, she received multiple courses of antibiotic as a case of bacteremia despite negative cultures, and the fever gradually resolved. And she was referred because persistently elevated inflammatory parameters were there. In her past history, she has remained well, and her birth history was unremarkable. With postnatal also, she remained well. Family history is also unremarkable on her. When we received her, she was well appearing, and parents were telling that she was afebrile for the last 2 weeks. She was failure to thrive. Her weight was less than 3rd centile, but her length and the FOC were at the 50th centile. And she was not in any distress. There was no rash, no conjunctivitis, no lymphadenopathy. Her peripheral pulses were palpable. Blood pressure was normal in upper and lower limbs, and there was her chest was clear. There was no visceromegaly. Her pulses perfusion were fine, and there was no arthritis. So the impression on her was that she has persistently elevated inflammatory markers following self-limited febrile illness, not infectious. So as per guidelines, it can be an incomplete Kawasaki disease in an infant. So we did her investigations, and that shows significant leukocytosis, thrombocytosis, and inflammatory parameters were raised. And her blood culture later on came negative. We did her chest X-ray and ultrasound abdomen, that was normal. We arranged an echo, and that shows all coronary arteries were dilated with giant aneurysms in the left and right main coronary arteries. There was a thrombus in the right coronary artery. So CT angio was urgently arranged for her, and it shows there was dilation of the proximal segments of multiple large arteries of the aortic branches, the brachiocephalic artery, left common carotid artery, the main pulmonary trunk, celiac axis at the origin, and the proximal supramesenteric artery, renal artery, they all were dilated. Like the pulmonary trunk was 18.78 mm, as well the ascending aorta was 11.95 mm dilated. The origin of the left coronary artery was also dilated. Here you can see the left common carotid artery is 5.36 mm. The brachiocephalic artery was also dilated, and so was the descending aorta, with dilation was also noted in the renal arteries. So looking at these images, it comes that she is having middle and large artery vasculitis. So most likely it is Kawasaki disease with other systemic aneurysms. The other differential which were considered were infantile polyarteritis nodosa, infantile Takayasu arteritis, And in autoinflammatory disease, we thought about the deficiency of adenosine deaminase 2 deficiency. When we reviewed the literature for systemic artery aneurysms in Kawasaki disease, this is a comprehensive review published in a Spanish journal by a Japanese study. They found that systemic artery aneurysms is in only 2% of the cases of Kawasaki disease. And they reviewed some 9 case series in which a majority of the cases were infants. The distribution of arteries was same which we saw in our case, and they found that the worst outcomes were noted in younger patients. Another study was about systemic artery aneurysms in Kawasaki disease, was published by a Chinese hospital in pediatrics in 2019. They found that all those patients who have coronary artery aneurysms with the Z-scores of more than 8 they develop the systemic artery aneurysms. And that was, and the estimation was the systemic artery aneurysms were found in 2% of the cases of total cases of Kawasaki disease. And there was only 51% regression rate of the systemic artery aneurysms at 20 years after onset. And if we see about the polyarteritis nodosa, as per the EULAR presentation, our patient was having angiographic abnormality, but she doesn't have the other criteria like skin involvement, myalgia, hypertension, peripheral neuropathy. And if we see the EULAR criteria for Takayasu arthritis, she is having angiographic abnormalities of the aorta, plus she was having the acute phase ejector proteins were raised on her. And so this was also in differentials for her. Other differential diagnosis was the adenosine deaminase 2 deficiency, in which major cases they present in childhood with the recurrent strokes at early age and some other symptoms as well. We did her MRI brain and it showed normal cerebral vasculature. Later on, her whole exam sequence was reported negative with no mutations on her. So initially we started her on IVIG 2 gram per kg with pulse, methylpred pulse 30 mg per kg for 3 days, followed by IV methylpred 2 mg per kg until the CRP gets normalized, then to switch her to oral pred with gradual tapering. For her giant aneurysms, she was followed by the hematology with low molecular weight heparin, followed by warfarin and aspirin. Her inflammatory markers in clinical course, they normalized, the platelets dropped from 1500 to 750, but she was continuously fluctuating. The inflammatory markers were fluctuating. And once, it happened twice actually, when we shifted to oral pred, her CRP shot up. She was otherwise clinically well, so the parents were resisting for discharge. So a month later, she was discharged on subcutaneous anakinra 6 mg per kg with the tapering course schedule of prednisolone. In 2-month follow-up, we repeated her images and they showed there was worsening of the luminal narrowing, and the inflammatory parameters were also raised. The CRP was 196, the platelet was again 1026 something. So this was images for her. So we switched her to IV cyclophosphamide with 10 mg per kg Q2 weekly for 3 doses and then Q3 weekly for next 3 more doses. And we restarted on prednisolone 2 mg kg with gradual tapering, and plan was to repeat the scans and definitely the echo as well after completion of cyclophosphamide. So she received 6 cycles of cyclophosphamide. After 4 months, when we repeated her scans, they showed there was no change. The appearance were unchanged, and there was ongoing vasculitis on the PET-CT scan. Although the echo showed some improvement in the caliber, but the aneurysms, giant aneurysms were still there. So at that time, this is the refractory case of large and medium artery vasculitis. She received IVIG, methylpred pulses, anakinra, cyclophosphamide, but not responding. So we switch her to infliximab, 10 mg per kg Q4 weekly, and with subcutaneous methotrexate weekly, and prednisolone 2 mg per kg with gradual taper. Clinically, she has remained well, and now she's on, after 4 months, she is on prednisolone 0.6 mg per kg. And the recent labs done on 17th of January are showing that her CRP is less than 1, ferritin is 8, and platelet count are again less than 750 for her. So this is a very refractory case of systemic vasculitis. We're thinking about childhood onset Takayasu arthritis. It's a granulomatous vasculitis that predominantly affects the aorta and its main branches. It commonly affects the young women between 20 to 40 years of age, and is far less frequent in children, with the peak age in children around 12 years and rare in infants. When we saw the literature review has found only 8 infants with Akbar arthritis. The most common symptom in infants was fever in 5 cases, elevated inflammatory markers, and in 6 cases out of the 8, they found the abdominal aorta was affected. And children may have the delayed diagnosis, often several years, because it contributes to higher frequency of patients who require surgery or stenotic occlusive complications. In children, the early phase of the disease reveals only blind lymphocytic inflammation with some neovascularization in histopathology, rather than the granulomatous inflammation. Conventional angiography is the standard for diagnosis, but due to its radiation complication, the EULAR recommends MRA for these cases. Majority of children with Akbar arthritis suffer from progressive or relapsing type of disease and frequent immunotherapy to control vascular inflammation. The diagnostic delay, which is often significant in children, remains a major challenge, as irreversible vascular damage and secondary organ dysfunction may occur in the pre-diagnostic phase of the illness. The treatment recommended by the EULAR is tumor necrosis factor inhibitors and interleukin 6 inhibitors as well. This was published in the European Journal of Rheumatology in 2020. Thank you.
Last but not the least, case will be presented by Dr. Al-Mayouf Abdullah, who is a pediatric rheumatologist consultant in King Faisal Specialist Hospital Research Center in Saudi Arabia. So Dr. Al-Mayouf, go ahead with your challenging case.
Assalamu alaikum. First, I would like to thank the organizing committee for giving me the opportunity to share my presentation, for which I really hope this case will be of interest. So we'll go ahead and start with the presentation. I'm going to share with you a lovely 3-year-old boy who was born preterm and had a normal neonatal period. His story started at the age of 2 months. At that time, he presented with fever and mouth sores, with a strong family history of immunodeficiency, for which he was referred to our colleagues in allergy immunology service at the age of 11 months. On obtaining further history, the family did report occasional vomiting and diarrhea with some of the attacks. And they have mentioned that since the age of 2 months, he continued to have the recurrent non-specific attacks of fever with mouth sores. When they saw him in clinic, it was almost 2 weeks after the last attack. And as you can see here, he had persistently mild elevation in his inflammatory markers with an ESR of 25 and a CRP of 6.3. He had borderline lower hemoglobin in the form of microcytic hypochromic anemia. His immunological workup, as you can see here, were quite unremarkable with normal immunoglobulin levels. He had normal lymphocyte markers, vaccination response, and oxidative burst assay. He was also assessed by GI team for the occasional vomiting and diarrhea with no remarkable results. Further testing were done in the form of genetics as the immunology team sent for primary immunodeficiency panel, and the results came back negative. At the age of 2 years, he had a severe attack which required hospital admission. At that time, he presented with high-grade fever associated with mouth ulcers. He also developed significant bilateral lymphadenopathy in the form of cervical lymphadenitis, as you can see here in the picture of ultrasound imaging. Clinically, he didn't look well and had abnormal vital signs. His inflammatory marker were also on the higher side with a CRP up to 100. At that time, he was assessed from different services and underwent infectious workup. The results came back negative. Still, he was treated initially with empiric antibiotic, despite having negative blood and urine cultures. He was discharged after stabilizing his condition with supportive treatment. Since then, he continued to have frequent ER visits with recurrent fever and mouth sores. He was assessed again, as I mentioned, by our colleagues in infectious and immunology team with no definite diagnosis. Again, genetic testing were sent, and this time in the form of whole exome sequencing, and the result came back negative. At the age of 3 years, he was referred to our service for the possibility of autoinflammatory diseases. And I'm going to summarize here his story. So when we saw him, he was 3 years old boy and had recurrent attacks of fever associated with painful mouth sores and occasionally abdominal pain, vomiting, and diarrhea, which tend to be mild. He did develop lymphadenopathy in two attacks. One of them were quite severe, as I previously mentioned. During the attack, he will be quite sick and lethargic. A trial of different antibiotics been done, which were unsuccessful as per the parents' reports. And also we have reviewed his hospital documentation. The duration of the attacks will last from 3 to 7 days and happen in irregular intervals, sometimes every few weeks, and in other occasions every few months. In between the attacks, the child will be completely back to normal. By this, we have kind of entertained different differential diagnoses, and probably the top differential diagnosis we thought about in this patient is also the consideration of autoinflammatory diseases, and the advantage of that, having recurrent attacks of fever associated with a specific manifestation, and the child will be completely back in between. Probably you may think about hyper-IgD syndrome, which also we call as MKD. And as you know, this kind of condition usually starts early in life with fever and constitutional manifestations. We have also considered PPAPA, but probably with the early onset disease and lack of other specific manifestation with this syndrome, we didn't thought about it much. Cyclic neutropenia was also considered, but we have checking his cell counts, which seems to be normal in between and during the attacks itself. Another condition in the era of autoinflammatory disease we thought about is haploinsufficiency of A20, which is one of the conditions that can be associated with recurrent fever and ulcers. Last but not least, monogenic lupus has been considered, but it's worth to mention that this patient had autoimmune workup, which came back negative. Also, probably from what you have heard, he didn't have that strong feature to suggest an autoimmune disease or monogenic lupus. So by that, we have sent for a targeted gene with our top differential, which coding for the hyper-IgD syndrome and haploinsufficiency of A20. Interestingly, the result came back positive for a heterozygous mutation in TNF-alpha AIP3, which is a gene that codes for the haploinsufficiency of A20. So what do we know about this gene? TNF-AIP3 codes for tumor necrosis factor alpha-induced protein 3, and this gene codes for the protein A20, which play an important role in the deubiquitinization. I'm not going to go over the pathophysiology in details, but what we need to know about this protein, that it plays an important role with the NF-kappa B. So once there is a dysregulation in the gene itself, this will lead to uncontrolled activation of different pro-inflammatory cytokines. There was a study looked at the gene in more details, and if there is a knockout of the gene, there will be a lethal disease for which the proposal of haploinsufficiency came out. There are different reports addressing polymorphism that's been reported in this gene associated with autoimmune diseases and malignancy. So just to describe the pathogenesis in a summary, once there's a mutation in the TNF-AIP3 gene, this will lead to uncontrolled activation of the NF-kappa B, leading to the release of pro-inflammatory cytokines. Also, it does play a role in the activation in the NLRP inflammasome, which will lead to uncontrolled systemic inflammation. The first case series, which was actually published back in 2016 by the group of the NIH team who actually discovered the gene mutation. And at that time, they have described 5 families who share similar phenotypes and genotypes. And as you can see here, this is the gene analysis. Most of the variants were reported in the otolin part, whereas only one variant reported in the zinc finger, with no clear association or differences between the two group involved. Furthermore, they studied these patients for the involved inflammatory cytokines, and they have found that interleukin-1 beta, TNF, and interleukin-6 had been quite elevated in the patients compared to controls, which probably can play a role to address the therapeutic intervention, but still lacking a specific pathway which can be targeted in these type of patients. Another paper was published 2 years after, where they described the same group of patients and an additional couple of patients. They have found that patients with HA20 tend to have early onset disease, and as you can see here, as early as 1 week. Still, in small number of patients, they tend to present late in life as late 20. In all of the patients, they had recurrent oral and genital ulcers, and that's somehow similar to Behçet. Still, in 50% of the patients, they had recurrent fever, which seems to fit more in the autoinflammatory disease category. Some of the patients had cutaneous manifestation, and this seems to be quite variable. In another group of patients tend to have musculoskeletal disease as non-deforming polyarthritis, and this seems to be quite different from Behçet, since they do have more of an oligoarthritis pattern. In assessing further these conditions, they have found that there's no gold standard for laboratory parameters. We have seen that in a majority of patients, they tend to have elevation in their acute phase reactant during the attacks. And in around 50% of the patients, they had fluctuating level of different O2 antibodies. Some of the patients may tend to have hypogammaglobulinemia and recurrent infection. The histopathology, which had been done in small group of the patient, tend to be not much conclusive. When they compared the HA20 with Behçet disease, they have found that HA20 tend to have early onset disease, as I have previously mentioned, with history of recurrent fevers, and most of the time the ulcers tend to heal with scarring, and in case there is a present of ocular manifestation, it tend to be anterior uveitis and refractory, different from Behçet, where it tend to be in the form of panuveitis and posterior. The GI manifestation seems to be quite wide, from mild to severe, and in some patients they may end up with bowel perforation, and the inflammatory markers were quite elevated, specifically during the attacks. So in order to think about HA20 compared to Behçet, we usually consider it in patients who had early onset disease with recurrent fevers, severe GI disease, and the presence of autoimmune manifestation. Also patients who had positive family member with similar condition and history of recurrent infection or hypogammaglobulinemia. There's no specific recommendations in respect to treatments, but what we have seen is that most of the patients with mild disease may respond to colchicine. Definitely steroid has been quite positive in treating the patient, but unfortunately, if it given for long periods of time, as we all know, this will lead to different side effects. What has been agreed by different experts who had followed these patients in the past few years, that probably targeting the therapy according to the major organ involvement is recommended. For example, if your patient had persistent painful ulcers, despite the trial of colchicine, you may consider anti-TNF. If there is a systemic manifestations, you may consider IL-1 or IL-6 inhibitors, whereas if there is a significant MSK disease, to treat the patient as GIA. What we know about the outcome is quite limited. As I said, this is a recently identified condition, almost in the last 5 years, so we don't have much in the outcome. If the patient had been treated early, then the morbidities tend to be less, specifically in respect to the medication-related complications. There was one reported death, and this was secondary to tonsillar ulceration and hemorrhage. Otherwise, we don't have much with respect to morbidity and mortalities. So definitely, we're going to take a message from here that further workup is needed in order to understand the disease pathogenesis and assess the prognosis and outcome of these group of patients. And by this, I'm going to end up my talk, and thank you.
Okay, I would like to thank all the speakers, the interesting case and challenging case. We'll start with the first question. Dr. Ilham, thanks for the presentation, a very interesting case. No. Now, to Dr. Mahdiv. This is the question regard to you, Dr. Mahdiv. Okay, thank you, very interesting case. Were ANA and anti-double-strand DNA before IgG infusion done?
This I have asked from Dr. Ilham for her patient with SLE and GBS.
Oh, sorry. All right, so where is Dr. Ilham? Okay, we'll move to another question. Where is she? Didn't join us for Q&A question? I cannot see another question here. Dr. Abdurrahman, كيف تشوف أنت في any question in your screen?
Right. Yeah, I can see them. I have just one question to Dr. Ali, if you allow me to ask. During your review of sarcoidosis, you have mentioned there is renal calcinosis or calcification or nephrocalcinosis. So I don't know about other organs.
So just can you repeat the question? I didn't get it. Sorry for that.
Yeah, during your review of sarcoidosis, you have mentioned nephrocalcinosis can happen with or calcification in the kidney with the sarcoidosis. I don't know about other organs.
So yeah, so virtually sarcoidosis, as you know, is the non-caseating granuloma, can involve, as it happened in our case, the lymph nodes. And it can affect also any other organ virtually. But a few case reports I could find affecting the liver, but in general, it can affect any other organ. And yeah.
Okay.
Okay. Dr. Abdurrahman, do you have another question? Because I have the question here to Dr. Ilham.
Yeah, go ahead.
Dr. Ilham, this question from Dr. Nasral, adult rheumatologist. All right, she's asking, I just want to ask, in your diagram, hydroxychloroquine was stopped in between. What was the reason?
Hi, that's a good question. Yes, unfortunately, our patient, after starting the hydroxychloroquine, after 2 days of starting it, she developed a reaction to it. She developed rash, uneasiness. She wasn't tolerating the medication well. Therefore, at that point, we were still in the diagnostic workup phase. So it was a decision based on her response to the medication. However, later on, once she was fully diagnosed, we obviously initiated it as one of the stepwise management.
Right. Okay, another question here for Dr. Al-Mayouf. Thank you for sharing this interesting case. How can you explain the missing mutation by OS? Missing mutation.
Yeah, I think that's a good question as well. We know that sometimes doing whole exome sequencing, you may still miss some genes. And that's why repeating either the whole exome sequencing or sending for a specific panel still may yield some results. And that's really depending on how which panels you're using and what exactly you're looking for. And how did you describe the phenotypes for the geneticist so that he can look exactly for the genetic mutations you're interested in. And that's why, based on the phenotypes of this patient, we sent for the targeted gene for this phenotype and came out positive as we initially suspected.
Dr. Abdurrahman?
Sure. Yeah, Dr. Nashat, thanks for the presentation. How frequent we see inborn error of immunity in clinical practice? You are mute, Dr. Nashat.
So, طبعا we know that physicians tend not to refer much immune deficiency. That's why we came up with these warning signs. Unfortunately, the warning signs are infection-centered. So they focus on the frequency, severity, opportunistic, family history, consanguinity. Recently, I think in January 2022, there's been a big study, multi-centered. They looked into 16,000 patients in Europe that had primary immune deficiency, and they looked into their presentation. They found about 18% of those patients presented with immune dysregulation, including lymphoproliferation, colitis, autoimmunity. طبعا احنا في عمان we just recently published a case, not yet published, it's under review, but I know that in Kuwait, for example, they published a paper on autoimmunity in pre-PID, and they I think reported about 20% of their patients having autoimmune presentations. I think in our study that we have done, not yet published, it's under review, we found about 25% of our patients having immune dysregulation.
Fair enough, thank you very much.
I think we have one more question here for Dr. Mahdif to Dr. Ilham. Okay, he's asking where ANA and double-strand DNA was done before IgG infusion.
No, unfortunately, it was actually done after. The reason was that initially she presented as a case of GBS, so she was being treated appropriately for it. When there was a poor response to it, that was when we started to screen for any autoimmune reason, any other causes for this severe presentation. And so that was when it was taken.
Oh, thank you. I think no other question. I cannot find. No other question. Dr. Abdurrahman, anything from your side? No?
Yeah, I think there is no more questions.
All right, would like to thank all the speaker for these interesting cases. It was really very challenging, and we learned a lot from your cases. So thank you very much. Okay. Now I would like you to close our session, pediatric session in this GCC conference. I would like to thank all the speakers for their valuable contribution and excellent presentation. It was really very nice talks, up to date, and really we enjoyed it very much. Although it was really virtually, we wish you be in Muscat so we can enjoy the weather now, but COVID didn't allow us to meet. But inshallah, we'll meet soon in other conference physically. And I would like also to thank all who attend the conference, and thank you very much, and bye-bye.
Tremfya is a human immunoglobulin G1 gamma monoclonal antibody that binds selectively to the P19 subunit of IL-23 with high specificity and affinity. IL-23, a regulatory cytokine, affects the differentiation, expansion, and survival of Th17 cells and innate immune cell subsets, which are sources of effector cytokines, including TNF-alpha, IL-17A, IL-17F, and IL-22 that drive inflammatory disease. Tremfya inhibits the bioactivity of IL-23 by blocking its interaction with the cell surface IL-23 receptor, disrupting IL-23-mediated cell signaling and activation, as well as downstream cytokine cascades. This regulates the production of effector cytokines, decreasing lesion levels of IL-17 and TNF-alpha, downregulating T cells, resulting in controlled inflammation. This is how Tremfya exerts its clinical effects in psoriatic arthritis and psoriasis, improving joint and axial symptoms, enthesitis and dactylitis, as well as providing sustained skin clearance. Additionally, the mechanism of action of Tremfya is not expected to block effector cytokine functions and hence decrease the chance of adverse events such as IBD and opportunistic infections. Tremfya is the first and only IL-23 P19 for PSO and PSA. Tremfya acts to restore homeostasis of the immune response and provides control of inflammation and symptom improvement. Tremfya offers an effective treatment across PSA domains, a favorable safety, tolerability profile, and the convenience of infrequent dosing. Inhibition of the master cytokine IL-23 with Tremfya regulates inflammation in PSA and PSO and results in sustained improvement of enthesitis, dactylitis, and joint symptoms versus placebo, so patients can keep moving, combined with proven skin clearance for confidence that keeps going, helping patients to get back to their lives with fewer interruptions, take part in activities with less burden of joint pain and skin manifestations, knowing that their disease is under control, not only their symptoms, giving patients the possibility to go out and seize the day, no matter the weather. This resolution of joint and skin symptoms brings impactful improvements to patients' quality of life. Inhibiting IL-23 with Tremfya helps keep the master cytokine of psoriatic arthritis and psoriasis under effective control for a life that's non-stop.
In the last few decades, there have been major advances in the understanding of the causes and development of spondyloarthropathies. A key element of this has been the recognition that enthesitis may be considered the primary pathological process underlying SPA-associated skeletal inflammation. Previous studies in PSA patients have identified risk factors for developing enthesitis to be high body mass, more active joint